waking up, like doing 72 hours duty continuously. I used to wake up at 2 o'clock, 3 o'clock in Thursday team and used to do all the putty starting from S8 till trauma center, me and Nitin. And even in during the December and January days, we did not used to go to a room and the resident room was too cold to lie down. So I used to sleep in my car. I was having a car. So for one whole month, I used to add a pillow and a blanket in my car, and I used to park it around 1 o'clock or 2 o'clock in the night in a dark spot, and used to sleep and wake up at 4 o'clock and again continue with the dressings. At that time, things seem very overwhelming, very stressful. But now, when I'm here, I think I have survived those days. I have learned something, so I can even survive whatever I'm learning today. Still, I'm in the learning phase. I'm learning the how to manage the patients and everything. So don't get overwhelmed. Sometimes some days are very hard, some days are very normal, very easy. So life is like this. Continue with your pace, continue surviving those things. I think eventually it will help you. And those old memories now, which seem to be very stressful, now they seem very beautiful to me. Thank you so much.
Jyoti, Nasir, you are next. ये लोग सब फ्रेम नहीं कर रहे, they are not framing answers for you. इसीलिए हमने इनको बुलाया, because this is a part of life जो सबने face किया है, and you are also going through the same. But we want you to learn from them and to go for.
So first of all, जब general surgery लेके when you come to the department, the idea is you will be sent to OT for the first day. तुम्हारे हाथ में scalpel दिया जाएगा and you will be see चलो operate करते हैं. But this is not how the reality is. When you come to the department, you see that OT की तो कोई बात ही नहीं करता है तुमसे. Everyone is ये काम करो, अभी round, कभी JR2 round ले रहा है, कभी JR3, SR, consultant rounds, and you have to be there all the time. So the idea of surgery starts getting fading away in your mind and you think that इसलिए आए थे क्या यहाँ पे. But what you realize in later run, जब तुम JR2 बनोगे, JR3 बनोगे, because this is the preparation phase. This is how you are being prepared to stay in OT for long hours. And one thing what I would like to say to you, all of you, is have each other's back. एक गलती के लिए, तुम्हारी गलती के लिए हो सकता है कभी तुम्हारे साथ में जो JR1 होगा उसको डांट पड़ेगी, कभी तुम्हारी गलती के लिए वो डांट खाएगा तो उसकी गलती के लिए तुम भी डांट खाओगे. दिस इज़ हाउ इट इज़. सो नेवर say anything to against each other. So just have each other's back whenever you work as a team. And department को घर बना लो. Because when I came here, first day I was posted in Thursday team, and then 2 दिन बाद change होके emergency posting लग गई थी. So I came, the day I joined I was sent to pre करने के बाद emergency, and I had no idea what is pre, what was emergency, and then again night emergency. So after around 96 hour I was told कि चलो room चले जाओ. एंड रूम जाने के बाद आई गॉट अ कॉल कि एग्ज़ाम्स हैं BDS वालों के, सो यू हैव टू फाइंड द केसेस. सो आई वॉज कॉल्ड बैक एंड आई हैड टू फाइंड ऑल द केसेस इन सर्जिकल ऑन्कोलॉजी एंड एवरीवेयर. एंड देन आई थॉट इन माई माइंड कि मुझे घर जाना ही नहीं है. एंड आई स्टार्टेड स्लीपिंग इन द रेसिडेंट रूम फॉर नेक्स्ट 3 months. I used to go to my room on Sunday only for taking bath and used to come back. So that attitude kind of helped me that I had the least expectation of this place कि कुछ भी हो जाए रहना तो यहीं पे है ना. दैट्स द लीस्ट दे कैन डू कि तुम्हें रूम नहीं जाने देंगे. वॉट दिस इज़ नॉट हैपनिंग राइट नाउ. अभी का सिनेरियो हैज चेंज्ड अ लॉट. So have each other's back and consider this department as your family, as your home, and this will help you a lot in the long run. That's it.
Thank you. तो दो चीज़ें हमेशा ध्यान रखो. हम लोग को लगता है सहना मेरी कमज़ोरी है, बिकॉज वी आर ट्रेडिशनली थॉट लाइक दैट कि तुझे क्या ज़रूरत है, तू क्यों चुप रहती है, तू क्यों नहीं बोलती है, बोलो ना. वी हैव ऑल बीन दैट. बट सहना कमज़ोरी नहीं है. सहना इज़ एक्चुअली अ शक्ति. हाउ मेनी ऑफ अस कैन एक्चुअली टॉलरेट अदर्स? मोस्ट ऑफ अस कैन नॉट. तो सहना इज़ अ शक्ति. कॉपरेशन, हमको लगता है कि अगर मेरे हिसाब से काम नहीं हो रहा है तो मैं कॉपरेट नहीं करूँगा. वी हैव द फ्रीडम टू स्पीक, वी हैव द फ्रीडम टू से वॉट एवर वी वॉन्ट. नो, कॉपरेशन इज़ जब आपसे पूछा जाए कि इसमें क्या करना है तो से लाइक यू आर द बॉस. बट अगर डिसीजन जब लेते हैं वो डिसीजन ना हो जो आपने सजेस्ट किया था तो एक्सेप्ट इट. कभी कभी हम ग्रुप में ये गलती करते हैं, हम बोलते हैं फिर कहते हैं अरे मेरे से पूछा क्यों था जब सुनना ही नहीं था मेरी बात तो. बट when lot of people decide together नहीं ऐसा करना है, तो accept it like a baby. तो moral is say like a boss but accept like a baby. तो अगर आप ये थोड़ी थोड़ी चीज़ों को implement करोगे ना, the life will become much more easier for you, much more easier. And try to find good in everyone. जो भी हमें दिख रहा है, the worst to worst of the person is not bad. They may have some good qualities and they may have some bad qualities. Everyone is a mixture of both. You can't say ये बहुत अच्छा है, ये बहुत बुरा है. Everybody has a combination to both. For you to live a better life, you have to see good in others. It is only then that you would live a better life. और ये जो सब हम कर रहे हैं वो हम दूसरों के लिए नहीं कर रहे हैं. We are doing it only for ourselves, for our inner peace, for our inner stability that should not get disturbed. Now, last, Nasir, please, we'll just, and then we'll finish.
मॉर्निंग. बेसिकली जब हम यहाँ पे आते हैं तो कंफर्ट जोन छोड़ के आते हैं. तो यूजी इज़ जो पीजी है हमारा, दैट इज़ नॉट लाइक यूजी. इंटर्नशिप में या यूजी में हम क्या करते हैं कि अपने मन से सोना होता है, अपने मन से उठना होता है. बट जब पहले हम क्लास 10th या स्कूलिंग कर रहे होते हैं, उस टाइम पे हमें जब 10th में आते हैं तो हमें सब लोग बोलते हैं कि यार बहुत मुश्किल है 10th पास करना. तो बट आपने एफर्ट डाला उतना, तो आपने बहुत अच्छा किया. फिर 12th में कि यार इतना ज़्यादा सिलेबस है, नहीं कर पाएंगे, बहुत मुश्किल है. बट आपने उसमें भी एफर्ट डाला, बट मोर देन जैसे आपने 10th पास किया उससे ज़्यादा ही एफर्ट डाला, तो आपने उसमें भी अच्छा किया. फिर जब आपने पीजी के लिए प्रिपरेशन की तो वो उससे ज़्यादा टफ था. फिर जब आप पीजी में आए हैं तो एक्चुअली जो आप एफर्ट डाले हैं इट इज़ डायरेक्टली प्रोपोर्शनल टू योर आउटपुट. अब आप यहाँ पीजी में आए हैं तो समझिए कि इट इज़ टोटली डिफरेंट फ्रॉम यूजी. आपको काम भी करना है और आपको काम इंटरेस्ट लेके करना है. ऐसा नहीं है कि यार सीनियर ने बोला है तो काम करना है, नहीं. आपको हर डिफ़िकल्ट सिचुएशन में सीखने को मिलेगा, और जितना ज़्यादा आप काम करेंगे, इंटरेस्ट लेके करेंगे, उतना ज़्यादा सीखेंगे. इसको बर्डन नहीं बनाना है. कुछ इशू हो रहा है तो सीनियर से शेयर कर सकते हैं, बिकॉज जिस स्टेज से आप गुजर रहे हैं आपका सीनियर गुजर चुका है वहाँ से, तो उसको पता है कि कैसे मैनेज करना है. तो सर्जरी इज़ डिफरेंट, और जो आप मैनेज कर रहे हो अभी फर्स्ट ईयर की जो चीज़ें हैं या सेकेंड ईयर, दोनों के अलग अलग काम हैं. तो बट ये है एक टीम की तरह काम करना है. ऐसे नहीं कि यार मुझे सारा काम करना पड़ रहा है, ये है, तो वो सब नहीं करना. तो एफर्ट डाल के इंटरेस्ट लेके काम करना है. वक्त गुजर जाता है, हर किसी का बुरा वक्त आता है, बुरे वक्त के बाद एक अच्छा वक्त आता है. बुरा भी नहीं कह सकते. सीखना है, आगे अच्छा करना है, तो अभी एफर्ट डालना बहुत ज़रूरी है. बस यही कहना है. थैंक
And mind it, if you have a good, good impression in the department, the life becomes much more easier when you grow up. And if you start harvesting with a bad impression that you are not working, like this boy is always sleeping, so life becomes difficult for you when you know, grow up as a senior also. तो क्योंकि शुरू में ही सबका डांट सुन सुन के, गाली सुन के, बुरा सुन के आपका कॉन्फिडेंस और मोरल डाउन हो जाता है. और वो मोरल और कॉन्फिडेंस कभी पिकअप नहीं कर पाता, जब तक आप थर्ड ईयर बन जाओ तब भी नहीं पिकअप कर पाता. इसलिए ट्राई वर्क स्लोली. The work may not get complete, that's also okay, because nobody scolds you for not completing the work. Most of the faculty also doesn't scold. But ऐसा नहीं होना चाहिए कि आप काम चोरी करो, भागते रहो, you know, do all this. तो उससे क्या होगा कि आपके सीनियर्स डांटेंगे, फैकल्टी डांटेगी, सब डांटेंगे, and your confidence and morale will go down. So that, let that not be a part of your life. If you have any problem, go and discuss with your seniors, go and discuss with the faculty. And as a senior, I would really suggest you don't get up from the bed, take a shower, or may not take a shower and come to the hospital straight away. Take out at least half an hour for yourself before you come to the hospital. Go sit in the nature for a while, wherever, the park, garden, whatever you like. Maybe it could be your balcony. Sit in the plant, sit in the nature for a while, sit in the sun. Try and think about the day, try and think about yourself. Think about yourself without your phone by your side, which is basically meditation. And do a little exercise, stretching, and then come to the hospital. You will see a hell lot of difference in your energy when you come like this to the hospital, rather than jumping from bed and heading straight to hospital or your work. So with this, I think we should close. Didi, please हम आपको stage पे बुलाते हैं एक बार. I request the third years to please come forward. All the third years. दीदी ने कम से कम थोड़ा बहुत spark तो डाला कि कुछ कुछ change कर लेते हैं. तो we would all like you to felicitate her. सौम्या. ये दीदी को देते हैं. एक फोटोग्राफ ले लो सबका. प्लीज आप आइए. शी इज रिटायर्ड फ्रॉम आर्मी ना. किस पोस्ट से?
Was I got permanent commission in National Cadet Corps. I hope everybody know school colleges में. And I was working as an administrative officer in girls battalion. This cadre, a whole-time lady officer, is meant for girls especially, but now is combined कर दिया है after 2014 से इसे combined all girls and boys together. Thank you very much.
So thank you for sharing your experience with us. And this is a small memento from KGMU. ये मुझे मिलेंगे ही नहीं कभी इसके बाद. सबकी टीम्स अलग हो जाएंगी अब.
check, check. Good morning, everyone. Good morning, respected dignitaries, esteemed faculty members, and dear colleagues and beloved students. On behalf of the Department of General Surgery, I extend a very warm welcome to all of you on the fourth day of 114th Foundation Day of Department of General Surgery. And today's theme is minimal access surgery, urology, and hernia. And starting with the session, I would like to invite Dr. Manish Kumar Agrawal sir for his lecture on open inguinal hernia.
Pointer sir. Start. Good morning, everyone. First of all, I would like to welcome you on the fourth day for this surgical education program, and I would like to thank Professor Abhinav Arun Sonkar sir, HOD and the organizing chairman of this program, and Professor Gitika Nanda ma'am for giving me this opportunity to talk to you on this very relevant topic for resident and general practitioner open inguinal hernia. Not working. Not working. These are my standard disclosure. Most of my cases are the laparoendoscopic, and this presentation is only for the educational purpose. So how we define the hernia? Hernia is the abnormal protrusion of an organ or tissue through the defect through the surrounding wall. This definition is very important for the postgraduate because this is commonly asked in your final year exam. Why we are talking about this topic? As we know that 27 to 43% of the males have the lifetime risk of having the groin hernia, and in female it is 3 to 6%. And most of these hernia are symptomatic, and only cure for this problem is the surgery. However, a small subset of the patients we can if they are asymptomatic small, we can observe then wait and watch technique, but however as per literature 70% of these patients will require the surgery in next 5 years. Worldwide 20 million cases of hernia done annually. So this is the second most common elective surgery worldwide at present, and with all the hernia repair, recurrence is still 10 to 15%, chronic groin pain 10 to 12%, and severe 1 to 3. So you have to see there is just so much of the volume and complication is still at the unacceptable range. So why this is there? If we go and see that how many surgeries are there, you see their long list of surgery and that are asked in the exam, and you get confused which technique in this. Why this is there? Because there is a problem with the outcome. We are not found the ideal solution for this problem. So what is the ideal solution? So the surgery which has a low complication rate. Low complication means low rate of the recurrence, low pain incidence, faster recovery to the patient, cost effective to the patient, and the most important, easy to learn, and if you learn, the results should be reproducible compared to the expert. It does not mean that you learn but you do not reproduce the same result, there is no use of learning that technique. So open hernia, ideally it is classified like this genes, either we do the RAFU or we do the patchwork. So one is the herniorrhaphy, another is the hernioplasty. We have to remember these four gentlemen if you are talking about the open inguinal hernia. First one is the Basniz, who has done the herniorrhaphy and is still the practice at present. Second is the Soldis, again the tissue repair. Third is the Lichtenstein, tension free hernioplasty. And the fourth one is the Dasarda. He is a surgeon from Pune, India, and he has described a flap repair which I will show you later on this presentation. So why the global? If we will see, this is the data. Our institute has also participated in this study, October 2024, from the Lancet publication, British Journal publications. You can see 14,768 cases has been enrolled. 81 countries has participated in this study, and if you will see that 70.7% of the cases in the high income like the US is still being the open inguinal hernia. So this is the data, and we talk about the India like low middle income country, 87.5% and low income 98.9% of hernia still at present in the world is done by the open inguinal technique. So this is the last at what the patient is getting at present in worldwide. While talking about the hernia, we have to think that when we are going, what are the risk factor which have the higher incidence of recurrence, like the female sex, direct inguinal hernia, limited surgical experience, sliding hernia, decreased collagen 1/3 ratio, increased matrix proteinase, obesity, and incorrect technique. So incorrect technique, last one but the important technique, as the majority of the recurrence many times it is there because of the surgical technical error. So when we analyze the hernia, we have two outcome as per the classification. So there you have read, some examiner is asking Gilbert, some Nihas. So all these classification is there. After this, all the hernia society across the globe merge into a single society of hernia search, and they have classified a new classification, European Hernia Society. So I will request all you or resident that when you are classifying or writing the diagnosis, write this in the format, because this is very important, because this will give us the assess that how much is the recurrence pain as per the standard classification, that what is the stage of the hernia, so that we can classify that. For learning the hernia, the most important open hernia we have to learn for the anatomy. So anterior superficial spine, pubic tubercle, inguinal ligament, ligament of Cooper, that are the standard. The most important thing, all these hernia are through the groin hernia are through the myopectineal orifice. It was classified by Henry Frouchard. Can anyone tell me the boundary? Anyone? Boundary of, want to try? Okay, leave it. Superiorly it is the conjoint tendon, inferiorly Cooper's ligament, medially it is the rectus abdominis, and laterally it is the iliopsoas. So this is the boundary of the myopectineal orifice, and we have to cover this orifice sufficiently 4 to 5 centimeter all around at, so that even after the mesh shrinkage there is no weakness at this level. So this is from the inside. Avnish sir will take care of this anatomy because he is going, I will not go into this. And second is the Hasselbeck triangle. So from here the direct inguinal hernia happens. Boundary is laterally by the inferior epigastric, medially by the rectus abdominis, and inferiorly by the inguinal ligament. And these are the nerves. So we have to take care, because neuralgia, pain, you have seen two complications. One is the recurrence, another is the pain. So recurrence is, you have to know about the anatomy, myopectineal orifice, and pain you have to be mindful of the nerve. So three nerves are there: ilioinguinal, genital branch of the genitofemoral nerve, and iliohypogastric. So you have to be take care of that. So I am not going into the detail of the investigations. You know that if it is a clinical diagnosis, if any suspicion is there, then you can ultrasound. Still occult hernia, then you have to add on the MRI. Now, according to the presentation, when the patient is presenting with the strangulated, obviously you have to do the emergency, otherwise you have to optimize and then perform the elective surgery. I am not going into the detail. So why in the open Lichtenstein is the preferred surgery? Why this is preferred surgery? It is the most commonly used and best evaluated, short learning curve, reproducible, less complicated anatomy, so easy to learn, can be done in the local anesthesia. So at the district level, PSC level, or even at a low setting, this surgery can be performed. No major complications, so do not require the post-operative observation, cost effective, and still with all these advantage, recurrence rate are comparable to the other standard surgical technique, less than 2% overall. Before taking the surgery, we have to again optimize the patient for the modifiable risk factor. Few factors are unmodifiable, you can't treat that, but few factor you can optimize. So optimize the patient before taking for the surgery, like the chronic constipation, cough, prostatism, nicotine, and if the patient is on the antiplatelet, then you have to modify the drug. Anesthesia, this surgery can be done under the local anesthesia, regional anesthesia, or general. Local in the indicated patient, otherwise general or the regional anesthesia can be taken. So why we are talking about the Lichtenstein? First paper, this is the copy of the first paper, it is not available on the internet as such. So this is the first manuscript that is came with the Lichtenstein in 1984. So he termed this paper as the tension-free hernioplasty. Tension-free hernioplasty. Why the tension free? Because previous all the repair what happened, basting each other, we pull the muscle and try to attach, so the layer are in the tension. Here the concept that you have to place the mesh in between that, so that it will be in the tension free. Second landmark paper came from Professor Hamid. So Parvez Hamid is the second in command after the Lichtenstein in the California, Lichtenstein Hernia Center. What they did, they have followed the 4,000 patient done from 1984 to 1981, and they have kept the operative notes of all those 4,000 cases. Out of these, 4 cases has the recurrence, and they evaluated those 4 cases of recurrence with the operative notes and found that common causes of these recurrence are the medial side and the short size of the mesh. So they have modified the procedure. So this is the landmark paper that came into the 1995 after the 4,000 cases and they have found the 11-year follow-up and they found the 4 recurrence. So you have to think that how meticulous the team was. They are seeing each and every cases, 4,000 cases, all operative records over 11 years, and they then re-evaluated the cases and found the recurrences, and they went into again into the operative detail and modified. So what was, so Professor Hamid has suggested the modification in the original Lichtenstein that was described in 1984. So it is from the paper from Professor Hamid in 1995. So what are the techniques? So techniques are the local infiltration technique. After the incision, they again infiltrate a local anesthesia. So patient will be pain free. So surgery during the surgery, it will be the comfortable for the patient and the surgeon also. Elevation of the cord 2 centimeter over the pubic symphysis. Previous Lichtenstein, they are not elevating the cord over the pubic symphysis. That's why the medial recurrence was the most common. 3 out of 4 has the medial recurrence. Preserve the cremastic muscles. Previously, they used to remove the cremastic. In the modification, Hamid modification, they started preserving the cremastic muscle. Sac inversion rather than cutting the sac. Mesh overlap. Previously, the mesh size was 5 to 10 centimeter. Here it is increased to 7 to 15. Length was increased so that we have the 2 to 3 centimeter of the medial and again the lateral. So that if the with the time mesh shrinkage is there, again there is a less chances of recurrence. So these are the important modification by the. Now I just show you the important steps. This is the head end of the surgery, head of the patient. First thing that we have to identify is the pubic tubercle. So identify the pubic tubercle, mark it. After that, you have to identify the anterior superior iliac spine. Mark it. Draw the line from the anterior superior iliac spine to pubic tubercle, and ½ inch to 1 inch above that you have to draw a line. That is our incision line. The length of this line will be the 6 centimeter, and you have to take the incision. After the incision, the first layer that you are cutting is the skin. After the skin, second is the subcutaneous tissue. So you have divided the subcutaneous tissue. After that, you will reach into the superficial fascia. So this is the superficial fascia. Campers and then the scarpa. As soon as you divide the scarpa fascia, you are seeing the white glistening structure, that is the external oblique aponeurosis. So when you have identified the external oblique aponeurosis at the deep ring, you have to just give a nick with the blade, and then you have to lift this external oblique, and you have to run the seizure below, because many times ilioinguinal nerve branches are there adhered here. So you have to make it down, and then you have to incise the external oblique aponeurosis. And while dividing the external oblique towards the medial end, we have to take care that we have to open the superficial ring. Many times we do not open the superficial ring, that is why we get the problem dissecting the spermatic cord of the inguinal canal. So we have divided this. After this, we can identify the two nerves, ilioinguinal and iliohypogastric nerve. So these are the ilioinguinal and iliohypogastric nerves. After the identification, because if you will be mindful of the nerve, chances of the nerve injury will be less. So after the identification, you have to again mobilize the cremasteric. So the mobilization of the spermatic cord is best done at the level of the pubic tubercle, because below is the pubic tubercle, no vessels. This is a avascular pain. So you have to mobilize the spermatic cord at the medial end, and with the sharp dissection only, without using the finger, you can elevate the spermatic cord. That is the beauty. So medial side it is attached. You can do the you can cut with the fine dissection, and then you just elevate the spermatic cord at the pubic tubercle over at the medial end over the pubic tubercle. So this is how we have lifted. Now we have to complete the dissection up to the deep ring. So how we will confirm that we have reached the deep ring is by identification of the inferior gastric artery and the vein at the medial end. That is very important. So as soon as you identify the inferior epigastric artery and the vein, your dissection, posterior dissection is complete here. So after that we have to do the dissection of the cremasteric. So this again many people do here the blunt dissection, but you can do the dissection fine, and always you have to be mindful of these three nerves. So if you will be mindful during these nerves during the dissection, chances of groin pain later on with the patient are very less. So this is the fine way you are opening here the layer external spermatic fascia, then the cremasteric muscle and the internal spermatic fascia. As soon as you divide, what you identify is the sac. So this is the sac you have identified. By the sharp dissection only you can do all these dissection. If you do the by the sharp dissection, less tissue trauma, early recovery, all will be possible. So after dissecting the sac, you will invert, and then you measure the distance between the pubic tubercle to the deep ring. Here it is 7.5 centimeter. You need the 3 centimeter medial and 4 centimeter lateral. According to that, you can cut the mesh, place the mesh, 3 centimeter overlap. First suture will be at the level of the pubic tubercle, but not with the bone. Otherwise, the patient will have the pain, and you then have to fix the lower part of the mesh with the incurved part of the inguinal ligament. And one more important thing is that beyond the ring, you have to take the lower part of upper leaf of the mesh and the lower part of the lower leaf of the mesh with the incurved part of the inguinal ligament. This is very important. And then you will just take the two gentle sutures, loose suture at the upper end, because there may be the nerve, so it may be the chances of entrapment is there. And after that, you can close the external oblique aponeurosis with the PDS and the superficial fascia. So this is about the lichen-stein, open lichen-stein repair that should be done how. Now coming to the Dasarda, here the up to the external oblique the technique is same, we are not going to modify anything. So I have skipped that part. Here the incision, first incision when we are giving at the level of the external oblique, we have to be mindful that we have to give at the lower border compared to the mid level that we give for the lichen-stein, lower level. We have to give that at the lower level. So first thing that you have to do is to give the incision at the slightly lower to the spermatic cord. So after this you will elevate the upper leaf and the lower leaf. Now the after dissection of the cord structure, the upper part of the external oblique, upper leaf of the external oblique will be sutured with the incurved part of the external oblique. So this is upper part of the leaf is sutured with the incurved part of the inguinal ligament. Understood? After that you will give second incision at the level of conjoint tendon. So this part of the, this will be act as the strip of the external oblique. So at the level of conjoint tendon. So this leaf, lower part of the this leaf will now get sutured with the conjoint tendon. Okay. So first incision at the lower border, you sutured with the incurved part of the inguinal ligament, and then every 2 or 2.5 centimeter you give another incision, and this then you will suture this flap with the conjoint tendon, and then again you will suture the upper and lower leaf of external oblique. So this is for the Dasarda technique. What are the precautions that we have to take? Elevation of the cord at the medial end, preservation of the cremasteric muscles, you have to identify the nerves so that there is a less risk of the nerves injury. Okay, thank you. बजा लो, बजा लो. Thank you.
Thank you, sir, for the very practical and enlightening talk. May I request Professor Avnish, sir, to kindly felicitate Dr. Manish Agrawal, sir? Continuing with the session, it's my pleasure to invite Professor Avnish Kumar, sir, who will be presenting on laparoscopic hernia anatomy and TAPP.
हो रहा है? नहीं आया यार. इधर देखो कुछ हो रहा है क्या? इसमें हो गए नहीं, इसी से करने को. कुछ लिख रहा है ना. नहीं हो रहा. ओके. Very good morning to everyone. As we have seen, the management of for inguinal hernia. Still, if you say inguinal hernia surgery is most commonly performed surgery after laparoscopic cholecystectomy for gallstones. But see, the most common surgery to be performed in inguinal hernia surgery, as you have heard just now, it is open repair in the form of Lichtenstein tensionless repair. Understand? But with the advent of laparoscopy or minimally invasive surgery, it is gaining its acceptance because of its overall lesser invasiveness in the form of lesser chance of ASI, surgical site infection, lesser pain. These are two important advantages. Of course, earlier return to the work. Of course, there are certain demerits for the laparoscopic repair in the form of, like, it always requires most of the time general anesthesia, and it is bit costlier. It is a bit costlier if you are not very much expert. If you are expert, it is not costlier so far. Okay. And see, all these are options for the hernia surgeries. Of course, there are lot of options. Just now, Lichtenstein tensionless repair, Besney's repair, McVeigh repair, Stoppage repair, and Soldis repair. Of course, in laparoscopic surgery, we have TAPP, transabdominal preperitoneal, totally extraperitoneal, and nowadays we are going towards the ETAP, enhanced view totally extraperitoneal. Of course, now we have started recently robot assisted transabdominal preperitoneal. We can go for ETAP also in some situations. Even IPOM can be done. IPOM is not the only surgery to be performed in case of ventral hernia, but of course, there are lot of recurrence anterior posterior, you do not have any planes, you can apply composite mesh in the form of IPOM, but that is rarely required. See, then that means there are lot of options available for the laparoscopic repair, TAPP, TEP and ETEP. I am not going to cover TEP. They have got advantages in the form of their own demerits or merits. TAPP has got wider space, but of course, since you enter into the peritoneal cavity, it has all complications which you enter with the peritoneal cavity, like there is a minimal chance of visceral injuries, but of course, this is a very less. and the choice depends on actually expertise of the surgeon, liking of the surgeon. It's not, because it has almost similar outcome in the form of recurrence, pain, surgical site infection, whatever it is. Every procedure has got the similar outcome. It is the preference of the surgeon which one opts for. Okay? And then how management of hernia depends, it depends on many things. One is the infrastructure where surgeon is operating, other one is hernia characteristics, and other one is patient characteristics. It is not the only single treatment which you offer to everyone. Okay? This you have to understand actually. It's not like that every hernia is going and you have to perform, like you have to perform TEP or ETP, whatever it is. It is actually the type of hernia, surgeon's expertise, that is all. And of course, one word about this classification. No, sorry. Yeah, this classification. You have just heard so many names of the classification, Nahias classification, Gilbert classification. The most accepted and easy one is European hernia surgery system classification. What is the importance of these classifications? Whatever classification we learn, direct, indirect, extend, complete, incomplete, this classification is actually working classification. What we surgeon are most of the time concerned. Understand whether the patient is having direct hernia or indirect hernia, whether it is a primary or recurrent, whether it is femoral hernia, so that we know actually which type of hernia I am going to deal with actually. Otherwise, hernia may be missed. If you don't know preoperatively, hernia may be missed. This is actually working classification. Understand? And we have to follow this simple one: primary or recurrent, femoral, or it size also is into the consideration. Size is L1, L2, L3. L1 is less than 1.5 centimeter, L2 is 1.5 to 3 centimeter, L3 is more than not 3, 3 is more than 3 centimeter. What is the importance of this size? If you have larger hernia more than 3 centimeters, at times you may need fixation of the mesh and defect closure as well. Otherwise, we usually don't fix the mesh, we do not need that defect closure, all these things. But don't confuse with this terminology with ventral hernia. Ventral hernia is entirely different ball game. Understand? So that you have to understand. And then of course, there is a learning curve for everything. Likewise, here also previously it was very high learning curve, but of course, it has reduced. Everywhere we teach hernia, we operate hernia. That is why residents are more exposed to this hernia surgery nowadays for minimal invasive. The learning curve almost has decreased about 20 to 25 cases. Previously, it was supposed to be 100 cases or 49 like that, but now it has decreased. Of course, hernia indications. What are actual indications for laparoscopic inguinal hernia is, one is bilateral inguinal hernia, recurrence after anterior approach, other one is inguinal hernia in females. Inguinal hernia is females. We want to go by laparoscopic route because they have the chances of missed femoral hernia. By this technique, actually we always look that area also. That is why whenever patient is having, female patient is having hernia in the form of inguinal or femoral, it has to be dealt with the laparoscopic route. Of course, if someone is very much expert, even male unilateral hernia can be dealt with the laparoscopic route, but of course, if it is unilateral, we should go by not laparoscopically by open, but my contention is, if you don't learn how to operate inguinal hernia on unilateral side, how will learn to operate on the bilateral side or recurrent hernia. That is why I always say, do it by lab, do it by lab, do it by lab. And then of course, I am not going into details of this. The only important thing is, what kind of mesh has to be used for this kind of surgery. See, in laparoscopic hernia repair, mesh is must. Why this is must? Because when we raise the flap, there is always some kind of disruption of transversalis fascia, which is one of the toughest layer which provides strength to the anterior abdominal wall. That is why we have to use the mesh. Understand? So, what kind of mesh? It must be, good morning sir, what kind of mesh? It should be polypropylene mesh of lightweight, large pore, usually of size 15 into 12 centimeter. 15 into 12 centimeters. It has been seen that if you apply this kind of meshes, the chances of recurrence is less. And then I told you all these things, these are the detailed things, and these are the port placement for the different surgeries. Since I am concerned with the TAPP, so TAPP what involves actually is one of the port 10 mm usually either at the level of umbilicus or 4 centimeter above the level of umbilicus, this is camera port, 2 of the ports on the lateral aspect of this umbilical port. This is a 3 port surgery actually. In TAP, Dr. Ajay will tell what are the different ports placement, there is kind of some difference, otherwise TAPP is usually standard one, this one. And of course, I am not going for the management of inguinal hernia. Of course, Dr. Manish just told you, if it is emergency setting, of course, repair has to be performed. If it is elective setting, mesh after 18 years of this patient. If some patient is after 18 years, of course, mesh. Nothing short of that. Some people are saying if it is 18 to 25, there is some problem. There is some consensus whether you can be RAFI or mesh. Of course, for you people, for me also, if patient is of 18 years age, use mesh, whether it is indirect hernia or direct hernia, that you have to. If there is unilateral hernia, I told you if it is unilateral, then of course you have option of Lycasin or lap. If it is a bilateral, of course lap. If it is a recurrence after anterior approach, it is lap. If it is a recurrence after lap, then anterior approach, that you have to remember. Understand? Why the stars are there? Nowadays, even in unilateral hernia, lap is preferred. Lap is preferred if the expertise is available. See the anatomy of the inguinal hernia, what is that? See what were we were taught, actually you have to just forget everything now, as of now. What we were taught? Anteriorly it is bound by external oblique, posteriorly it is by the transversalis fascia conjoint tendon, roof is formed by the arching fibers of the internal oblique transversus abdominis, and floor is formed by the shelving edge of the inguinal ligament. This was the boundary which was usually taught, but you do not remember it, all these things. What you remember by this figure is, see this is, sorry, kya ho raha hai? What you have to remember this year is, only 2 things you have to remember. Inferior epigastric के medial जो hernia होता है, that is direct hernia. Inferior epigastric के lateral जो hernia होता है वो क्या होता है? Indirect. This is the one point which you have to remember by this figure. Another one is inguinal ligament is also known as iliopubic tract. Inguinal ligament is also known as iliopubic tract. Why it is like that? Since it arises from ASIS, which is a part of ilium bone, and it attaches to the pubic bone, that is pubic symphysis or near to the pubic bone. So that is why it is also known as iliopubic tract. This knowledge will be utilized for understanding the endoscopic anatomy. Do not remember all those boundaries which I have just told you. What you have to remember is inferior epigastric के medial जो भी hernia होता है वो direct hernia होता है. Inferior epigastric के lateral जो hernia होता है वो direct. Another point is this iliopubic tract or inguinal ligament divides this myopectineal orifice into upper part and lower part. The upper part forms the site for the inguinal hernia, either direct or indirect. Lower part forms the site for the femoral hernia. If you still go lower down in the pelvis, there are obturator nerves, that is the site for the obturator hernia. So these are the 4 hernia which are dealt in a single attempt by doing endoscopic repair for the inguinal hernia. Anatomy you have to understand. And see, there are rules of 3, if you can remember. Once you enter into the peritoneal cavity, you encounter 3 ligaments, that is these 3 ligaments. What are those? The most prominent one which you say is the medial umbilical, in midline it is a median umbilical, and the impression which is given by that inferior epigastric is known as lateral umbilical fold. Got it? So that means if you enter into the peritoneal cavity, the most prominent is medial umbilical ligament. And what is the importance of this medial umbilical ligament? Between these 2 medial umbilical ligament lies the bladder. So whatever incision you have to give on the lateral aspect, you have to limit here only. Otherwise, you will be cutting sometimes bladder if you have not deflated it properly before the procedure. Understand? So, you have to limit your dissection incision up to the medial umbilical ligament. This is the importance of identification of this anatomy. And once you enter it, this is a very good figure. If you know, this is from inside actually. We have entered into the periperitoneal cavity either by TEP or TAPP, we will come to later. And then see, you have to imagine this anatomy. I told you first you have to visualize the inferior epigastric vessel. The area periperitoneal space in medial to inferior epigastric vessel is known as space of Ridges. This is a periperitoneal. Lateral, it is known as space of Bogros. And then this is white line, this is known as iliopubic tract. Above to this is the site, medial side is for the medial hernia, that is mean direct hernia. Lateral it is indirect hernia. Below it is medial to femoral vein or external iliac vein is the site for the femoral hernia. If you still go here, this is the obturator now, this is sometimes site for the obturator hernia. This is what we have to exactly visualize, we have to actually imagine when we enter into the peritoneal cavity. And of course, on the lateral aspect, there are few nerves. What are those? In open surgery, iliohypogastric, ilioinguinal and genital branch of genitofemoral. In lap surgery, most lateral is lateral cutaneous of thigh, and then femoral branch of lateral femoral branch of genitofemoral nerve, and then femoral nerve. And then these are three nerves. What is the importance of this? We do not fix mates at any point of time here, because patient will have chronic pain. That is why whatever the tacking or fixation has to be done above this iliopubic tract. This is the importance of knowing this anatomy. Understand? And of course, there are few spaces which we have to take into consideration. I told you space of Bogros, space of Ridges, and the area in front of the bladder is prevesical space. Then there are few triangles, zones also. These are funny names, but you have to all those remember what are those zones. Medial zone is known as zone 2, lateral zone is known as zone 1, and then here it is zone 3, which contains the external iliac vessels. And then of course, these are few of the triangles, triangle of doom, triangle of pain, nothing but you must be knowing all these things. Triangle of doom, medially it is vas, laterally it is other cord structure other than the vas, and inferior it is the peritoneal fold. Triangle of pain is iliopubic tract here, and medial boundary is one lateral cord structures, and the again peritoneal fold. So, these are some of the imaginary triangles. If you, why do we want to know? Because once you reach in this particular area, we want to focus. These are the triangles we have just dissected it or not. And then of course, time है कि खत्म हो गया, वीडियो दिखा दें सीधे. See, there are, how then do we TAPP? TAP, there are 10 commandments. One, once you enter into the periperitoneal cavity, decide to see what are those landmarks, medial umbilical, median umbilical, lateral umbilical fold. Then of course, you give incision. I told you after you have to limit your incision to the medial umbilical ligament, and then of course, once you give the incision, you raise the preperitoneal flap. And then the one dictum is, once you are raising the preperitoneal flap, fat should belong to the anterior abdominal wall, then you remain to the preperitoneal area actually, otherwise you get lost sometimes. And then second point is, you go to the some zones, zone 1, zone 2, like that, zone 3. The zone 3 is last to be attempted, zone 2 or zone 1, it is the preference of surgeon from where he starts the dissection, Medially, it is my preference, you have to go medial zone, that is zone 2, because there is a pubic tubercle, pubic bone, which is a consistent landmark, you are going to 100% get that. No hernia can displace that. Understand? So, you have to just go to zone 2 first instead of zone 1, if you are very good. And then of course, the next one is still dissect 2 centimeter below to that pubic symphysis or pubic tubercle, whatever Cooper's ligament you get there, and then you at that time only you see the femoral vein for any femoral hernia, and then of course, if hernia is not reduced, it is indirect hernia, you deal with the sac which is going through the deep ring, you then cut it, if it is not reducible properly, and then you peritalize it. Peritalization means you strip off 5 centimeter peritoneum from the deep ring away from the cord. And then of course, if there is lipoma of the cord, you have to just dissect it, take it out, otherwise patient will have some pseudo hernia kind of feeling if it is left there. So, lipoma has to be dissected. Eighth one is, after you have dissected everything, you want to know whether I have dissected adequately or not. That means space has to be there proper. You have to cross medially 2 centimeter beyond midline. You have to visualize whether I am able to see psoas or not, so posterolaterally, anteriorly medial to ASI or not, so that adequate size of mesh can be applied there. And of course, you try to apply adequate size of mesh, which I told you just now, 15 into 12 centimeter. If it is direct hernia more than 3 centimeter of defect, of course, you try to fix it the mesh, otherwise no need of fixation of the mesh. You properly unfold the mesh in the preperitoneal space and come out and close the side. Understand? Whatever button holes are there, actually you have to close it, because there is chance their bowel might get adhered to that mesh through these holes. So, every hole has to be and then I told you a lot of indications. So, this is one video, this is small video, I will run through it, do not worry. So, we have entered into that one. This was a case of bilateral inguinal hernia. This was irreducible one. Okay. We are going to dissect all those areas, and then we are just entering the lateral space here. We have just done the hernia, reduce the hernia, and then we are peritalizing it actually. After peritalization, we will prepare the mesh. After preparing the mesh, we will introduce the mesh through the 10 mm port, and then of course, we fix it, because it was bilateral, one side it was direct hernia, other one side it was indirect hernia, and then we fix it and close the peritoneal flap. And if there is a bilateral, we will repeat the same step to other side also. And this is a V-lock suture, which is now being used. Previously, it was not V-locked. It can be used Prolene, chromic catgut or Bicycle, whatever it is. And this was the opposite side also. Same procedure was repeated. Okay, thank you.
Thank you, sir, for this excellent academic session. Now I would request Professor H.S. Pahwa, sir, to kindly felicitate Professor Avnish Kumar, sir. Now I would request Dr. Ajay Kumar Pal, sir, to give his talk on TEP hernia repair.
Good morning, everyone. So my topic is inguinal hernia by TEP repair. TEP is basically totally extraperitoneal repair. So as sir was telling about, both have made my presentation very easy. So we are going to go into the extraperitoneal space without entering the peritoneal cavity. So let us see how it goes. So you know that it's the most commonly performed surgery. Endoscopic repair is now more common because of lesser pain, earlier return to work, and less chances of surgical site infections. So whatever key questions remain in TEP, how we confirm that we are not entering into the peritoneal cavity, when is the need, then the conversion from TEP or TAPP is required, or TEP to an open approach is required, in which scenarios TEP is relatively contraindicated, and how we modify our technique of TEP in cases of bilateral repairs. So initially TEP was described by Fazli and McKernan. With the increasing experience, the classical indication and applications have encompassed even some cases of incarcerated hernias and large hernias also, especially with the advent of extended view TEP. So we, sir, already discussed about rule of 3. I'm not going to go into details, but the important point here is knowing about the vascular anatomy, because since a totally extraperitoneal repair is a limited space surgery as compared to a TAP one, the vascular injuries are relatively common and have been reported more as compared to TAPP, and especially in relation to the corona mortis and inferior epigastric artery injuries. So what is corona mortis? Corona mortis is basically communication between the internal iliac and the external iliac arterial system. It is basically the pubic branch of the obturator artery which communicates with the pubic branch of the inferior epigastric artery. So that is an arterial corona mortis. Similarly, there is a venous corona mortis also. So both the corona mortis are responsible for during catastrophic injuries during a performance of any inguinal hernia repair. So you need to know this anatomy. So there have been reported cases of injuries to this corona mortis. You can see on the right side there is an arterial corona mortis here, this one. So this is very commonly, because this is also responsible when you are placing a tack, because the fixation is usually not indicated in TEP, but when there is a hernia which is of a larger size, especially the M3 ones, the current guidelines say that it has to be fixed at least 2 or 3 points, one of which is in Cooper's ligament. So these are the zones that sir already discussed, and the current guidelines say that the inverted Y and the zone dissection is very important to correctly identify that your dissection has been completed before placing a mesh. We discussed about the indications of TEP. It is basically the role is common in if there is a recurrence of a anterior approach, then you go for a posterior hernia repair, which is TEP or TAPP. Sometimes bilateral hernia has especially triangular approach to TEP. In females, this TEP hernia approach is done. In obese patients, it's relatively difficult because of excessive torquing of the fat present, but still it can be done. So the contraindications remain if the patient has undergone a preperitoneal surgery already, prostate hernia or a vascular surgery, then or a prior laparotomy, ascites, these remains the relative contraindications. Learning curve, we discussed that 25 cases are at present the learning curve of TEP, and they have been ever decreasing because of the advent of laparoscopy. With regards to antimicrobial prophylaxis, not routinely recommended, but in the patient who have a higher risk of surgical site infection, in those cases sometimes antibiotic prophylaxis is used. But also to remember is urinary catheter is usually also not recommended, but the patients who have a giant hernias, since the TEP requires more dissection in limited space in the prevesical space, there is an increased incidence of post-operative urinary retention. So that's why the urinary catheter may be required in such cases. Mesh is mandatory, and with regards to comparison between TAPP and TEP, there is no clear superiority as of now. So that the randomized trials and systematic review has told there is no clear superiority of TEP over TEP or TAPP over TEP, but there is a higher chances of conversion to another method in TEP, with respect that TEP can be converted into TAPP or an open approach. So depending on the surgeon preference, the port placement in TEP is either a triangular technique or classical, the midline approach, in which three of the ports are placed in the midline, one in the infraumbilical region, one in the suprapubic region, and one in between these two. In the triangular port, this infraumbilical, and on the side of the hernia it is lateral to the inferior epigastric artery and middle to the inferior epigastric artery on the contralateral side. Another difference between TAPP is the initial dissection. Initially when the TP was started, was done by the approach of balloon, taking the help of balloon which was attached to the trocar, you can see here, and this balloon was inserted under direct vision inside and then inflated, and it leads to non-visualized dissection of the extraperitoneal space. But since the optical trocar come into place and there is current reports of telescopic dissection, so the telescopic dissection has taken place more commonly because of less cost and under view dissection. So this is how it is actually done. This is basically the video of ETP. It is similar to the TEP, but only in the supraumbilical region or infraumbilical region. So if above 4 centimeter above the supraumbilical region we are doing dissection, it is called as ETP, which is extended view TEP. After entering into the preperitoneal space, vertically you place your trocar, you start insufflation and you insert the scope, which scope is 0 degree, and then turn it at the angle of 90 degrees towards pubic symphysis, and straight away you can see the very well visualized layer of fascia transversalis in the preperitoneal and pre-PRS space. So at present we are in the pre-PRS space, but as soon as we go below the arcuate line, we enter into the preperitoneal space. So there are studies which compare optical trocar versus balloon dissection, telescopic dissection versus balloon dissection. All of them have not found any particular significant difference between them, but remember the optical trocar has got the less intraoperative time as compared to a balloon dissection, as compared to a telescopic dissection, but balloon trocar has the least time. Zonal dissection, the difference here is zone 2 dissection is done before commencing upon to the zone 1 dissection. Why so? Because in the central part you are entering into the straight away going towards the space of Ritzius. So that is basically zone 2. So that's why it is done. Another thing important between classification of zones is zone 1 is least chance of having morbidity or mortality. Zone 2 is relatively higher as compared to zone 1, and zone 3 has the highest risk of catastrophic injuries. So that's why their zones are ever increasing in severity also. Another concept that came into place is the critical view of myopectineal orifice. It is similar to the critical view of safety. It has been done by the pioneer of extraperitoneal repair, George Dice and Felix, and this states that the myopectineal orifice should be carefully dissected without injuring any vessels or nerves, and this dissection is very important because only then you have to apply the mesh, otherwise there is a chance of recurrence. So you can see on the right side, this is the myopectineal orifice that has to be dissected. This is similar to the 5 triangle and the inverted Y approach. So sir already discussed about these commandments. They remain the same in TAPP and TEP. Only thing that differs is the presence of large inguinal scrotal hernias. So when dealing with the large inguinal scrotal hernias, either the performance of ETP as a modification to TEP is required, or performance of TAPP, but some studies are there that have done TAPP in large inguinal scrotal and hernias and irreducible hernias also. Paratalization of the cord is basically required, but remember that you need not to devascularize the vas also, because if there is too much handling of the vas, there is a chances of vascularity that you don't want to do in the post-operative phase. And also the nerves should not be divided of the fascia, that there is a facial covering which is a deviation of fascia transversalis. It should remain of the ilios vas, it should remain over the ilios vas. They should not be divided, whether you want to see visualize the nerves or not. So these are your boundaries of dissection: superiorly 4 cm above the deep inguinal line, medially pubic symphysis, inferiorly below the pubic 2 cm below the pubis, and laterally anterior superior iliac crest, and inferiorly it is ilios vas muscle. And the large mesh that is required is in the range of 15 by 13 centimeter, or at least 10 centimeter, and it should cover the MPO, which we already discussed, and all the 5 triangles are covered. Fixation is not necessary in TEP, barring in M3 cases according to HS classification. And this is the deflation. Deflation seen in TAPP is different from the TEP one. In TEP one, you take hold of the one of the edge of the mesh and then start deflating, because it's an extra peritoneal space. You want the mesh to be remain in place. So these are the 7 steps we already discussed about. So identifying the pubic symphysis, dissecting the Cooper's ligament, sweeping the pre-vesical plane 2 centimeter below the pubic tubercle. The direct space, which is the Hasselbeck triangle, is divided. You visualize the inferior epigastric artery, you visualize the femoral space also, and remove the fat if it is there. And inferior epigastric vessels are identified and elevated superiorly. It should not come down. And then laterally the space of Bogros is also developed. And later on you separate the sac from the cord structures, which is the zone 3 dissection. And to remember, you want to look for cord lipomas, but cord lipomas are not necessarily removed always. As per the current guidelines, if you are too much dissecting the cord lipomas, there is an increased chance of cord edema, cord hematomas, and seromas. So the reduction is accomplished by dissecting posterior medially, and sac is held superior laterally. So you are using a polypropylene mesh which has a shrinkage rate of 20%. So that's why the size of the mesh is very important. It should be in the range of 15 to 13 centimeter as per current guidelines. We have already shown you the initial dissection. So this is the lighthouse sign, visualization of the Cooper ligament. Then we go for a medial dissection, which is zone 2 dissection, and separation of the zone 3 dissection is done at the last, which is separation of sac from the cord structures. Then you want to ligate the sac and division of the, and then you paratalize the cord, which is basically crossing of the pars medially. Similarly, you have to remember that in some conditions, especially the patient who have a very thick panniculus, in those patients the table can be because it requires a flexion of the operating table, because you want to increase the distance between the umbilicus and the pubic symphysis. And sometimes there is in TEP, if you find incarcerated hernias or in ATEP, there you require a release incision, which is a concept given by Faisal G. And the releasing incision in cases of all these type of hernias is towards the medial side. In direct hernias, it's quite easy to do relaxing incision, but in direct hernias, when the incision is given, there is a chance of injuring inferior epigastric artery or a branch of the inferior epigastric artery. Then you need to divide it before incising the ring. And femoral hernias, similarly, the incisions are given. There are certain variations of the arcuate line or transversalis fascia. We are not going into go detail, but they are sometimes visualized during the dissection in TEP. But you need to remember, if you are in the correct plane, you will be able to dissect and reach to the Cooper's ligament and see the White House. That is our target. So similarly, ETP is also done. The only thing that is different is basically the port, which is initial port or initial camera access, which is given in extended view TEP, is in the PRS plane, and it is about 4 centimeter above the umbilicus, and the lateral border, it is medial to the lateral border of rectus abdominis. So there are various port techniques for unilateral or bilateral ETP. We are not going to go into details, but the dissection of triangular ETP or a unilateral ETP, essentially the plane remains the same as of TEP. With regards to complications, you should all be aware that the complications of the surgery are there. Serious events in the form of vascular injuries or other injuries, especially the chronic pain or recurrence of hernia, are there, but in comparison to TEP or TAPP, as per the systematic review published in Cochrane, they are not so significant, but they are there. So you need to be aware of the anatomy and correct dissection planes. Especially with the respect to the vascular injuries, more vascular injuries have been reported in TEP as compared to TAPP, but more visceral injuries are reported in TEP as compared to TEP. Quality of life is also remaining the same. Hematoma and seroma are common complaints. Seroma specifically, it ranges in the 20 to 30% of the patient, but there is no as such further treatment required for so. But hematoma, definitely you have to observe it, and sometimes you have to, if it there is a chance of infection, you have to release. So in conclusion, the mastery of anatomy, your modus operandi and meticulous dissection are the 3M required for the correct performance of the surgical procedure TEP, and there is a learning curve, but it is reproducible safely, efficiently, and with good outcomes. Thank you.
Thank you, sir, for this very informative lecture. Now, I would like to request Professor Geetika ma'am to kindly felicitate Dr. Ajay Parkar. Geetika ma'am. We are honored to have with us a distinguished surgeon and a teacher who has significantly contributed to the surgical training and patient care. Now, I would like to request Professor Rajendra Prasad sir to give his talk on the topic GERD and fundoplication.
First of all, my thanks to Dr. Sonkar and Dr. Geetika and the rest of the team for asking me to come and speak to you here. So the task given to me is GRD and fundoplication. That is the title of the talk. So at the outset, I would like to say that okay. At the outset, I would like to say that GERD, gastroesophageal reflux disease, is a very complex problem. There are almost 50 phenotypes if you look at the manometric and physiological studies of GERD, and not all of them are not all of them respond well to surgery. So you have to be very, very careful in picking your patient for surgery, because you are all surgeons. So effectively, you will be given a lot of referrals for doing these cases. So you should be very, very careful in selecting your patients, otherwise you can land up in trouble. So what is gastroesophageal reflux disease? Everybody has some degree of reflux, right? All of us have some or the other reflux at some time. But how it has been defined is, it's the reflux of gastric contents causing troublesome symptoms or complications. Then only you call it a gastroesophageal reflux disease. Otherwise, some degree of physiological reflux will happen to everyone. Now, the next thing is a hiatus hernia, because these two are terms are very often used interchangeably, but it is not so. You can have a person with gastroesophageal reflux disease but no hernia. On the other hand, you can have a large hernia but no gastroesophageal reflux disease. But there is an association between the two, that many patients with hiatus hernia will also have gastroesophageal reflux disease. So it's better to know a little bit about hiatus hernia also, and that is why I projected this slide. Otherwise, they are not synonyms. Gastroesophageal, in OPD you will get many patients referred for hiatus hernia, and you talk to them, there are no symptoms which can connect that hiatus hernia to their problem. So if you operate them, you may not necessarily be benefiting those patients. So this is the definition of a hiatus hernia: protrusion of any abdominal structure other than esophagus into the thoracic cavity, and common disorders. And there are different types and all, will not go into that. So before you go on to talk about GRD, you need to know a little bit about the basic anatomy, and these are the 4 things you should know about. These are considered a little bit of anatomical things, which is lower esophageal sphincter, phrenoesophageal membrane, angle of His, and crural diaphragm, and all of these is there a pointer? Yes. So, all of these contribute to the preservation of anti-reflux mechanism. Now, when do you get gastroesophageal reflux disease? There is a disruption of anatomical structures which contribute to the prevention of gastroesophageal reflux, or when there is a loss of intra-abdominal segment of LES. So, these are the anatomical structures, and then this is increased transient LES relaxation. So, this is a normal phenomena, but when their frequency increases, that also leads to GRD. And on the other hand, you also may have delayed acid clearance. Everything else may be normal, but there is a delayed acid clearance of the normal reflux that happens, that can also contribute to symptoms, or and that usually happens the esophageal peristaltic disorders. So, that is another thing which is very important and should be aware before you offer any treatment to these patients. So, this is that there is a association between hiatus hernia and the GRD. So, what are the symptoms? So, there are typical symptoms. So, if you have these symptoms, heartburn, regurgitation, sometimes dysphagia, chest pain, and patient response to PPIs and all, these are good candidates for surgery. Or you may have atypical symptoms. In these patients, you should be very careful in offering surgery because it may not necessarily help them. And then you have these extra symptoms, they are now becoming more and more well recognized, and these are cough, asthma, throat clearing, laryngitis and all. Again, the benefit of surgery in this group of patients may not be as good as that in the typical symptoms. So, therefore, it is important to choose your patients. So, how do you diagnose this? By history, there is nothing much that you will see in examination, a thorough history, and there are symptom scores and all, which will not go into the details of. Upper GI endoscopy is very important, and as you can see here, it will. So, this is the squamocolumnar junction, and somewhere there is your diaphragmatic pinch. So, this patient has a little bit of a hiatus hernia, and then it tells you about the hiatus hernia size, the Hill grading, and whether there are any complications etc., like Barrett's esophagus or the degree of esophagitis, which is described as LA, A, B, C and D. So, B, C and D are considered to be pathological, A may happen in a normal also. So, this is what shows you a hiatus hernia, and this is a Cameroon ulcer in a patient who has a hiatus hernia and reflux. These Cameroon ulcers can bleed. So, endoscopy is a very important component of workup, and barium swallow from a surgeon standpoint, although from a diagnostic standpoint gastroenterologists do not want it, but from a surgeon standpoint you do want it to see how much is the hiatus hernia, whether it is a sliding type, or you may actually have a complete twist of the stomach. It is a rolling type of a hernia with a organoaxial twist. So, this is barium swallow helps you to plan your surgery better. You also get a little bit to know about the let us see whether this works. Yes. So, you can have, let us see this barium swallow, you have a small sliding kind of a hernia, and it is a relatively small hernia here on this video, right. On the other hand, you can have a scenario like this, where there is a organoaxial rotation, and if you see this particular hernia, it is a huge hernia, almost half of the stomach has gone up into the thoracic cavity. So, your management, your treatment, your fundoplication, your technique is going to vary a little bit depending upon the size of. So, it is important to have all these investigations because they help you plan the surgery well. Then HRM is manometry is very important nowadays. Prior to surgery, you must always do it because it tells you about motility disorders etc., and you can then tailor your fundoplication accordingly. So, this is the manometry. It also tells you about this. So, this is a normal manometry where crural diaphragm and LES they overlap, whereas if you have a hiatus hernia, the LES has gone up and this is the crural diaphragm. So, this is one of the most sensitive investigation to diagnose a hiatus hernia. And pH studies are the gold standard, which will tell you whether or not there is a reflux. And usually conventionally it has been 24-hour pH manometry, but nowadays wireless 96 hours pH manometries are also available, although not in India I guess, and they help you to sometimes you do not pick up these problems. So, they tell you about it is a bit of a complex thing, and it has been well defined by this Lyon consensus. And these are the grades of endoscopy. When do you call it a conclusive reflux? If you have LA grade B, C on D esophagitis, acid exposure time of more than 6%, and then you definitely say that yes, this is a reflux, and these patients may benefit from surgery. On the other hand, if you do not have any esophagitis or a hiatus hernia or anything on endoscopy, and your acid exposure time is less than 4%, then you would not consider it a candidate for surgery, or you would not even consider that this patient has any significant reflux problem. And then there are other parameters which can be done on impedance, which also support or refute the diagnosis of gastroesophageal reflux disease. So the idea of all this is that you make a diagnosis of reflux. So what are the indications of surgery? So esophageal or extraesophageal symptoms that are responsive but not completely eliminated by PPIs. Patients with heartburn eliminated by PPIs but continued volume reflux, that is regurgitation. Patients with GRD complications such as Barrett's or vocal cord injury while taking PPIs, and those who have GRD who do not want to continue PPIs. So these are the indications of surgery. To choose your patient for surgery, ICARS has given guidelines, and if you have these symptoms, that is heartburn responding to PPI, regurgitation response to PPIs, symptoms with hiatus hernia, Barrett's, LAB esophagitis, or symptoms with sliding or paraesophageal hernia on barium, these are the candidates who will do well on surgery. On the other hand, if you have these situations, extraesophageal symptoms only, reflux, hypersensitive esophagus, functional heartburn, eosinophilic esophagitis, scleroderma, they are not the good candidates of surgery. So that is important that you choose your patient properly. So coming to now, what are the surgical options? So this is how it has evolved from a total Nissen to partial wraps to thoracic approach, and then Hill's gastropexy and Colles gastropexy for special situations. We'll focus today a little bit on the fundoplication part of it, and everybody knows Nissen, who is the one who described this fundoplication, 360-degree long wrap, with a downside that it created a supracompetent valve leading to difficulty in swallowing and belching, and dysphagia and bloating. So there have been many modifications of this, like Nissen Rosati, Demister, who advocated a floppy short wrap, then no division of short gastrics, etc. So these are the different modifications that have been proposed for Nissen. And then Toupe proposed a wrap which is a posterior wrap, and in his own language, his idea was to create a wrap by fixing the fundus to posterior aspect of abdominal esophagus in a semi-gutter shape, and then they added a gastropaxy to it by fixing it to the diaphragm. So this is how people have tried it out, and Watson proposed an anterior wrap, which is a 180-degree, and subsequently he went on to say even if you do a 90-degree wrap, it is good enough. It gives you relief of symptoms, and it also leads to lesser side effects of the more bigger wraps like 360-degree or something. So the idea is that you start with something like this, and you want to create a valve. Due to shortage of time, I didn't go too much into those some of the things, but this is what you want at the end. These are three different procedure. One of them is a Nissen, one of them is a Toupe, and one of them is an anterior door. They all will give you a competent valve. So that is what you want to achieve. This is the aim of fundoplication surgery. So these are our patients, and then how you do it has been described by this Lotus trial, and we'll go through these steps one by one. So this is how we normally nowadays do it through laparoscope or sometimes robotic. So this is the port placement. And then what you want to do is identify the right and left crus. So these are the right and left crus. You must make sure that you leave some peritoneum over there. You start off with something like this, and then you want a dissection where these two are identified nicely, and you want to create a retroesophageal window, you want to preserve this fascia over this crura, because your otherwise your sutures will not be very well taken. And mediastinal dissection is done to get enough, say about 2.5 to 3 centimeter intra-abdominal length of the esophagus. During this process you need to preserve anterior and posterior vagus, right. Then you want to create a then you want to do a cruroplasty. So you want to do it using 2 to 3 or 4 sutures depending upon the size of the hiatus. It should be snug but not too tight. There are different aspects to it, but we will skip that for a moment and let us see. And then finally, you want to create a wrap, and in this particular short clip, what you are seeing is you do the shoe shine, and then you want to see that everything is coming nice and easy, and then you create a Nissen fundoplication, taking one of the stitches through the esophagus. So, we will go on to show you a video here. So, you see here a full video you want to see here. So, we start with the identification of the right crus. We always try to preserve this hepatic branch of vagus, and you need to get into the right plane here. That is the key point. If you do not get into the right plane, and if you see a lot of blood here, that means you are not in the right plane, you are in the wrong plane. So, if you are in the right plane, you will see this loose areolar tissue, and then you have to do, and if you remember a big hiatus, this patient had a lot of stomach in the mediastinum, you want to bring it all down. So, you identify the right, and this we are now going on to the left. And for large hiatuses, you will have to divide few short gastrics. Sometimes you may not need to do it, but mostly you for large hiatuses you will have to. And then you extend your mediastinal dissection. You can see this mediastinal dissection going up here. And I would also like to have you have a look at this. So that's a robotic thing. You do the same thing. You here now see, but you just see the stability of the platform now, how stable the view is there. And here now we are doing that shoe shine maneuver, right. And once you ascertain that, but you see the stability of view in that robotic, and then you close this crura. Same thing you are doing on that side also through the robotic, but again I hope you can appreciate the difference in the stability. And then you are now doing a crural closure here, and if you do not have very good crura, then you use the buttressing material as we have done in this particular case. And here you are seeing a Nissen in progress. On top you are seeing in a inset you are seeing a toupee in progress, where you stitch either side to the either side of esophagus, and in the robotic also you will see a toupee in progress. And suturing and all definitely is a little more easy in robotic, as is evident in this particular video you can see. And here is a completed Nissen. You remember to take out these slings and all, and here is a completed toupee on the robotic end. So, sometimes you have a very large hiatus like in this case, and the diaphragmatic crura are not very good. So, what you see here is we have done most of the dissection. So, I just wanted to give you an idea as to, so this is being done robotically. So, you see the condition of crura, this was a 70 plus persons. We normally do not use mesh, rarely we might have to use a mesh, and rarely you may have to use a both anterior and posterior closure, because if we kept doing posterior closure, it would cause a angulation at the G junction. So, that can cause dysphagia. So, sometimes you have to, and here is a bioabsorbable mesh that is being placed. So, it is a very rare situation where we use a mesh, otherwise most of the time we want to avoid. And again, as you can see, the robotics help you to do this nice and easily. It can be a bit challenging when you are trying to do it in a laparoscopic technique. And this is a short clip. You have already done the dissection, got the esophagus down, and this is we are trying to show you how to create a anterior wrap. And what we do here is, first we recreate the angle of his. This is what is being done. The first stitch being taken at the top of the fundus and with the left crus and the left side of the esophagus, and then 2 or 3 more stitches on the left aspect of the esophagus. So it recreates the angle of his. And recently I had gone to Bombay in a IAJS meet, and there an endoflip was being demonstrated. Very nicely showed that merely AOH creation leads to a very good wrap. And now we are flipping it over to the other side, fixing it to the right side of the esophagus and the right crus to eventually give you a anterior door fundoplication. So you can kind of decide what to do depending upon your patients. Most of the guidelines now say ask the patient what they want rather than so these are some of the contentious points: complete vertebral pulses, short gastric division, yes, no, mesh, yes, no, robotic laparoscopy. In surgery, in my nearly 40 years of experience, I can tell you there is no hard and 100% rule. You always have to tailor. You should know about the things and tailor them to the requirement. It's not that every time you will need this or every time you will need that. So partial wraps have been found to be reasonably good, and more people are now switching over to the partial wraps, particularly in those with some degree of esophageal dysmotility. Short gastric division, now if you see this, in this patient, you know, the fundus was so floppy, without any short gastric division you can get that wrap. But if you try to do it in this, the spleen is getting pulled the moment you are trying to, you know, pull the stomach from behind. The spleen is getting pulled. So if you do a wrap in this situation, at the end of the day the spleen will pull it back and it will cause some twisting. So you can, you know, always do some short gastric division, not extensive, just to make sure with few short gastric division it is looking now so nice and easy. So mesh or no mesh I have already discussed. In the long term, mesh has not shown any benefit. In the short term it has shown some, and the recommendation, they say we cannot make an evidence based recommendation, equivocal benefit. So use it judiciously, like I showed you an example where there seemed to be a reason for us to use a mesh, so we used it. In morbid obesity, other than fundoplication, you can use a Roux-en-Y procedure. First you try it, but if it does not work, you can actually do a Roux-en-Y. It is a good anti-reflux procedure. So so these are the recommendations, that after failed Nissen or a redo Nissen, you can do a Roux-en-Y bypass in morbidly obese. Robotic and laparoscopy, eventually you are doing the same thing, it does not really matter. So although the talk was on fundoplication, I just wanted to add that magnetic sphincter augmentation is another thing that has now come up and has shown good outcomes early on in patients who do not have any significant hiatus hernias and all. And a reflux stop is another newer technique which is being used for GRD patients, again in patients who do not really have much of a hiatus hernia. So to end my talk, a word of caution: you must establish GRD as a cause of symptom, identify esophageal shortening, identify contributory pathophysiological factor, and make patient aware of relatively diminished success of surgery if you are doing it for atypical symptoms. So understanding the pathophysiology is very important. Proper patient selection and complete preoperative evaluation will help you to make a good decision and choose a good procedure, and it can help us meet the patient's need and improve the outcomes following an anti-reflux surgery. Thank you very much for your kind attention. And if there are any questions, I will be happy to take them. Yes.
Good morning, sir. Sir, I just wanted to ask the reason for going for a Roux-en-Y gastric bypass in a patient with morbidly obese who has GERD and not going for a sleeve gastrectomy. Why are we not going?
Because sleeve creates a high pressure system which will lead to more reflux, which has a potential to lead to more reflux. So if you have a documented reflux, so again understand, you may have a documented small hiatus hernia but no reflux. On the other hand, you may have a documented reflux. There is also a particular pathophysiology which if you go into that, you will know why even with a small hiatus hernia patient may not have reflux. It all depends upon the insertion of phrenoloesophageal membrane, how it gets inserted. So, as per that also there are different classifications. But Roux-en-Y is definitely better because by itself it leads to on the other hand, sleeve, it creates a high pressure system. If you already have reflux, it can accentuate it. But if now people say that if you have a hiatus hernia, you close it and do a sleeve or anticipatory angle of his accentuation. But those are, I guess, for patients who do not have a significant reflux as demonstrated by peer studies or presence or absence of esophagitis.
So, and laparoscopic gastric banding also produces a high pressure system. Is that
laparoscopic gastric banding is different because there you are putting a band just across the G junction, right? And nowadays nobody does it. Laparoscopic gastric banding has been practically given up,
yes,
right? Whereas in a sleeve gastrectomy, you still have a whole lot of stomach with an antrum and a patent antropyloric region. So they are two different situations. Okay.
Yes.
So in laparoscopic gastric banding, you will just have a 30 ml of high pressure system. Here you have a whole length of the stomach to you.
Yes.
Okay.
Thank you, sir.
Thank you so much, sir, for such a clear and engaging talk. I am sure everyone has benefited greatly. Now, I would like to request Professor Abhinav Arun Sonkar, sir, to kindly felicitate, sir. Now I would like to welcome Dr. Divakar Dalela, sir, former professor and head urology KGMU, to deliver his talk on the topic renal cell carcinoma, a stage-based surgical strategy.
Thank you very much. Changer. Okay. Yeah. अभी आया नहीं है. Okay. So, very good morning, everybody. It's always a pleasure to come in this lecture hall because I have practically sat in every corner of this room. I joined this institution in 1979 as an undergraduate, and by 1981, we were in this hall. So, without wasting your time, I'll take you through some important basic concepts about the surgical management of renal cell carcinoma. The surgical management of renal cell cancer is dictated not by the presence of tumor alone, but by the stage and the volume of the disease. The stage decides whether to operate, and volume decides how to operate. So both aspects are important. So I'll share with you some information on the stage first, and this is the simple sketch anatomy of the renal area and its capsules and fascia, not difficult to understand. The T1 lesion is T1A less than 4 centimeter, T1B 4 to 7 centimeter, T2A 7 to 10, and T2B more than 10. So T1 and T2 are essentially intracapsular, intraparenchymal lesions. The only difference is in the size. The T3 is the one which becomes extracapsular. A is extracapsular, and you may also have, if the node is positive or if the small tumor thrombus in the vein. This is all T3A. But the moment tumor thrombus goes in the inferior vena cava infradiaphragmatic, it becomes T3B, and when it goes to supradiaphragmatic or just below the diaphragm, T3C. When you have extra capsular, extra facial, beyond the gyrota fascia, like the T4, or if the adrenal gland is involved, that's T4. So this is the T staging of renal cell cancer, and it is on this basis we go how to operate. So what is the role of surgery in renal cell cancer? Where do we offer surgery to the patient? We offer in localized cancer, this means T1 and T2, we do a nephron sparing surgery, which is either tumor enucleation or partial nephrectomy. When tumor gets little more in size, is locally advanced, we offer radical nephrectomy. Some patients of localized cancer also go for radical nephrectomy. And when it is metastatic cancer, we offer palliative nephrectomy. Some patients of locally advanced can also go for palliative nephrectomy. So such is the spectrum of the surgery. What I intend to tell you here is that at all stages of renal cell cancer, surgery has the value. What are the objectives as a surgeon? What are we aiming at? We are aiming at oncological control, good complete oncological control, at the same time conserve kidney function, and conserve kidney function of the involved kidney and also the contralateral kidney. And when we do this, both objectives, at that point there should not be any increase in the surgical morbidity. Now you may ask me this question, that in oncological practice a biopsy is mostly recommended in all cases prior to cancer surgery, right? And this is a standard practice. But in renal cancer, this is not the case. Not all cases require a biopsy. So this is a deviation, and major deviation. And what is the reason for this? Reason for this is that when we do a sectional imaging, either a CT or MRI of the kidneys, the radiographic diagnosis is accurate as much as more than 90%, right? So I don't see the need to do a biopsy, correct? But then if somebody insists and does a needle biopsy, the histological accuracy is only around 90% and grade accuracy is even lesser. So I am actually may not be able to pick the disease. And in that case, one may do a rebiopsy. If you insist, if the patient insists, document my diagnosis, you do a rebiopsy, then probably I am wasting time. If we do ultrasound guided and CT guided to increase the accuracy of the biopsy, then even in that case, forget the blind technique, in the guided technique, the incidence of hematoma and hematuria is there, and therefore I may, although less often, create a complication. So if you see 1, 2, 3, 4, there are 4 reasons for me not to recommend renal biopsy for every patient. When today, then it should be preferred. There should be some select indications for us to do this, and this is when you have a doubtful diagnosis of renal cancer. There is a mass lesion in the kidney and you are not sure, radiologist is not sure. Then in that case, for instance, if it is a hematologic malignancy like lymphomas in the kidney, or it is a metastatic disease, I have seen sometimes thyroid cancer metastasizing into the kidney, osteogenic sarcoma metastasizing into kidney. So these two I have seen myself. So or there is an infective mass lesion, tuberculoma sometimes. So you need to establish a diagnosis. There you need a renal mass biopsy. In those cases where you know that it is renal cell cancer, a reasonable diagnosis already made, then only for T1, I will repeat here, only for T1 you have to do a biopsy to find out is it an indolent cancer or it is an aggressive cancer. Because if it is an indolent T1 cancer, you can leave the patient for watchful waiting or for active surveillance. What should be the considerations for surgical management? As a surgeon, what is in my mind going? In my mind, what is going is that you have to concentrate in the preoperative scenario you have to concentrate on an operative scenario, and you have to have some time for the post-operative period. The role of surgeon begins in preoperative phase and goes till the end, the post-operative phase. And remember, champions prepare hard before they play. So you have to, before you go to the OR, you should know A to Z about the disease. Champions play every ball with precision, right? So there's no scope of confusion. So you have to have very clear roadmap what you do in the OR. And then champions don't count their chicken before they hatch. So if you want to call yourself a surgical champion, you have to be very well doing at all these three fronts. Which approach to follow for surgical removal? There are today open surgery, gold time surgery, laparoscopic surgery or robotic surgery. Oncologically they achieve same goal, but the craft changes, the morbidity changes, and therefore you choose what is best in your hand and what is available to you in your institution. Preoperative considerations, what is in the mind? In the mind is that here you have a renal cancer in the left kidney, upper pole. You want to know in good details about the disease first, right? And you want to know how bad is the cancer, and this is by radio imaging, and in some patients I told you renal mass biopsy. Then you want to know how difficult shall be the surgery, surgical skill, surgical performance, and that you know by radio imaging again and renal function test and liver function test. And you today we use a scoring system that's called renal nephrometry score, RENAL, and there are more scores like renal scores, Padua scores, C index and ABC. There are a variety of scores. We in our institution have used renal score more often. You are trying to pin down the complexity of surgery beforehand, and having done that, you move to know about the patient whom you are going to operate, and this means anesthesia fitness and also surgical fitness. So what I am saying is that you are treating renal cell cancer not in the kidney alone, you are treating this in the entire urinary tract, and the urinary tract is in a live human body. So you have to remember everything, and you are managing kidney cancer not only as a part of a urological disease, but the entire patient till he or she is sent back home. The operative considerations, moving to that area, we have 4 concerns in our mind, and 4 concerns: which incision, how much to excise, how to protect kidney function, I said this is the objective, and how to protect adjoining organs which may sometimes be involved. How do you decide incision? People still use a flying incision in renal cancer, particularly on the left side, also on right side. This gives you direct access to retroperitoneum. It's completely extraperitoneal approach, and most importantly, the incision is along the nerve direction. So the neuronal injury and the vascular injury is least. Very good for lower polar tumors, as shown in the picture here. The another incision is popular is a transabdominal chevron or subcostal incision, which is done for situations like the one shown in the picture. And chevron incision is like inverted V. I hope you know what a chevron is. You know what a chevron is? What is chevron? Chevron is, if you see a soldier, army man, on the sleeve of the soldier, this is the kind of the mark, and this mark is called chevron, and from that we have taken the name chevron incision. But we also make sometimes for a smaller tumors right subcostal only, not the contralateral side. But the beauty of this incision is it gives you excellent exposure of renal pedicle, inferior vena cava, the in fact entire abdomen, the contralateral side, and then if you have to remove vena caval thrombus, this is the incision. Sometimes we use thoracoabdominal incision. This is for large upper polar tumors, right, where you have a possibility of involvement of spleen or talar pancreas and base of diaphragm. how much to excise in which case. And here comes the role of the stage of the disease. And we go stage by stage, how much to excise in which case. For T1A, if it is a familial cancer, only enucleation will suffice. But if it is sporadic case, you need a partial nephrectomy. For T1B, most of the times we do partial nephrectomy, but some situations we do radical nephrectomy. For T2A, radical nephrectomy, most cases, unless there is a compulsion to do partial nephrectomy. Same thing for T2B. For T3A, when the vein is involved, the way it is shown in the picture here, you can still do a radical nephrectomy. If the lymph nodes are involved, extended radical nephrectomy. If the inferior vena cava is involved and the tumor is below the diaphragm, you do radical nephrectomy with tumor thrombectomy. And if it is above the diaphragm, you will do radical nephrectomy with tumor thrombectomy with coronary bypass. So with this help of the slide, the point I am trying to make is, greater is the volume of the disease, it changes the extent of the operation, and that's true for all cancer surgery. If you have adrenal involvement, you do standard radical nephrectomy for T4. You also do for T4 disease, if it is a fascia is involved and some perinephric fat is involved, then again you do a standard radical nephrectomy. How to conserve renal function? This is a big question, and anesthetists also take equal part in this game. For partial nephrectomy, you have to, try and, if you are doing partial nephrectomy, remove only 3 millimeter parenchyma around the tumor. Don't remove much of the parenchyma. Your goal is to save parenchyma. So it is said that if you remove 3 millimeter, it is safe oncologically. And you have to try and reduce the warm ischemia time, lower the better. And radical nephrectomy, the contralateral kidney function conservation is very necessary. Okay, particularly when you are taking the control of the vein on the other side in the veins. And if you are doing tumor thrombectomy, the conservation of contralateral kidney function is of paramount importance, and we use these days lots of drugs to conserve the kidney. How to protect other organs? No rocket science in this. You have to see CT scan, MRI pictures in 3D imaging. It is better that you know which solid organ is involved upfront and you handle accordingly. Confusion often arises about the diagnosis of hollow organs, and then you can create injuries. So be careful in that part. Moving to the post-operative area, which complications should you keep in the mind? You should go by the time. When you operated the patient, shifted in the post-operative period, for first 2 days, you have a bleeding, which is perinephric or hematuria, or a urinary leak. These two are urinary complications, or even oliguria. These three, right? These three are urologic complications, but you can have extra urologic complications also, which is pulmonary and a down lung syndrome. If the patient is later, 48 hours and beyond, up to 7 days time, the urologic complication is wound sepsis, and extra urologic is ileus, very, very common. And then I have seen some bowel injuries where fecal leak comes from the wound. So take few more minutes sharing with you the common questions that are raised from you in exam if you have a long case as a renal cell cancer. And this is on the nephron sparing surgery. When do you opt for nephron sparing surgery? What is the difference between enucleation and partial nephrectomy? When do you perform nephron sparing surgery? Right? When you've done a preoperative evaluation and you found renal functions are normal, right? And then you want to sort of do in a case where you want to have a chronic kidney disease in future. If you remove lot of renal parenchyma in surgery, then patient left with less volume of kidney and he can develop chronic kidney failure in future. That is the rationale for doing a partial nephrectomy in T1, T2 disease. Then there are some patients who have risk of going into renal failure in immediate postoperative period. They are normal to be in preoperative period. But post-op, they can go into renal shutdown, and they are the patients like tumor in solitary kidney, tumor in bilateral kidneys, tumors where one kidney is small contracted, tumor when the other one kidney is chronically shrunken, CKD, and tumor when you have the other kidney hydronephrotic, right. So, in all these situations, if you operate a patient, post-operatively the patient can go into renal shutdown. Therefore, you conserve as much kidney function, kidney tissue as much as possible. Now, there is a scenario where the kidney function is abnormal even preoperatively, serum creatinine 2.53. Then here the onus to conserve the kidney function is even more, and this situation can arise in patients who have tumors in CKD. This is very common these days with dialysis used, both kidneys or multiple tumors in CKDs. And then the second question, what is the difference in enucleation and partial nephrectomy? In enucleation, you go by just removing the kidney outside the capsule, no renal tissue is removed. In partial nephrectomy, 3 millimeter parenchyma is removed, right. So, that difference you should understand. About radical nephrectomy, quick few more minutes on common questions. Adrenal gland. Adrenal gland today is not removed as a routine in kidney cancer. Few more minutes to finish. Yeah, thank you very much. So, remove adrenal gland when it is directly involved on CT or MRI, or when you presume the chances of involvement of adrenal gland may be higher in the kind of indications listed here. You spare the adrenal gland if it is not involved in kidney cancer, and in most cases tumor volume less than 10 centimeter, adrenal is not involved, adrenal is not removed. In Robson's typical radical nephrectomy, adrenal gland was removed in every case. Same thing is lymphadenectomy. It is not done in every case. In cancer surgery, you would like to remove lymph nodes in most cancer surgery. But in kidney cancer, lymphadenectomy is not the routine part of it. Only when lymph nodes are visibly involved on CT or on table, they are removed, otherwise they are not. So, there are various indications of doing this, when grossly you can see it, or on frozen section, or you doubt somewhere. Also, I want to tell you one more thing. When you remove a renal cancer, it is your sacrosanct duty to show the specimen to the relatives, bisect the specimen in front of relatives, and then note down the features of cancer, gross features. And there are 10 features which you as a surgeon are supposed to note down in the biopsy form and give it to the pathologist, because they change when the specimen is conserved in the formalin. Okay, so this is very important, do not forget this. When you do nephrectomy, please do this. So, thank you very much for your patient listening. Thanks very much.
Thank you, sir. Thank you for that highly insightful and enriching talk. Now, I would like to invite Professor H.S. Pava, sir, to kindly felicitate, sir. Now I would like to call upon stage Dr. Rahul Singh sir, Associate Director Minimal Access Surgery, Max Hospital, Lucknow, to give his talk on the topic multi-organ hydrated cyst disease management.
Good morning, everybody. Thank you, Department of Surgery, for having me here today. So this presentation is basically a video-based presentation, but I have tried to modify it a little bit in such a way so that it is useful for the students going for examination or for further super specialty examination. So we all know some basics, that hydrated disease, also known as echinococosis, and it is basically a class of zoonosis. Three major organisms are there which are causing this, namely the granulosis, multilocularis, and the legatus. The important point in this, which can be asked as a question is that there is something known as malignant echinococosis, because it is very turbulent course. It is mainly caused by multilocularis, and multilocularis does not involve the classical dog sheep cycle. It involves usually foxes, so it is a wild variety, and basically it revolves in the dog and the sheep, and man is actually an accidental host, because once this organism enters the man, it is the dead end for the organism itself. Then the cycle is broken. Quick important things: it is ingested as an embryo. It becomes an oncosphere in the duodenum, enters the bloodstream, and reaches what all organ comes to it in the first instance. Normally it is always liver, because the portal circulation, everything drains into the liver, but sometimes some of this oncosphere can actually bypass the portal system and go and lodge in the lung, brain, spleen, developing as those extrahepatic sites for echinococosis. So these are the few things which you can see. First one is the brain, and the next one, can anybody identify what is the structure? So this is the neck. This is the neck of the patient, where the patient has developed a large echinococcal cyst. So I have highlighted these points because these points have sometimes come as a part of examination. So I have just tried to highlight in examination point of view that 75% of this hydrated cyst is found in the right liver, involving segment 6 and 7. This is in comparison with your other cystic disease of the liver, that is the pyogenic or the amoebic, wherein the male and female incidence is equal in this case. And once the liver is infected with a hydatid, the cyst becomes visible within 3 weeks. And the most common presentation is abdominal pain, whereas the most common sign elicited by the clinician in a patient with hydatid cyst is hepatomegaly. So this again has been as a question in some form. So when talked about the workup, the ultrasound forms the basis of all the workup, and we know classically the Garby classification was then, which is now was there in the past, but now it is mainly changed and now replaced by the WHO classification. If you have a large symptomatic hydatid cyst, you need to do a contrast enhanced CT scan. If it is liver, then abdomen, and if it is lung or brain, then you do the CT scan of the whatever organ is involved. If the patient with a hepatic hydatid has some history of cholangitis of jaundice, so you can suspect that there has been some cystobiliary communication. In that case, you have to do an MRCP also. So MRCP is not routinely required in all the hepatic hydatid, but if the patient shows a history, gives a history of jaundice or fever or cholangitis, you need to do an MRCP. And regarding the serological test, we do ELISA, which checks the IgG antibodies for this. It is very, very sensitive. So now we'll quickly go to the WHO classification, which is the currently followed classification. It is CE1 to CE5. CE stands for cystic echinococosis. Okay. So 1, 2, 3, 4, and 5. The important points is which you have to remember is the first 3 are the alive cyst, and the 4 and 5 are the dead cyst, because it has developed calcification, so it is not active anymore. Next point to be noted is, it can be asked as a question, is that the CE1 is a simple unilocular cyst. This honeycomb or the rosette appearance is there in CE2, and the water lily sign, the classical water lily sign, comes in CE3. Ball of wool sign is seen in CE4, wherein the entire cyst is filled with this calcified material. So when you compare this WHO classification with the previously present Garby classification, you see that Garby 1 is CE1, Garby 4 is 4, and 5 is 5. So there is no confusion in that. The only difference in this is that Garby 2 actually corresponds to CE3 and Garby 3 corresponds to CE2. So this is a small point which can be asked in some MCQ or some question like that, that the difference, only difference between WHO and Garby classification is that 2 and 3 are actually crossed. So what is important in this diagram is that there are 3 classical layers, that is the pericyst, ectocyst, and the endocyst. Now this pericyst is the host tissue. It is not a part of the organism, so this again can be asked as a question, and only this ecto and endocyst are the parasitic tissues. And even in this ecto and endo, it's only the endocyst which is the actual living thing. So rest everything is not the actual organism. Now coming to the management, very, very small subset of patients require no treatment at all. That is conservative, you can just watch them. Who are those patients? Old patients with a very small asymptomatic and densely calcified cyst. Otherwise, in all the other patients, you have to do something, either give medication or do something. Albendazole being the classical drug, it is given at 400 milligram twice daily. there is, in our part of country, there is huge variation. Patients come to us with 3 months, 4 months, 1 year of albendazole, but the textbook says that at least 2 weeks prior to intervention, patient should be given albendazole. That is the minimum which should be required. More than that, there is no clear-cut evidence. And what is the advantage of patients on whom you start albendazole in which you are anyway planning surgery? People might say that anyway you are going to plan surgery. What is the role of albendazole? So the role is that effectively shrinks the cyst, so the actual chances of spillage and the complications of spillage come down. So it's very imperative that even if you are planning a formal surgical resection or any other procedure, you have to give albendazole. And then there may be some patients who are not fit for any intervention, like the disseminated disease or very, very poor surgical candidates. In those patients, you just go and continue the medical management. Probably those are the patients wherein you can just continue for lifelong metronidazole. Then another important procedure is PAIR. Full form of PAIR is very important because in various textbooks I have seen there are different abbreviations for it. So the actual name is puncture, aspiration, injection, and then reaspiration. And then there is PVAC. For this is a little bit larger bowl needle, and then you do a percutaneous evacuation also. Scolicidal agents, initially there was 10%, but now it is 20% hypertonic saline. And then there is classically silver nitrate, ethanol, and iodine. The problem with silver nitrate is, anybody can tell? It causes sclerosing cholangitis, so it's not recommended that much. And problem with povidone iodine is that it causes confusion with bile leak. So once you are operating and you have washed the hydrated cyst with povidone iodine, now you are not able to make out that is it iodine color, is the betadine color, or is it the cystobiliary communication or the bile leak. And bile leak has to be tackled. So it is very, very important not to use this. Although it is a very good solicidal agent, but operative time there may be a difficulty. Again, some contraindications. Usually PAIR can be done in majority of them. The contraindications are superficially located because there is chance of spillage. Then extrahepatic sites, ruptured cyst, CE2 and CE45. So a quick question can be that CE2, CE4 and CE5. These are contraindications for PAIR technique. Coming to surgery, in all sorts of surgeries, you open the cyst, you aspirate the cyst, you fill it with scolicidal agents, unroof it, and then you have a lot of other options which you can see you can do depending on your surgical expertise. Either you can completely excise the cyst, which is very difficult because it's a major surgery going for a liver resection. You can simply do a marsupialization. You can put and fix omentum inside it, and then you can also go for a partial hepatectomy procedure. Two more other important things are that the cystobiliary communications to be meticulously looked for and sutured, and finally the laparoscopic management, which is now my video presentation, that has got a dramatically very, very low morbidity, and the patient actually gets discharged in 2 to 3 days. So we'll quickly go through the video. So this was a case of actually hepatic as well as splenic hydrated. What you can see here, so this is a large hydrated cyst in the left lobe of the liver. So again, this is the left lobe of the liver, and then you can see it on the spleen also. Is there a pointer here? No. Anyway, so now what you can see is that mainly the left lobe of liver which is completely distended, and now we are going towards the midline and seeing that the cyst is so big that it is crossing the midline. As important in all the hydrated cyst surgeries, you have to completely pack the entire surgical area with hypertonic saline. So what we have used here, I have used here is 100 gram, the 10%, but it is recommended if you can get it 20% of hypertonic saline. Now we are going to open this area, but the opening will not be in such a way that it just spills all the contents, because the contents will anyway be under pressure. So we do a little bit of weakening of the wall, and you can see this is a large bore suction which we directly put inside the cyst, because we don't want to open and cause spillage. So now you can see that the entire section has gone inside and the cyst is getting deflated. Once you deflate it, you have to reinstill with hypertonic saline multiple times. It's like installation, aspiration, and once you are sure that everything properly, you have cleaned all the fluid, you make the opening wide and you enter inside. And once you enter inside, you see this beautiful daughter cyst. These daughter cysts are very, very immunogenic, and they can cause severe anaphylactic reaction. So you have to be very careful. You put in a bag inside the peritoneal cavity, remove all the cysts and put one by one inside them. You want to make sure that you don't leave any of these daughter cysts inside. Again, you want to make sure that you don't leave any of these daughter cysts in the general peritoneal cavity, because these can actually give rise to multiple new hydrated cysts, because each of this is actually a normal living being, I mean the normal living hydrated. Once you have cleaned everything, now you are looking for the very important cystobiliary communication known as CBC. You can see here how my instrument is going inside. So this is actually communicating because the cyst has eroded into a nearby the biliary radical. Individually there may be 2, 3, 4, you have to identify each of them and individually close them. Here we are doing the suturing inside the cyst. Doing it laparoscopically sometimes it's a bit challenging because you have to enter with the instruments as well as the camera inside the actual cyst wall. There were, I think, two of them, 2 cystobiliary communication in this, which individually we ligated both of them. And once you are sure that this thing has been done, now we leave it as such and remove the bag. Next, shift our focus to splenectomy. Splenectomy is a very classical regular splenectomy, because in spleen we don't have an option of doing a partial splenectomy. If there is a decent size cyst, you have to remove the entire spleen. I will skip this splenectomy part because I think I don't think we can forward it. Anyway, let's go through how much time is left. 3 minutes. Anyway, we'll quickly go through the splenectomy. So in the splenectomy, this is a classical splenectomy wherein you approach from the lower pole to the hilum. The spleen, the blood supply of spleen is in such a way, it's usually a magistral or distributed pattern, so that as soon as you go on blocking one by one arteries, that much segment of the spleen will get devascularized. So there is no collaterals inside the spleen. A vessel which is entering the lower pole, you divide it, lower pole gets devascularized. Okay. So gradually we are progressing towards the hilum. Is it possible to forward this? Okay. So this is the greater curvature of the stomach, which is stuck very closely to the spleen. You have to remove because here it is very important that you divide the short gastrics very carefully, otherwise the bleeding can be torrential. Now we shift back our focus to the hilum. It is always a very safe practice to have some gauze piece in hand, so that in case there is some bleeding, inadvertent bleeding, you can actually compress it before you clip the vessel. So we dissected the hilum. This is a right angle. It's a very nice instrument for use for nephrectomy as well. And we usually clip. It is good practice to the patient side. You put 2 clips for extra security and 1 towards the specimen side. This part I have specially highlighted because you see, although the dissection and clipping looks very good, but you see there was a hidden posterior branch which started bleeding, and the problem in splenic bleeding is that within seconds the entire field might be masked. So now the gauze which we had actually kept before, anticipating that there may be a bleed, which comes in very handy. We sucked it, we clipped it, and then we completely blocked the bleeding, and luckily we could actually control the bleeding. Then further you have to just progress with the dissection, and once the hilum is done, you can do the complete splenectomy finish of the entire splenectomy. This is just because the part of the video, so and there's no method I can forward it so that we can come back to the hydrated thing. So this is the main splenic vessel which is entering the hilum. Once you divide it, the entire spleen is devascularized, and you just need to pull this spleen out of the abdomen. Fine. So once the hilar dissection is complete, you just need to bluntly dissect the spleen from the underlying structures. And most importantly, because this was as you saw in the CT scan, it was an upper polar cyst, there is always a lot of adhesions to the diaphragm. You have to you can now see the cyst. Once the entire spleen is lifted up, you can see the large cyst on the upper pole. Here it is always, because the cyst is on the upper pole, there is a lot of adhesions with the diaphragm, and you have to be very careful not to injure the diaphragm. Usually upper polar cyst, upper polar abscesses of the spleen can actually get adherent to the diaphragm so much that it is sometimes very difficult to separate them. Anyway, we could actually separate this. Now this was a big spleen. and taking it out of the abdomen after a laparoscopic surgery again is a challenge. So what the bag which we use here is actually a Euro bag. Euro bag is very, very sturdy, and it's an ideal thing to hold such big things. I will finish in just 2 minutes. Putting this bag, putting this large spleen inside the bag again is a challenge, but definitely you, over a period of time you will know how to bag the specimens. And once the entire specimen is put inside, we remove. Now we shift back our focus to the splenic, hepatic hydrated which we have done, and we are completing that procedure with the omentopexy. We fill in as much omentum as possible, but you know that as the patient stands up, the omentum is again going to fall down. So we take 2 or 3 bites, and just to try to retain the omentum in the cavity, so that omentum is like the policeman, everybody knows. So it will help to obliterate that cavity, and there is no seroma collection or fluid collection which you can later on get infected. So this is how the omentopexy was done, and now the specimen was completely removed. Once we remove the specimen, you have to break the specimen in pieces, and you can see the morcellated spleen and the cyst wall, and these are all the beautiful daughter hydrated cysts which you removed. The drain was placed, which was removed after 2 to 3 days once you are sure that there is no bile leak from the lesion. So that's it. Thank you very much.
Thank you, sir. That was an extremely informative and practical session. And now I would like to call upon stage Professor J.K. Kushwaha, sir, to kindly felicitate, sir. Now we have a short break for 5 minutes, and then we'll start with the urology session.
आई रिक्वेस्ट ऑल रेजिडेंट्स टू प्लीज़ गो एंड विजिट द स्टॉल्स, नहीं तो हमारी स्पॉन्सरशिप कैंसिल हो जाएगी यार, प्लीज़ चले जाओ. जितने लोग बाहर से हो, नहीं बाहर से अभी कितने लोग हैं? अभी केवल आप ही हो ना? विल स्पीक लेटर. आप कहाँ से हो? सिविल से, ओके. विल यू बी कमिंग टुमारो फॉर द फाउंडेशन डे? अच्छा, तो आनंद मिश्रा तो आ रहे हैं कल. सर को बोलना कि मैम ने कहा है कि हमें यहाँ आना है.
Now starting with the urology session, it's my privilege to invite our next speaker whose clinical experience and academic contribution needs no introduction. I would like to invite Professor H.S. Pahwa sir to give his talk on the topic testicular tumor, diagnosis to definitive care.
So, good morning. First of all, I am thankful to organizers and especially Geetika ji to assigning me this special task. She mentioned that I should cover these testicular tumors. So, diagnosis to definite care. Definitely, this is a very vast topic, but I would like to touch few important aspects, and I will give a brief overview. And we'll try to finish in time, and definitely welcome few questions after that. So how the various clinical presentations, what are various clinical scenarios, I will like to highlight few out of them, and important diagnostic evaluation, and a overview of management, how to manage these cases. So as we know, this is disease of young adults, like malignancy of young adults, 20 to 40 years old. So this is very, you can say that these patients are very psychologically very disturbing for the family, and as well as fertility problems are there. So malignancy of young adults, this is a sort of little different scenario. And another thing, 90 to 95% majority are germ cell tumors and majority are malignant tumors. But good thing about these tumors are, like now these are curable. So there is definitely a stigma of cancer, but then same time we are supposed to counsel these patients, it is curable. So this is important. So as we know, primary, we can simply classify germ cell tumors and non-germ cell tumors, secondary neoplasm, paratesticular. Primarily testicular tumors are germ cell tumors, so we will focus here to germ cell tumors. And they are further subcategorized. Seminomas, they are most commonly we encounter in our clinical practice. Then non-seminomatous germ cell tumors, embryonal cell carcinoma and teratoma. So these are nearly half in the distribution, we can say. Non-germ cell neoplasm usually rarely we encounter in our clinical practice. So definitely as we go ahead with the if you are managing any testicle, any malignancy, we need a proper staging, clinical staging or some TNM staging, as we all are familiar. So pathological tumor specimen is important here, history, clinical examination and imaging, and then tumor markers are also important. So two things are important, as in the morning session also, as Professor Dalila highlighted, like there are certain malignancies where we don't go for beforehand biopsy, like in renal cell carcinoma also, as he mentioned, we can make a diagnosis with imaging only, and then we have to proceed for definitive care without biopsy. Okay. So in same way in testicular tumor also, we don't go for pre-operative biopsy, we straightforward confirm our diagnosis by imaging, but here we have an add-on facility with markers also, like tumor markers are there. So we can confirm our diagnosis and we proceed for diagnostic and therapeutic, like hierarchectomy, and so it is nice. So we usually avoid biopsy in these cases. Coming to the clinical presentations, so if you have painless enlargement of the testis, painless progressively enlarging testis without any signs of inflammation, so it should be considered as neoplasia or testicular malignancy. And their figure of 10 is important. Somehow we look few cases like 10% can present acute testicular pain. That pain may be because of sometime infarction or sometime there is intratesticular bleeding, so that can present, or secondary infection that can present as acute testicular pain. But otherwise usual presentation is painless progressively increasing testicular swelling. And incidentally detected cases 10% you can have, like patient is going for under evaluation for any other problem and you find out a space occupying lesion and then it is. And 10% cases can present with advanced disease. So, here I think unfortunately in our scenario, Indian scenario, we may get more cases of in this category, like good number of cases we receive which are presenting with lump in abdomen, abdominal lump, and then we find out that patient is having undescended testis and testicular tumor, and sometimes they are having a small testicular tumor. They are ignoring, simply thinking because hydrocele and this filiary epididymoarthritis is very common in Indian scenario or at least in northern India. So, they are not much bothered about this increasing swelling and later on they are presenting with abdominal lump. So, that may be a different clinical scenario. So, that is, these are the common clinical scenarios. On examination, there is testicular mass, diffuse enlargement, typically firm and non-tender, and epid. So, what is difference here? Like you are going to examine a scrotal lump, which is painless, non-tender, smooth lump. So, in testicular tumor, what is important? And quite often, you people are usually examining those cases of hydrocele with epididymoarthritis or chronic epididymoarthritis. So, these two swellings you can differentiate. There is important distinction is like in testicular tumor, once you are doing examination, you will get, you are able to palpate a testicular mass and you can very well visualize separately palpate epididymis. But while in cases of hydrocele or on those inflammatory lumps, epididymis and testis is usually distinctly not palpable. So, this is also very important. So, in testicular tumor, if it is a testicular mass only, then quite often you are able to palpate epididymis in these cases. But definitely if it is very advanced disease, very advanced, very large swelling, then definitely these classical features will be masking. And another point I mentioned about a bulky retroperitoneal central abdominal lump, that is another common presentation with patient presenting with advanced disease, and the rest of things supraclavicular and inguinal lymph nodes, with later on you can in more advanced disease you can find out. So, what is important dictum for any solid scrotal swelling is all patients with a solid intratesticular mass that cannot be transilluminated should be regarded as malignant until unless it is proved otherwise. So, all scrotal masses which you are having a doubt, slightest doubt, like if it is not fitting in your classical diagnosis of hydrocele, means it is not transluminant, it is not cystic. So, if you are having a doubt, that you should consider as malignant and you should do proper evaluation on those lines. So, there are two things, and other extreme also sometimes we are overdoing these things, like a simple classical case of hydrocele, chronic hydrocele, we start this exercise. So, we are getting those cases also, like patient is having bunch of investigations and tumor markers and then they are referred. So, I will highlight that case scenario also in the next slide. Important differential diagnosis, as we all know, epididymoarthritis related with chronic epididymoarthritis with hydrocele, that is the most common. We are seeing in the day-to-day practice these cases. Hematocele post trauma, chronic hematocele, granulomatous arthritis, tuberculosis or Hansen's disease means, okay, and then spermatocele and cystic masses they can also present. They can sometimes confuse with your diagnosis. I am highlighting this case scenario, left testis, a nodular swelling. There are various clinical scenarios which we can encounter, like left testicular nodular swelling for 2 months, notice enlarged in size over last 15 days. This is a early case which presented with dull pain over left testis, referred to groin for 4 days, no significant history of trauma, fever, local redness, discharge, weight loss. So, he presented with small swelling with discomfort. Unfortunately, this patient was a son of one of our employee here only, and on examination scrotum was normal looking, no skin changes, left testis normal size, a small nodular swelling 1.5 by 1.5 centimeter size and firm hard swelling in inferior lateral part of testis. We could appreciate, and epididymis was separate developable. So, it was a, you can say, the early detection, a small nodular swelling in testis in a young adult. So, that was one case. On ultrasound, so definitely with, if patient is presenting with this swelling, a solid swelling, so next investigation will be imaging, that is high frequency ultrasonography of scrotum. irregular ill-defined heterogeneous mass in the left testis with low flow. So, there was little bit catch here, they mentioned low flow, although it should be, sometime it is most of the time hypoechoic lesion with high flow is very characteristic feature, but here it is little bit variable. So, well defined heterogeneous left testicular SOL on 18 by 16 millimeter with no evidence of retroperitoneal lymphadenopathy. So, definitely that patient went somewhere, then he got a CT scan done, a small poorly enhanced focal area for CT scan for testis as well as for retroperitoneal. So, 16 by 24 upper pole left testis extending to left epididymis. So, this is how imaging is going to help you, but sometimes it is troubling you also and delaying, unnecessary delay is there. So, there was definitely a better option of after ultrasound, if you are going for investigation, the choice is MRI. We could have gone, he could have gone for MRI, and although serum markers were normal. So, patient planned for exploration in here, and we went for frozen section in this case. So, high we planned for exploration with the inguinal incision, we delivered testis with clamping, okay, and then we taken a frozen section, but frozen section was also inconclusive because there was doubt with this ultrasound imaging, there was doubt on CT also. So, then finally we did exploration considering very high suspicion index like it is malignant. So, we subjected for frozen section. Frozen section was also not able to answer. They mentioned about like there are inflammatory infiltrates, atypical cells and whole nodule was so we thought it is likely and maybe there was doubt of malignancy. So, we completely excised with margin and sent for biopsy, but ultimately unfortunately that biopsy came to be malignant testicular tumor, and then we went for high inguinal architectomy later on. So, this way sometimes these are rare cases, but in we can. Another clinical scenario we usually can encounter right sided scrotal swelling, noticed 5 months ago, gradually increasing in size, 5 centimeter long when noticed. So, in that case I am again refreshing like clinical examination, then we went for ultrasound. Unfortunately, we were not able to make our diagnosis confirm with ultrasound. The next step was MRI, and finally we could have gone for, if it is straightforward, we can go for straightforward high inguinal architectomy, but in that case we explored, we did inguinal exploration, then subjected to biopsy, and finally we that patient was subjected to high architectomy and final staging. So, patient was this case again which we in clinical practice we usually encounter, like this patient initially painless, developed mild dragging during pain history. This patient was misdiagnosed as a case of hydrocele, again a misdiagnosis, and they explored this patient for as a case of hydrocele, and during exploration they find there was a solid testicular mass. So, good thing about that was they simply closed it without any biopsy or any further intervention, and they referred that patient to us. So, here we proceeded with this patient, and unfortunately this patient was having advanced malignancy with retroperitoneal lymph nodes and raised markers, and then after proper staging we could go for, it was T4 like scrotum was involved because of incision has been given, and finally high inguinal architectomy was done, and then we treated as per stage. Case scenario 3 I will also like to highlight here. Presently that patient can present sometime another extreme we can see, like a patient, if I am summarizing it, a patient living with a scrotal swelling for last 15 years, started having right groin pain, detected as on examination we find there was a right scrotal large lump of 15 by 15 centimeter, firm to hard in consistency, and with bilateral inguinal hernia, elderly patient, that patient is still in our ward. So, this is another scenario. So, definitely initially that patient referred to us with intent, like when it was examined somewhere in periphery, on clinical examination that picture was clearly mimicking of testicular tumor, a large testicular tumor, okay. But that patient was having developed inguinal hernia, that was symptomatic, and that was. So, what is catch here? Catch here was like that patient was living, clinical examinations are looking like on evaluation it looks like hard solid mass, but that lump he is living for having for last 15 years. There was no change in that size, no and non-tender and not any increase in size. So, what is important here? This history is most important, but that patient was subjected to the markers and all those things were normal. So, here could find out there was a calcified, and in picture in X-ray also you can see there is this you can see then there is calcified hydrocele on right side with bilateral inguinal hernia. So, these are extremes. So, these patients are also sometimes subjected to unnecessary investigations and workup like ultrasound and tumor markers, and then he was referred for that, and ideally he had only this hernia. So, ultrasound remains like if patient is presenting with testicular lump, ultrasound remains the first investigation screening, that is for confirmation of diagnosis, and if like we are able to confirm that it is testicular tumor, then we should go for next investigation abdominopelvic CT to confirm for retroperitoneal lymphadenopathy along with alpha these tumor markers. And this is CT picture. Tumor markers are important. I will just take 2 more minutes. So, help in diagnosis. It helps in staging residual disease and prognosis and follow up. So, in that way this is important, and usually in clinical staging, stage 1 simple disease confined to the testis, stage 2 if disease is going into retroperitoneum. I am not going in much detail, intricacies, simple you can remember for residents and for PG level. The disease is confined to testis is stage 1, and if it is in retroperitoneum is stage 2. If it is going beyond retroperitoneum like mediastinum and visceral, then it is stage 3. So, that you should remember, and stage this simplified treatment is usually guided to this. Once we will go for complex TNM staging, and then again we will subgroup in these 3 broad categories. Okay. So, simple understanding you should have here. This again it is more comprehensive TNM staging like T1, T2 and everything we are going, but finally again we are going to group these subgroups into stage 1, stage 2 and stage 3. So, disease confined to testis, retroperitoneum and beyond retroperitoneum is stage 3. So, these I am not going in these details. The principles of treatment: early disease, seminoma is due to radiation, radiotherapy and chemotherapy. That is good thing about this, but surgery remains mainstay of treatment, and non-seminomatous germ cell tumors are sensitive to chemo responsive. So, these germ cell tumors are very chemo responsive. So, advanced metastatic disease responds well to chemotherapy. Principles of treatment. So, this is like recent NCCN guidelines how we should go ahead. So, if suspicion of tumor, we should go for history and physical examination, testicular ultrasound, then these tumor markers, and we should counsel these patients for fertility, and we can also discuss for prosthesis placement in these cases. So, I am going through comprehensively how we will giving a final slide here. So, if there is seminoma and non-seminoma. So, if we are having a seminoma, if it is radical inguinal, so first step will be diagnostic and therapeutic will be inguinal archidectomy, and if it is stage 1, stage 2A or stage 2B. So, in those cases usually we will keep these patients on surveillance, means if disease is confined to the only testis, like that was first case scenario which I discussed. So, we will go for surveillance. In high risk cases, if there is like tumor markers are positive, or if there is lymphovascular invasion, in those cases we can go for carboplatin single dose, or sometimes we can consider ipsilateral low dose radiation and follow up. So, these patients will be in follow up. While in advanced stage like stage 2B means sizable lymph nodes in retroperitoneum, or stage 3 like metastatic disease, in those cases first after high radical archidectomy we will go for chemotherapy. So, first line is BEC, bleomycin, etoposide and this cisplatinum, and then if it is completely responding, then they will go for surveillance. If mass is more than less than 3 centimeter, we will keep those patients on follow up. More than 3 centimeter, in those cases, we can consider here in cases of pneumonia FDG PET scan. Otherwise, there is not much of role for FDG PET scan in testicular tumor, but in these cases, and if it is positive, then we can go for excision. And if it is growing and non-responding to chemotherapy, then definitely we will go for second line and third line chemotherapy. So, this is a very crisp, oversimplified understanding of seminoma. And then for non-seminomatous germ cell tumor, because it is not radio sensitive, so that radiation option is out. Here we will consider surgery. So, radical inguinal architectomy, stage 1 and stage 2 we will go for RPL-ND, and in stage 1 it is low risk, we will simply put on surveillance, but if it is high risk category, then we will give adjuvant chemotherapy, then BEP. So, we are more pro for chemotherapy in non-seminomatous germ cell tumor. And if it is after 4 cycle complete response, we will observe. If there is residual mass, then we will go for this retroperitoneal lymph node dissection, and if it is advanced, if like lymph nodes are positive, in those cases again we can go for VIP, vinblastine and ifosfamide, or if it comes teratoma and fibrosis, then we will observe. So, it is a stage wise treatment plan. So, in recent guidelines, like stage 1 non-seminomatous surveillance is preferred, low risk cases, adjuvant chemotherapy 1 cycle or nerve sparing RPL-ND is being promoted if lymphovascular invasion is present in non-seminomatous, and chemotherapy is preferred for. These are templates for retroperitoneal lymph node dissection. BP, as you know, bleomycin is causes pulmonary fibrosis. It is also important multiple choice question for you people. Then BP and 3 cycles are we can use, we can skip bleomycin if respiratory reserve is poor. So, in those cases we go for 4 cycles of EP, and second line is VIP. Follow up and surveillance is very important. Follow up requires 10 years physical examination, tumor markers and imaging CT, abdomen and chest. Up to 2 years we need very intensive monitoring following these cases. But in spite of all these things, even in spite of advanced stages, we can say prognosis is excellent. These germ cell tumors are, to an extent you can say, these are curable tumors. So, like stage 1, this seminoma 99% cure rate, stage 2 70 to 92%, and stage 3 85. There is a little bit in comparative to seminoma, non-seminoma are having little poor prognosis. So, finally, to conclude with any solid tumor mass in malignant, considered malignant until proved otherwise, ultrasound and tumor markers are essential first step before radical inguinal architectomy. Radical inguinal architectomy is both diagnostic and therapeutic. We should avoid like scrotal biopsy, as it was done in second case. Stage based multimodal therapy achieves high cure rate. So, now chemotherapy is, I think majority of cases will require chemotherapy, that is what I would like to highlight. And improved overall survival of testicular tumor is, now we are having excellent prognosis because of better understanding of disease. We have tumor markers we use in different way, although I could not elaborate those 4 points here, and we are having cisplatin based better chemotherapies now. So, and now emphasis is on to diminishing overall morbidity, that is surgery and chemotherapy induced, and to improve their quality of life and fertility. So, in that way testicular tumors are being treated. So, thank you. I think little bit I am overshooted my time.
That was an extremely informative and practical session. Thank you for sharing your experience with us. Thank you, sir. Now, I would like to invite Professor J.K. Kushwaha, sir, to kindly come and felicitate Professor H.S. Pahwa, sir. Continuing with the session, with great respect, I invite Professor Apul Goyal sir to deliver his talk on the topic uh, renal calculi, medical to urology basics.
ये मोबाइल तो डॉक्टर बाबा का किसका है ये सबका है
Hello. Okay. So thank you, Professor Sonkar and Dr. Geetika for this opportunity. It's always a pleasure, coming back. I did my MS from this place only, my MBBS as well as MS, and it's always a pleasure coming back and talking here or listening here. Okay, so how many are final year residents here? Final year MS. So it's primarily on the right side. So can I have the slides? So there are 3 different topics given to me during different emails that were sent. So but there's no talk on renal stone. So it's a mixed type of presentation. So I'll be talking about management of renal stone disease, but little bit of ureteral stone as well, something about pregnancy and ureteral stone. Okay, so and if someone can give quick answers, because the time is less, I have about 40-50 slides, so it's a long presentation, and if we talk, then probably it will be too long. So if someone can give me quick answers, then it will be good. So it's an important disease, lifetime risk. It's a relatively common disease. You can say bread and butter of a urologist is a stone disease. Okay. So and it causes morbidity and can give rise to loss of renal function. So it has implications as well. Okay. So how do you manage acute colic? Can someone tell me quickly which investigation? First investigation. Quick. Acute renal colic or ureteral colic. You don't know. The patient comes with colic. जोर से बोलिए मैडम. नहीं, there are 2 things. Treatment क्या देंगी? Pain का क्या इलाज है? नहीं, हाँ, non-steroidal analgesics. Which investigation? First investigation. NCCT. Okay. NCCT KUB. Ultrasound. The problem with ultrasound is it gives you indirect evidence. You see hydronephrosis and assume that probably the patient is having a ureteral stone. Okay. So and X-ray KUB, the problem with X-ray KUB is bowel gases. It's difficult. You can't pick up a small renal, small stone. Although 90% of renal stones or ureteral stones are radio-opaque, calcium containing, but still X-ray KUB in acute pain is not a good investigation. What is the problem with MRI? It's written here. Have you seen a MRI in a patient with stone disease? It looks black. It's very difficult to read it. MRI stone disease, it's very difficult to identify where is the stone because it looks black. Okay. So this is what it is. What is MET? Can someone tell me the full form quickly? Medical expulsive therapy. Which drug? Tamsulosin, alpha blockers. Okay. The most literature is on tamsulosin, but other drugs also like sildosin and alfuzosin, these can also be given. Today we give tadalafil as well. You can give tadalafil. Okay. Okay. Pregnancy. Does the incidence increase? I have written it doesn't increase. Prevalence of urolithiasis does not increase, although there are physiological changes during pregnancy like hydronephrosis, because the uterus compresses the ureters. So there is physiological hydronephrosis. Okay. So the problem is the patient comes with colic, you get an ultrasound because you can't get an NCCT in a pregnant patient because of radiation exposure. You do an ultrasound, you get hydronephrosis. Okay, so you don't know whether it's because of pregnancy or is it because of stone. So typically hydronephrosis typically does not, if it is physiologic, if it's due to pregnancy alone, it doesn't extend beyond the iliac vessel. So once it is into the pelvis, it loops back, so the pressure is gone. So there is the hydroureter doesn't extend into the pelvis. In case the ultrasound is not diagnostic, you are still confused, you can get a MRI here in this scenario. Although as I mentioned, in the primary scenario, MRI is not a good investigation, but here you are, because of pregnancy, you try avoiding NCCT, but still low dose NCCT can be performed if needed, okay, but we tend to avoid, but yes, you can do. Okay, so the treatment is alpha blockers have been tried, but the data is weak. Mostly you have to do if the patient comes to you, you have three options. Either put a percutaneous nephrostomy, place a DJ stent, or you can do ureteroscopy. If you have a stone in the ureter, the patient is pregnant, you can do typically in the second trimester. You avoid doing it in the first trimester. In case you place a stent, it has to be because there is increased excretion of calcium during pregnancy, so you need to change it frequently. Typically we keep stents for 3 months, but in pregnancy you have to change it frequently, otherwise it gets encrusted. Okay, any guess? A patient has received a renal transplant and develops a stone. So what will be the presentation? कुछ माइक में बीच में छोड़ता है, क्या प्रेजेंटेशन होगा? ट्रांसप्लांटेड किडनी, अगर स्टोन बन गया क्या प्रेजेंटेशन होगा? It is a denervated kidney, so there is no pain. A transplanted kidney, if develops stone, there will be no pain. So you have to, any dysfunction, evaluate the patient. The creatinine starts rising or some other reason, suspect stone disease, because the patient will not present with pain, which is typical of urolithiasis. Okay. Okay, I think, okay. Do birds pass urine? How do they excrete? Cloaca, yes. And so uric acid होता है typically, ठीक है, इसमें urea creatinine. Okay. PUJ obstruction. So this is a typical picture of a patient who has secondary stones. If there is obstruction, okay. So these are multiple stones, they are rounded, they are because of stasis, है ना? वैसे क्या होता है, अगर stone का typical configuration क्या होता है, triangular होता है, renal pelvis में अगर फंसता है, ठीक है? These are round stones. So this is because of there is secondary obstruction, there is stasis, so it causes stone formation. So PUJ, have you seen patients of PUJ? PUJ obstruction in your OPDs or something? Any patient being operated? So most patients of PUJ do not have stones, but some do have. So why most patients don't have and some patients develop stone? Because they have underlying metabolic abnormality. It's not obstruction that is giving rise to stone formation, it's the underlying metabolic abnormality. So this you need to remember. It's not कि अगर stasis है तो stone बन जाएगा, ठीक है? Okay. So there are different types of renal stones. This is important. Why this is important? Why you need to know all this? Because you need to prevent stone formation. Okay, otherwise it comes back. There is high recurrence of, if you treat a patient with a stone disease, if you don't tell how to what precautions to take, the stone will come back. दोबारा बन जाएगा. Okay, so you need to know which precautions to tell to the patient. Okay. So imaging, CT scan remains the gold standard, although intravenous urography in our department, I'll say, it has taken a back seat, but in many departments, because IVP is a very good investigation, the problem is that you have to prepare the bowel for the patient. It takes 2 days. So you have to wait for 2 days. NCCT, there is no, you can do it immediately. Okay. So that is the advantage of a CT scan. This is how IVP looks like, and here on the right side you have a upper ureteral stone. What is upper ureter, what is mid ureter, and what is lower ureter? I hope you know this. We say that it is a upper ureteral stone, it is marked upper ureteral. So what is upper? What is lower? When do you say it is lower ureter? So the ureter between the sacroiliac joint, so between the superior border and the inferior border of sacroiliac joint is the mid ureter. So the ureter above it is the upper ureter, mid ureter, and the lower ureter. Okay. So that was this is a upper ureteral stone. I just wanted everyone must have seen ultrasounds, stone disease, acoustic shadow. The stone obstructs the passage of sounds, so you have this black area. So this is called acoustic shadow. So it's a very good investigation. NCCT today we write it left and right. So it tells you, it gives you so many other information. It gives you the Hounsfield value. Hounsfield was the person who invented the CT scanner. Okay, so Hounsfield value of 0 is which structure? Water. So water is 0. So stone, you can measure the Hounsfield. It gives you indirect evidence of composition as well. Less than 600 is probably a uric acid stone. A calcium containing stone typically 800, 900, or maybe more than 1000 as well. And it tells you if the Hounsfield value is above 1000, probably it's a very hard stone and won't break on ESWL. Okay, so all this information you get on CT scan. There are so many other things. If you choose urology as a carrier, you'll know so many other things about how to read CT scans in a patient with urolithiasis. Okay, so it's shown. It looks white on CT scan, dense structure. On the left side, you can see hydronephrosis in the first film, and you see a stone there in the second film. Again, another patient, multiple CT scans, you can see hydronephrosis, and then you see there is a big stone in the renal pelvis. So initial evaluation for like any other disease, this is almost the same. Metabolic evaluation, especially in patients who are getting recurrent stone formation. Okay. Or if the stakes are very high, the patient has a solitary kidney, okay, or if there is uric acid or the composition is such that you want to do evaluation, or if there is an anatomic abnormality. As I mentioned, PUJ obstruction, if the patient is forming a stone, the reason is probably metabolic abnormality. Okay, so in those patients as well. So there are things, I think the time is only 3 minutes left. So I'll skip all these things and tell you something about the management. So you need to increase the fluid intake. Typically, these patients of a stone disease, they consume less water. So you need to increase the water intake. बच्चा कब ग्रो करता है? जब पैदा होता है और बड़ा हो रहा होता है. किस समय ग्रो करता है? जब वो सो रहा होता है ना. तो उसी तरह से स्टोन भी तभी बनता है जब व्यक्ति सो रहा होता है. स्टेसिस, आप लेटे हुए हो, 8 घंटे की स्लीप है, 7 आवर्स व्हाटएवर. सो स्टेसिस ज़्यादा होती है और न्यूक्लिएशन, ये सब चीज़ें ज़्यादा होती हैं व्हेन यू आर स्लीपिंग. सो आप बोलो उसको कि सोने के पहले पानी पी लो, ठीक है, ताकि एक बार यूरिन के लिए नींद खुले आपकी. ठीक है. सो द हाइड्रेशन हैज़ टू बी डिस्ट्रीब्यूटेड इवनली थ्रू आउट द डे. ओके. So citrus fruits, because they contain citrate, you have to increase because it's a inhibitor of nucleation and growth. And these are the various options. I'll quickly tell you ESWL, we have this machine here. It's a fantastic thing, small stones. You know, it's totally non-invasive. The patient lies down, it's done under local anesthesia, the patient is awake, just lying down for about half an hour to 45 minutes. And you know, the rays comes, fragment the stones, and they pass off. Very, very good treatment, but it is effective for small stones. So there are certain advantages, disadvantages. I don't think I have time for that. This is one patient of the stone is located in the renal pelvis. It's not that opaque. I don't know the Hounsfield value, but it doesn't look too white. ठीक है, contrast से तो हल्का ही है. ठीक है. This is after the first sitting, this is after some time, maybe after the second sitting, and then it has cleared completely. Okay. So it's a very good treatment, I must say. Then percutaneous nephrolithotomy. Why this image is like this? You see the buttocks and not the front of the patient. It's the back of the patient, not the front. Why? Because it is done in prone position. The kidneys are located in the retroperitoneum, it's in the back. Okay, so today we do PCNL in supine position as well, but typically the standard method of doing PCNL is in the prone position, and very effective. Every day I think 2 or 3 patients are they undergo PCNL in our department, and residents do it. Okay, so it's a very common procedure. This is the instrument. You have to dilate the tract, create a tract. You can use metallic dilators or Teflon dilators, and this is how the endoscope looks like. This is how it is done. The patient is prone. You see the system. You do a retrograde study. You can see a uretral catheter. This is passed by cystoscopy. You see the system, make a puncture, and you see the stone, fragment it and take it out. Okay, very good treatment. Then you have, because now as I said, we are doing supine PCNL as well. So in patients who have a complex stone, you want to avoid multiple sittings of PCNL. What you can do, you can combine. There are 2 trolleys, 2 urologists. One passes a flexible ureteroscope into the kidney, the other does PCNL simultaneously. Okay, so this is what is called ECIRS, endoscopic combined intrarenal surgery. So you have a flexible ureteroscope passed from below and PCNL, okay, going simultaneously. So there are certain advantages. I'll just, bhaiya fix ho gaya kya? Okay. This is not moving. Acha, yeah. So you can do it by open surgery as well. In those scenario, if the patient is having simultaneous PUJ obstruction as well, आपको 2 surgery करनी है, stone भी निकालना है और जैसा वो था X-ray, PUJ obstruction भी है, पाइलोप्लास्टी भी करनी है, तो लैप्रोस्कोपी से पाइलोप्लास्टी कर दीजिए, स्टोन भी निकाल दीजिए या ओपन सर्जरी कर दीजिए. ठीक है, ओपन, ये दिस इज पाइलोलिथोटमी. हाँ, पाइलोलिथोटमी है. ये एनाट्रोडल लाइन से जाते हैं. एनाट्रोफिक के क्या मतलब है? देखो इसको पढ़ो, देखो क्या लिखा है. Second line, incision is made along the avascular plane of Brodel. ये रीनल आर्टरी के 2 डिवीजन होते हैं, एंटीरियर पोस्टीरियर. ठीक है, तो इन दोनों के बीच में है ना, क्रॉसओवर नहीं होता है, देयर इज नो एनास्टोमोसिस. ठीक है, कोई क्रॉसओवर नहीं है, तो ये क्लियर कट लाइन होती है, ब्रोडल लाइन कहते हैं. एनाट्रोफिक वर्ड का क्या ओरिजिन है? एट्रोफी एक तो है, एट्रोफी के मतलब खराब हो जाना. ठीक है, इसमें रीनल आर्टरी क्लैम्प करनी. आप किडनी में इंसिजन दे रहे हो तो रीनल आर्टरी को क्लैम्प करते हैं. ठीक है, तो आर्टरी को क्लैम्प करके आइस लगाते हैं. ये एक वर्टिकल वो इंसिजन है अलोंग द ब्रोडल लाइन. यू टेक आउट द स्टोन एंड देन यू क्लोज इट. ठीक है, ये इस तरह के का, क्योंकि पीसीएनएल में क्या है, इन स्टोन्स के लिए आपको सेपरेट पंक्चर करने पड़ेंगे. When you do PCNL, you have to, for taking out these stones, so the patient will have to undergo multiple surgeries. PCNL कई बार होगा, multi stage होगा. ठीक है, तो इसमें जो है, but still you see after doing all this exercise ये वाला पत्थर छूट गया. एनाट्रोफिक के मतलब ये होता है कि एट्रोफी ना हो. एनाट्रोफिक, किडनी की एट्रोफी ना हो, ऐसी जगह इंसिजन दिया. ठीक है, कि एट्रोफी नहीं हो ब्रोडल लाइन. ठीक है, इसका नाम का ओरिजिन ये है. चलिए, आई थिंक आई विल स्टॉप हियर बिकॉज इट्स ऑलरेडी टाइम इज ओवर. सो इफ देयर इज एनी क्विक क्वेश्चन आई विल बी हैप्पी टू आंसर. चलो, थैंक यू.
We are grateful for such an extremely academic presentation. Now I would like to invite Professor H.S. Pava sir to kindly felicitate Dr. Apul Goyal sir. Now I would like to invite Dr. Manoj Yadav sir, Professor, Department of Urology, to give his presentation and talk on the topic common radiographs in urology.
A very good afternoon to everyone. I did also my MS from here, MCH from KGMU. So this is a very good feeling to come here. Because my topic was after this, after Ansman. So sir has told you about the treatment. So I would like to discuss the common radiographs which is required for your day-to-day practice, as well as it will also be asked you during your MS examination. So myself, Dr. Manoj, I am professor in urology department, KGMU. So basically, urological surgeries are elective surgeries except urinary retention, hematuria, or any emergency renal trauma. So we have to select the patient, select the modality, and select a roadmap how we will treat the patient, how will we deal the patient. Like malignancy, we have to go for a CT scan. So I am basically, the topic given to me was the basic radiograph. So I will be discussing about the this plain X-ray KUB, IVU, RGU, cystograms, and some films of the CT scan. What is the difference between this X-ray and CT? X-ray is a linear film where you can see a two-dimensional, but in CT scan you can have a cross section. When CT scan was not there, then IVU, we used to do surgeries, or we used to diagnose the patient on the basis of these radiographs and some contrast studies. What is the role of contrast? Because we have to check the anatomy of the bilateral kidneys, ureters, and urinary bladder along with their functions. So both things can come simultaneously with serial pictures. Previously our teachers used to say, when CT scan was not there, they do a chain cystogram to diagnose a urinary bladder tumor. So it was a tedious job. Sir has said IVU, it requires 2 days because bowel preparation is required. So everybody knows physics is there. There is a X-ray emitter and there is a cassette where these photons will emit from the X-ray tube, and they will cast a picture, and this can be formed in a form of an image. Contrast media, as all you know, mostly we use for the IV is the low osmolar non-ionic. So most commonly used is the iohexol for this CT scan and IVU, and for this this lupogram and another bowel pathologies which we give through the oral route are the high osmolar. So I think during surgery you are more aware of it. How this kidney handles this contrast? Basically what we want a pelvic calyceal, because urologists, they mostly deal with the pelvic calyceal system, either the stone disease, stricture, PUJ. So mostly we are on the pelvic calyceal system side. So we have to know the anatomy of the pelvic calyceal system and function of the kidney. And nephrologists, they used to treat the parenchymal diseases. So 3 phases are there. First is the vascular, when we inject the contrast. The volume of the contrast which has been given in IVU is 1 ml per kg body weight of the patient. So this much of the non-ionic contrast has to be given. It will concentrate in the renal parenchyma, that is the nephrographic phase, and then the kidney, if it is functional, if function is more than 20%, then it will excrete this contrast to the pelvic calyceal system, and we can delineate the pelvic calyceal system more efficiently. One emergency situation when this CT scan was not everywhere present was the treatment for going for the traumatic kidney going for nephrectomy. We have to do a static IVU film, so that we can know the other status of the other kidney as well as the function of the kidney. Suppose there is trauma on the left side and right kidney is absent, and we did a nephrectomy on that side, then patient will be anephric, and he requires this dialysis, as well as the negligence can also be on your part. So for that we do a single film, we double the dose of contrast, that is 2 ml per kg body weight has to be given. A static film has been taken, we saw other kidney is functional, then we can go for a nephrectomy for a patient who is in shock and severe hematuria. So this is the emergency indication of IVU in emergency situation. Now IVU, you will always see a plain film or scout film. What it means, scouts, previously scouts were made to evaluate the ground. Whenever anyone is coming, they used to see the ground, what are the loopholes of that ground, what is the status. So plain film is required before any contrast study. Even for the CT scan, you will see a non-contrast NCCT along with the contrast study, because we have to compare what is the pathology on the plain film, what we saw, is it in the contrast film or not. So plain film is required. Second, we can see the status of the bones, ribs, spine, pelvis, or the ischium and ilium bones also. Sometimes we can also find the shadow of the kidney in a good KUB plain film, and we can also see the status of the Schwann muscle, is it bulky. Sometimes in a Schwann sepsis you can see there is some haziness in the Schwann. So we have to be careful in watching the film. Then look for the pathology. Suppose a ultrasound patient is coming to you with an ultrasound, there is a radiodense said there is a calculus in the ultrasound on left kidney, but we are not able, we have to confirm it on the radiograph. So then we will look for the any pathology like this. Here you can see in a first film, this is 11th and 12th rib, spine, pelvis, everything is fine. Now we can see this is the contour of the right kidney, yeah, little bit visible, and there is a radio opaque shadow in the right renal area. We cannot say on a plain that it is inside the pelvis, calyx or some. So we have to say there is a radio opaque shadow in the right renal area. Along with, you can see these are the bowel gases, which is tedious to study, to read a plain X-ray or IVU. So that's why CT scan is quick and easy, but IVU give many advantages. I will show you in the next film. Now here you can say there is some radio opaque shadow in the pelvic region. Most probably organ is here, either rectum or the urinary bladder. Another film, this is the radio opaque shadow in the right renal area. Basically it's a double J stent. Along with, you can see a faint radio opaque shadow in the left renal area. I am not saying it's a renal pelvis, but I know it is in the renal pelvis, but what you have to say, it's a radio opaque shadow present in the left renal area, and along with some crustaceans, probably it's a forgotten DJ stent. Now what is the limitation of the ultrasound? Because due to the bowel, we cannot see the mid ureteric stones, which are mostly traverses through the upper SI joint to the lower SI joint. So for that, either CT scan, or if it is a radio opaque densely calcium based stone, we can see it on X-ray. So we have to confirm it on X-ray. So plain film, we can see there is a radio opaque shadow in the mid ureter. Now we have to confirm these findings in some other films. This is basically a picture of nephrocalcinosis, because there is not a definitive shape. These are also not the secondary stones of PUJ. So this is a typical picture of the nephrocalcinosis, and DJ stent has been placed by somebody else because either creatinine was raised or something else. This is the typical picture you will see in the picture. Can you guess it? It's a putty kidney, commonly found in GUTV. Now coming to the IVU, intravenous urography, intravenous pylography. First and foremost, we have to check the renal function of the patients, because contrast cannot excrete in a patient who is having deranged renal creatinine, and it can also induce it can also cause CIN, that is the contrast induced nephropathy. So first of all we have to check the renal function, then we can go for this IVU. 1 ml per body weight of the patient or the individual, we have to inject the contrast, and we take serial films. So this is the plain film. What we see, there is a radio opaque shadow in the right renal area, and the spine is normal, no abnormality. These are the two ribs are seen, because relation of these ribs is required during percutaneous nephrolithotomy along with pyelolithotomy. You say I will not do a PCNL, but you will do a pyelolithotomy, na? So this relation is required, so that how you will decide how to open the how to reach the kidney, how you will get the stone. Suppose you are going for a pyelolithotomy, you give a subcostal incision and you are not able to reach the stone. So draw a line from the mid of the stone. If it intersects the rib, either 11th or 12th, go through that rib in a flank position. So plain film can also decide what kind of incision in your open surgery you will require. This is a typical normal IVU picture. These are both the kidneys, superior calyx, this is middle calyx, and this is lower calyx. This is renal pelvis, and contrast is simultaneously normally excreting, and it is filling the urinary bladder, and urinary bladder contour is also normal. So it's a normal IVU picture. Now this film has to be confirmed on contrast film. So see, this is the bowel shadow. As sir has said, this is basically disturbing. We are not able to diagnose where is the radio opaque shadow. So a good bowel preparation is required before doing a IVU. And you can see there is a radio opaque shadow in the left renal area. So now we will confirm by giving contrast. The right, as a dictum in exam, just say read the first the right normal thing. So right kidney, normal opacification of the pelvic calyceal system and ureter, and right side there is hold up of the contrast, and some delineation of the calyxes has been started. Now coming in a 10th minute, right kidney normal, left side some more opacification or pooling of the contrast is seen, but there is no opacification of the contrast. So here there is obstructing stone in the renal pelvis. Probably, we cannot say, but we can assume it some obstructive pathology is there. Now after the another film, we can find there is a stone in the renal pelvis. Now the ureter has been delineated. So here this is the lower calyx, these are the calyxes, and this is the superior calyx. So how we will diagnose? So now diagnosis is bilateral normal functioning kidney along with the left renal pelvic stone. So this is the diagnosis of this. No bony abnormality is required, is seen. Another is after hysterectomy or a difficult pelvic surgery, most of the patients land up in emergency with inuria. Now and deranged renal function. First of all, we do a bilateral percutaneous nephrostomy like liver abscess, and we drain the urine, we settle the patients, settles the metabolic acidosis, and then we will go for an antegrade contrast study in such kind of patients. So this antegrade contrast has been given to the patient and given to the bilateral kidneys, and we will see on left side there is patency, but right side there is stricture. So it's a right sided ureteric stricture. Cause can be anyone, because I have not given you history, just assume it's a post hysterectomy or post pelvic surgery. So it's a kind of right ureteric stricture, and you can also see the extent. It is up to the mid ureter. Now we have to choose the treatment. Either we go for a ureteric reimplantation or a Boary flap formation. It is beyond you. So it's a antegrade contrast study showing the right ureteral stricture. Another is, this is a long weighted right sided ureteric obstruction. So we did a nephrostomy. It also says what is the function of the kidney. It also drains the pus in the system, and we also use for the antegrade contrast study or its nephrostogram. So there is also a right sided ureteric stricture. So this is the diagnosis in antegrade dye study. Any patients coming with the urethral pathology like thinning of the urinary stream, history of catheterization, history of trauma, or pus discharge from the urethra, previously it was TD, and there is thinning of urinary stream, you are suspecting there is a stricture or something traumatic to the urethra. So first of all, for any contrast study in urethra, the sterility of the urine culture is required. If it is not there, put a SPC and do a culture sterile through antibiotics and go for retrograde urethrogram. This is the commonly picture you have seen. This male urethra has penile part which starts from the meatus to the penoscrotal junction, then the bulbar urethra, it reaches up to the membranous urethra. Membranous urethra is the shortest part of the male urethra, and after that the prostatic urethra and bladder neck. So this is the normal. Here you can see contrast is being given. Why it is retrograde? Because contrast is given through the meatus and going up to the urinary bladder. So it's a normal retrograde urethrogram study. Now, patient coming with the thinning of the urinary stream, first of all we have to scout a plain film, then you can see retrogradely contrast is given, normal density of the anterior urethra, but there is something. What is it? It is a stricture, there is a narrowing, you can say a narrowing. So it's a bulbar urethral stricture. So we have to plan according to the our literature what it says. So it's a bulbar urethral stricture. Another is post traumatic, there is complete obliteration of the urethra, bone is normal, and there is complete blockade at the this bulbar urethral region, and this is the cystogram which shows there is complete cutoff at the membranous. So it's a bulbomembranous or a straddle injury to the urethra. Now these are the some common pictures. Cystogram to see the outline of the urinary bladder pathology. Some common pictures quickly. This is PUB because posterior urethra is dilated. Another is, this is reflux. You have seen grade 5 reflux on the right side along with dilatation of the posterior urethra. So it's a case of posterior urethral valve with reflux. थोड़ा सा चला दो. This is typical picture of GUTV, thimble bladder, है ना? It's a thimble bladder, small bladder having both the ureters. It's a picture for tertiary appearance in neurogenic bladder. Now coming to the CT scan, as sir has shown, bilateral pelvic stones. How the CT scan shows the stones. This is right-sided PUJ obstruction, and this is a case of renal trauma. This is subcapsular hematoma, and this is grade 5 renal injury. So where the cross-section study is required. Thank you so much for your kind listening. Any questions?
Thank you so much, sir, for this highly insightful and enriching lecture. Now I would like to call upon stage Professor J.K. Kushwaha, sir, to kindly come and felicitate, sir. Continuing in the line, I would like to invite Dr. Anshuman Singh, sir, to give his talk on the topic penile carcinoma, nodes, staging and surgery.
ऊपर वाला हाँ ठीक ठीक.
afternoon, everyone. It is a privilege for me to be here because I also did my MS from this very department. So, starting with the diagnosis, staging, and management of carcinoma penis. So, it's an important topic even for the MS general surgery residents because it can come as a short case for you all. What I would request you is stop writing anything because everything is there in the slide. You can keep the slide, take a handout, just focus on listening because every aspect of the treatment diagnosis is covered in the slides. That is why the slides are a bit busy. So, focus on listening. So, we will be covering the topic in the typical Love and Bailey approach like etiology, risk factors, moving to diagnosis, the tumor management, the nodal management, and then the follow up strategy. So, overall globally it is not a very popular cancer, not the very prevalent cancers, but the problem with India is India significantly contributes to the global burden of the disease. The reason being that the awareness with respect to penile health is lacking in most parts of India. That is why, as we can see that in the developed nations the incidence of the malignancy is lesser, but India is among the top 5 to 10 countries in which the global prevalence is higher. So, the most common decade is the 6th decade, that is age 50 and plus, and recently the HPV prevalence in the cancer is on the rise, so that the non-HPV related cases are on a decline. So, mainly there are 3 risk factors for the development of this cancer. The first and the foremost is HPV infection during childhood or adolescence. The second is chronic inflammation in form of either phimosis, chronic infections, or lichen sclerosis. So, these are the 2 main categories which contribute to most of the cancers. There are other certain risk factors like smoking, phototherapy or radiation of any kind to the penis which may lead to the development. So, as we can see the risk factors, similarly there are certain protective factors which may help in preventing the diagnosis in future, that is neonatal circumcision and HPV vaccination during adolescence. So, most commonly the disease presents as a palpable non-healing lesion on the glans or prepuce. The lesion can have 3 to 4 morphological types, as you can see, ulcerative, exophytic, flat plaque like as in carcinoma in situ, or varicose as you all have seen in oral cancers. So, similar because the predominant histopathological subtype is squamous cell carcinoma, the presentation also is in a similar manner. So, moving on to the physical examination is not complete without a complete groin examination. So, it includes a penile examination along with bilateral groins, because the nodal metastasis from the penis happens first in the groin lymph nodes and then moves on to the systemic nodes, systemic organs. So, the complete examination consists of a penile examination and bilateral groin examination, and you have to document the entire characteristics of the penile lesion as well as the groin lymph nodes. In many cases, this is an important point, that in many cases phimosis may obscure the primary lesion in about 25 to 50% cases, because phimosis is one of the risk factors. So, in those cases a dorsal slit or a formal circumcision is mandatory for a complete assessment of the penile lesion. So, the diagnostic workup is very straightforward, that after a complete history and physical examination we move on to the penile biopsy. So, one thing important for you to understand is any ulcerative or proliferative or chronic indurated area over the penis is to be considered malignant until proven otherwise. So, if physical examination is suspicious for any penile malignancy, the next step is a mandatory biopsy. The biopsy helps us to know, to confirm the diagnosis, and then to ascertain certain features in the diagnosis which helps us to prognosticate. So, the pathology report, whenever you are sending the biopsy, you should check the pathology report that it should contain all the parameters that should be there in a proper pathology report, that is the histological subtype, whether it is squamous cell carcinoma, usual type, basaloid type, warty type, whatever it is, then the differentiation, that is the grading of the tumor, the invasion status, that is LVI, PNI is positive or negative, and HPV status, which does not come normally, but you have to ask for a specific IHC, that is P16, to get the HPV status. So, these are important parameters because everything helps us in prognosticating the tumor. Then coming to imaging that is required for staging. So, there are 2 sets of imaging, that is one for ascertaining the local stage, that is the tumor stage, that is the T stage, and the N and M stage. So, we will be coming to it later. that the imaging is required for two certain reasons, and there are certain sets of imaging that is there for a particular indication. So coming to the pathological subtypes, the most common type is squamous cell carcinoma, that is 95% of all the penile malignancies. Out of that, most common, more than 50 to 60% SCCs are the usual type SCCs. The rest, the rarer types are basaloid, warty or verrucous types. So every subtype has its own maybe a more aggressive or a lesser aggressive variant, but the most aggressive that you should understand is the sarcomatoid, and luckily it is the rarest. So verrucous is the most kind of having a benign course, it is being a malignancy, but it is mainly a locally invasive but does not have metastatic potential. So this is the, you can see here the key prognostic factors are the tumor grade, depth of invasion, the lymphovascular invasion, perineural invasion, and the margin status. So coming to the imaging that I told, that there are two sets of imaging. One is for local staging, that is the T stage. The other set is for the N and M stage. So for local staging, if the diagnosis is in doubt, that we are not sure about the urethral invasion, we are not sure whether it is involving the corpus spongiosum or the cavernosum, then we can do an MRI of the penis with erection so as to ascertain the local T stage and the urethral invasion. So the role of MRI is mainly for the primary tumor stage, that is the T stage. When it comes to the nodal assessment, we need to see whether nodes are there in the pelvic region or systemic metastasis. So distant mets and inguinal nodes and pelvic nodes are better seen with a CT scan or a PET scan. High resolution ultrasound has a specific role in case we feel that there is any palpable node in the groin region, whether it is mobile or fixed. We should get an guided FNSE to ascertain whether it is infective or malignant. So that helps in the staging of the nodes. So beyond that, any imaging is not having any role in the other setting, that we cannot do an MRI for the distant metastatic workup, we cannot do a CT for the local staging. So for local staging, MRI has to be done. For distant metastatic workup, CT or PET CT has to be done. So this is the TNM classification. You all must be knowing. You can refer to it later on. I will not go into the details. So coming to the prognostic factors, the most important, the critical prognostic factor that affects the survival is the nodal status. It is not the primary tumor status, it is the nodal status that affects the
loss or early satiety. Patient underwent hemorrhoidectomy 3 years ago at a private clinic and also underwent diversion of sac of for left hydrocele under local anesthesia 6 years ago. Patient has a history of anti-tubercular drug intake for 1 year at 6 years of age for a diagnosis of pulmonary COX. He also had one episode of blood transfusion for anemia at 6 years of age. No documentation was available for the same. There is no history of any other comorbidities. The patient has 2 siblings all in good health, and there is no history of any similar illness in family members. The patient consumes mixed diet with normal bladder bowel habits, has normal sleep pattern, has no history of any substance abuse and no known allergies. He is educated till 12th standard and is a power loom operator by occupation. On general examination, the patient was conscious, cooperative and well oriented to time, place and person. Yes. So my history is of a 34-year-old unmarried male presenting to us with a left upper abdominal lump for the past 2 years, which is insidious in onset, gradually progressive, associated with mild aching pain. He also had one history of hematemesis 2 years ago, for which he underwent medical treatment and did not undergo any further endoscopy. The patient has a positive history of anti-tubercular drug intake at 6 years of age. Coming to the general examination of the patient, the vitals of the patient are as follows. The patient was afebrile with a pulse of 96 beats per minute in the right radial artery, blood pressure of 140/68 millimeters of mercury in the right arm, supine position, with a respiratory rate of 16 per minute. Pallor was present, although there was no icterus, clubbing, cyanosis, generalized lymphadenopathy or pedal edema. On head-to-toe examination, we found no stigmata of CLD or thalassemia, no evidence of any bruises or ecchymosis on dependent parts. The patient weighed 49 kgs with a height of 165 centimeter with the BMI approximating 18 kilograms per meter square. Coming to the per abdominal examination, we can see a left upper abdominal fullness in the patient. A swelling of size approximately 22 cross 24 centimeter can be seen in the left hypochondrium, extending midly to the epigastric region, inferior to the umbilical and left and right lumbar region, extending beyond the umbilicus along the left spino-umbilical line. The umbilicus is inverted and shifted inferiorly. The swelling appears to move with respiration. The skin overlying the swelling appears to be normal. There are no scars, pigmentation, pulsations, peristalsis or any engorged veins. My inspectory findings were confirmed on palpation. There was no local rise in temperature or no tenderness. A palpable intra-abdominal lump in the left hypochondrium, epigastric left and right lumbar region and umbilical region measuring 24 cross 22 centimeter in size with smooth surface, well-defined margins. The upper border of the lump was not palpable and we could not insinuate our fingers below the left costal margin. The lump was firm in consistency, moving with respiration and non-ballotable. No other lumps or organomegaly was noted. Bilateral leader angles were non-tender and the spine was within normal limits. Coming to the percussion, a dull note was present over the lump, a tympanic note was heard over all other regions. The liver span along the mid-clavicular line was 14 centimeter. Shifting dullness was absent and dullness was present over top space and Castle's point. On auscultation, normal bowel sounds were heard. Excuse me. On per-rectal examination, the perianal skin was normal. There was no evidence of any excoriation or fissures or no evidence of any mass coming out per rectum. On palpation, the mucosa was normal and no bile. No palpable growth or swelling was present, and fecal staining of the glove finger was present with no blood staining. External genitalia were within normal limits. On proctoscopy, we did not find any evidence of hemorrhoids or rectal varices throughout the mucosa visualized. Systemic examination was within normal limits. Central nervous system was, the higher mental functions were intact with no focal neurosurgical deficits. Cardiovascular and respiratory systems were intact. Summarizing my case, it is of a 35-year-old male with a progressive left upper abdominal lump with dull aching dragging sensations with one episode of hematemesis and PR bleeding with pallor. And on examination, there is a 22 cross 24 centimeter intra-abdominal lump extending from the left costal margin towards the right flank region beyond umbilicus, moving with respiration, which is non-ballotable with inability to insinuate fingers under the left costal margin. Moving onwards, my provisional diagnosis for this case is that of massive splenomegaly with portal hypertension. Etiology remains to be evaluated. My differentials include tropical splenomegaly syndrome, splenic tuberculosis, and myelofibrosis.
Well presented. On palpation, you mentioned the lump is 24 into 22 centimeter.
Yes.
All the margins are clear.
No, so the upper border was not palpable.
No, that is what not mentioned. You stated that all around that is regular margins, whereas the superior you cannot approach the subcostal margin. So there is controversy.
What is the cardinal features of the splenomegaly?
Sir, a splenic lump is one arising from the left hypochondrium, goes towards the umbilicus. It is non-valotable with inability to insinuate fingers below the left causal margin. We may palpate a splenic notch over the superior anterosuperior border, and the lump moves with respiration.
Which directions?
Sir, vertically, sir. It moves vertically with respiration.
What is the position of the spleen?
Sir, I didn't get the question.
It is upside down. Position of the spleen. It moves obliquely,
Yeah.
not up and down,
Yes.
toward the opposite iliac fossa. Is there any perrectal findings of the previous surgery? You said that there the hemorrhoidectomy is done.
So the patient had no documentation regarding the same. We could not find any significant findings on proctoscopy. He told us he underwent a hemorrhoidectomy at a private clinic outside. No, sir, no history of any melena, sir. The patient had just one episode of hematitis.
Inspection findings.
Why do you say it has portal hypertension?
So, I'm saying portal hypertension because one, the patient is a young male. Second, the patient has one episode of hematemesis, and a massive spleen with hematemesis points me towards portal hypertension. The
I suppose massive splenomegaly, you have clear-cut Kala-Azar,
Yes,
CML.
sir. Yes, sir.
In portal hypertension, you never get that big spleen, right? Plus, single episode of hematemesis you are talking about.
Yes, sir.
There are no other features of portal hypertension? Any
No.
ascites?
No, sir. The no ascites clinically.
Then, why portal hypertension?
So the patient does not have any constitutional symptoms suggestive of Kala-Azar or a tropical.
What are the constitutional symptoms of Kala-Azar?
Sir, hyperpigmentation, recurrent fever, weight loss. The patient has none of those complaints.
The patient may have some hemolytic anemia. He presented with one episode of hematemesis. Why go in for portal hypertension?
What was the point we were in favor of portal hypertension? Just enumerate.
So first the young age of the patient. The second is the patient had hematemesis and
Single
possibly
episode.
Single episodes. That works in both in favor and against for my case.
No caput?
No caput medicine.
Then why portal hypertension?
There is no doubt that it is a massive splenomegaly.
Yes, sir.
But you have to discuss a thing in favor of portal hypertension, against portal hypertension, or any other possibility which may lead to massive
So the other causes, so the patient does not have any symptoms of the common other causes, sir. In case of autoimmune hemolytic anemia, the patient has no dark colored urine or hemoglobinuria in his complaints. And so the patient just has pallor that might be due to of such a large, and so constitute symptoms suggestive of CML or polycythemia vera or myelofibrosis, which may present with recurrent fever, bleeding diastasis are not seen in this patient. He might have those in the future if he has those complaints, but since the patient presented to us with a history of two, keep those in my differential diagnosis.
Yes, you are presenting well, don't be nervous. You are presenting very well, but you don't be biased about the associated portal hypertension. The question in history is, he is power loom worker.
Yes, sir.
Would you correlate in some way with the present presentation of splenomegaly? Number one. The question number 2 is, have you done upper GI endoscopy for history of hematemesis?
Yes, sir. So patient has undergone an upper GI endoscopy. The findings are ahead, sir.
Mention. Yes, yes, sir.
Yes, sir. So the patient underwent routine blood examination with a hemoglobin of 0.98 grams per deciliter. Total count of 1,530 cells per microliter with monocytosis. A platelet count of 21,610 platelets per microliter with a elevated PTINR of 1.65. Viral markers were non-reactive. Rest LFT was within normal limits, and RFT was also within normal limits. Subsequently, the patient underwent a USG whole abdomen with a CDHPVS, in which the liver was 15.15 centimeter in size with altered decotect. The spleen measured 27.1 centimeter, tiny hypoechoic foci in the parenchyma, suggestive of gamma gandis. The main portal vein could not visualize with multiple venovenous collaterals around it, suggestive of cavernoma formation, which was suggestive of extrahepatic portal venous obstruction. Evidence of any free or localized peritoneal collection in the form of fasciitis, and the hepatic artery was patent. The patient underwent an MRI abdomen outside, which had the findings as follows: with gross splenomegaly extending up to the left and right iliac fossa, causing significant mass effect, displacing the bowel loops and the pancreas to the right, and causing compression of the left kidney. We also found multiple hypointense areas within the spleen, likely representing lymphomatous infiltration or granulomatous lesions or healed infarcts. The splenic vein was dilated with no evidence of any thrombi of diameter 14 mm. The patient also underwent a GBP-RC with the presentation being as follows: with anisocytosis, microcytosis, hypochromasia, few cystocytes, suggestive of microcytic hypochromic anemia with query pancytopenia. The patient also underwent an upper GI endoscopy, in which the Department of Gastroenterology found one column of grade 2 esophageal varices and two columns of grade 1 esophageal varices with no evidence of any active bleeding. They also found a mosaic pattern of gastric mucosa suggestive of portal gastropathy with congestive and hemorrhagic spots. The patient had a malaria card antigen test done, which was non-reactive. Kala Azar via RK39 card test was also non-reactive. Direct Coombs test also came out to be negative. Serum IgM was slightly elevated. My final diagnosis after investigations is portal hypertension due to extrahepatic portal venous obstruction with massive splenomegaly with pancytopenia. The plan is to go ahead with a bone marrow aspiration. I would also like to go ahead with a fibroscan. I haven't mentioned it here, sir, because the patient has undergone no other evaluation for his liver apart from the USG CDHPVS. And if conditions are right, so we'll go for a splenectomy with or without shunt surgery.
If your diagnosis is portal hypertension, you should write the CTP criteria. What is the CTP grade?
So this patient falls under child CTP grade A, sir. The patient has no ascites with the serum albumin of 3.2, just the INR is deranged.
For interest of all the residents, just enumerate the child's criteria for the audience in details.
I'm sorry, sir, I don't recall the details right now.
What is the left-sided portal hypertension?
I'm sorry, sir?
Left-sided portal hypertension.
Sir, left-sided portal hypertension is portal hypertension seen with isolated esophageal varices, specifically due to portosystemic shunting between the left gastric vein and the splenic vein.
what is the treatment difference between the left-sided portal hypertension and EHPVO?
Sir, a left-sided portal hypertension sir, usually presents with acute variceal bleeding. So my first line of management will be to manage the varices to go forward with the banding. The patient may or may not need a splenectomy based on the response. And if the patient presents with an acute variceal bleed, we might not go for a straight ahead splenectomy. We must go for any shunting procedures like a TIPS.
TIPS is not involved in here. If you are a child book class A,
yes, sir.
TIPS is no questions. Okay. But if they are the left-sided hypertension, that if you are tackle the esophageal varices, then treatment is only splenectomy. Understand?
Yes.
No shunt surgery is required. But here there the EHPVO is there. There are some pressure difference is always there. It needs the shunt surgery. What are the various type of shunt surgery? You know?
So there are non-selective shunt surgeries, selective shunt surgeries, physiological shunt surgeries, and TIPS. So non-selective shunt surgeries are mostly of historical origin. They include shunting the superior mesenteric vein into the portal vein or the splenic vein directly into the portal vein, also known as portocaval or mesocaval shunts. So selective shunts or distal shunts are one shunting the splenic vein into the left renal vein. So that is the most commonly performed in our institute, known as the Warren shunt. Apart from that, sir, there exists a physiological shunt known as the Rex shunt, which shunts the splenic vein into the intrahepatic part of the portal vein. The part of the portal vein within the Rex recess, which we usually perform in children with EHPVO. And so TIPS is always a radiologically guided non-surgical shunting procedure, shunting the hepatic vein and the portal vein.
What is the indication of TIPS?
So TIPS is usually performed as an emergency procedure for acute variceal bleeding. It may also be done as a bridge procedure towards surgery for patients with Budd-Chiari syndrome or post-hepatic portal venous obstruction.
This type of patient comes in the emergency later on and develop the massive hematemesis. What is your approach to management?
So the first line for any massive hematemesis is to assess the vitals of the patient. If the patient is in shock, my first priority would be to resuscitate the patient immediately with fluids and blood products. Once the patient is stable enough to undergo an endoscopy, we'll go for an emergency endoscopic variceal banding. If that is not possible, we'll apart from that, we can start medical therapy in the form of octreotide and terlipressin. Following this, if the patient is still not stable enough, we'll go for a DSA guided TIPS procedure to shunt the hepatic vein into the portal vein.
What are the causes of EHPVO?
Sir, EHPVO has multiple causes, the most common of which is neonatal sepsis and umbilical vein catheterization at a very young age. Although the most common cause of EHPVO is considered to be idiopathic. Earlier there used to be a idiopathic EHP, I'm sorry sir, multiple coagulopathies like antithrombin 3 deficiency, protein C or S deficiencies, factor 5 lead-in mutations also contribute to EHPVO. Any prothrombotic state may lead to EHPVO.
Inflammatory infectious causes?
Sir, infective causes I mentioned neonatal sepsis. I do not recall about inflammatory causes.
Very common case presenting to the surgical emergency or medical emergency. Pancreatitis?
Yes, sir, pancreatitis.
That is very common. Leads to portal vein thrombosis, splenic vein thrombosis, and then it progresses.
In case of emergency, how will you manage a massive upper GI bleeding? Facility of that upper GI endoscopy or anything?
Sir, in such a situation, sir, we can first is again, sir, resuscitating the patient with blood and blood products. Then is to go for a gastric lavage with ice cold water. Then we can use balloon tamponage to stop the bleeding. We can use a sense taken Blakemore tube.
You don't find mostly that sense. And if you don't have, then what can you use? For For academic purpose only.
Sir, a Bakri balloon catheter can be used.
Yeah, Foley's.
A Foley, yes.
What is the common cause of lower GI bleeding? Most common cause of lower GI bleeding?
Sir, in an adult male, it is diverticulosis.
It is the upper GI bleeding which is the most common cause was the lower GI bleeding. If patient come with the lower GI bleeding, firstly rule out the upper GI bleeding, then you go for the. In this patient, would you like to do the colonoscopy also to rule out the other portal?
Sir, I would like to go for a colonoscopy in this patient just in case the patient has any rectal varices lying high up, because my proctoscope can only visualize up till 6 centimeters and rectal varices may be usually higher.
What are the various sites for the portosystemic junctions you look for during your clinical examinations?
Sir, portosystemic collaterals exist at multiple places, first being the lower esophagus, where the shunting occurs between the left gastric vein. Apart from that, sir, there is one in the bare area of the liver which is not clinically appreciable. So clinically appreciable one is the one in the rectal varices between the superior rectal vein and the inferior and middle rectal veins, and the paraumbilical region between the paraumbilical veins and superficial epigastric vein. Apart from that, so there are also retroperitoneal collaterals between the colic veins and the lumbar veins.
Suppose this patient is planned for the surgery and ultrasound report shows there the portal cavernoma, huge portal cavernoma.
Yes.
What are the problems during the surgery and how to manage it?
So the major problem we'll encounter during surgery is extensive bleeding. Anywhere we touch the patient will lead to torrential bleeding. So the hemostasis of the patient is paramount in this case. To tackle this, sir, initially we can go for with a medical management to lower portal hypertension. We can start with non-selective beta blockers. We can use propranolol or carvedilol. Then follow. There are no specific recommendations on when to start, but our Department of Gastroenterology recommends starting it at least 2 weeks before surgery. We can, yes, intraoperatively, sir, we have to be careful.
Most important thing. What about the consent of the surgery?
Sir,
such patient, if there is the portal cavernoma, huge portal cavernoma all over.
So the consent of the surgery will include splenectomy, the possibility of a shunting, coming first to the complications, we'll have to inform the patient that there is a risk of torrential bleed which may not respond and the patient may die on table. So DOT consent is must before going forward with the surgery, followed by an ICU consent and a venti backup consent. Coming to the post-surgical complications, sir, we have to take in account post-splenectomy bleeding and overwhelming post-splenectomy infection or OPSI. Apart from this, if we perform a shunt surgery, we'll have to inform the patient about the risk of hepatic encephalopathy. If for this particular patient it does not hold much role because this patient does not have CLD, but in cases of CLD we will have to inform the patient that there is a higher risk of hepatic encephalopathy post shunt surgery.
What is the ideal time for vaccinations?
Sir, for an elective case, we usually vaccinate 2 to 4 weeks earlier. For a patient who has underwent emergency splenectomy and who is undergoing early discharge, we try to vaccinate the patient by 7 days, or ideally after 2 weeks is the ideal vaccination time, sir. And then we follow up with a meningococcal booster at 6 months and 1 year, and a pneumococcal booster at 1 year.
What counseling is needed if the patient is landed with this splenectomy? What do you counsel the patient? Post-splenectomy. Always you counsel if the patient is having minor URTI, he or she consult the doctors and take medication and time to avoid the OPSI.
You must vaccinate before discharge. Suppose in a government setup,
so in
will
our practice,
lost to follow up, patient
yes,
won't come. So before you discharge, please give. Otherwise, patient when patient is doing fine, vital signs stable, you can vaccinate that time. So what are the 3 vaccines you give?
Sir, pneumococcal, meningococcal, and Haemophilus influenzae B. Yes, sir. We give pentavalent vaccine because we do not get HIV vaccine separately. Thank you, sir.
Nicely presented.
Sir, 56 year homemaker by President of Uttar Pradesh. I am Upendra Sharma, presented with chief complaint of lump in left upper abdomen since 1 month. My patient, she is apparently well 1 month back when she noticed a swelling in the left upper abdomen. Instead in onset, gradually progressive from approx 3 to 3 centimeter to the present of 5 into 6 centimeter. There is history of constipation, decreased appetite and unquantified weight loss. There is no history of pain, vomiting, urinary symptom in the form of hematuria, urgency frequency, fever, melena, hematomesis or jaundice, bone pain and cough. The past history patient had open cholecystectomy 1 year back. There is no history of hypertension, type 2 diabetes, tuberculosis and COPD. Personal history, she consumed mixed diet, decreased appetite, wobble habit presently, constipation present and bladder habit is normal, there is no addiction. Family history, there is no significant family history. Case summary, 56-year-old female presented with a painless progressive left upper abdominal lump for 1 month associated with constipation, anorexia and weight loss with the history of open cholecystectomy 1 year back. On examination, patient is examined in a well-light room after taking a proper verbal and informed consent in the presence of female attendant after full exposure from nipple till mid-thigh. Patient is conscious, cooperative and well-oriented time place person. Patient has average weight with well nourished. Height is 163 centimeter, weight is 52.6 kg, BMI is 20.2, ECOG is 0, afebrile, pulse is 78 taken in right radial artery with regular rhythm, normal volume with no radio arterial delay and radiofemoral delay. BP is 100 by 170 mm of mercury in right brachial artery in supine position and respiratory rate is 18 per minute, no parallel ictal cyanosis, clubbing lymphadenopathy and pedal edema. On systemic examination on infection, abdomen is distended, well healed previous surgical scar in the right hypochondrium, umbilicus is inverted and centrally placed, all quadrant move equally with respiration, overlying skin is normal, no visible peristalsis or dilated vein, bilateral hernia orifice and left supraclavicular region is normal, there is no fullness. On palpation, temperature over all quadrant are normal. 6 into 5 centimeter single non-tender oval shape with smooth surface and well defined with firm consistency, non-reducible, non-compressible lump in the left hypochondrium, 7 centimeter from midline, 3 centimeter below the left costal margin, and finger can be initiated in the left costal margin and in lump. It's 6 centimeter in the front of mid axillary line and 10 centimeter above the umbilicus. Does not move with respiration. Swelling disappeared on Carnet test, and swelling is mobile, is not mobile in horizontal and vertical plane. Non-bloatable and bimanually not palpable. Bilateral honey on orifice, spine and bilateral renal angles are normal. No organomegaly or free fluid present. On percussion, resonant node on lump and tympanic node on the rest of the abdomen. Bowel sound present. No bruise present. On DRE, external no external hemorrhoid, fistula or fissure or no skin tag. Fetal thing present. There is no melena present and no Bulmer's self is present. And CNS is rest all systemic examination within normal limit. Case summary: 56-year-old female with painless progressive increasing lump in the left hypochondrium for 1 year, associated with constipation, anorexia and weight loss, with past history of open cholecystectomy 1 year back. On examination, there is a 6 into 5 centimeter from a non-tender, well-defined swelling with smooth surface in the left hypochondrium, which does not move with respiration and non-vertebral. A finger can be inserted in the left costal margin. So my provisional diagnosis is likely the malignant etiology, sir, arising from colonic reasons.
आपने एब्डोमिनल एग्जामिनेशन में शुरुआत में बोला एब्डोमेन डिस्टेंडेड, तो वाज इट डिस्टेंडेड? When do you say the abdomen is distended?
Sir, when we on inspection we take the two bony prominence, sir, midline.
नहीं, distension कहोगे या protuberant कहोगे?
It's protuberance.
When do you say it is distended?
When there is any ascites, mass, grossly, and
Or
umbilicus.
there is an obstipation.
Obstipation and umbilicus is inverted, sir. Dilated skin.
So एक तो ये problem है ना? Distended ना बोलिए.
Sir.
क्योंकि distended से तुम्हारी diagnosis examination से सीधे जो सीधे है वो intestinal obstruction या ascites, हाँ obstruction में चली जाती है.
5, sir. Fat fetus, feces, fluids.
तो ये उधर ही ले जाएगा फिर डिस्टेंशन, ठीक है? हाँ, डायग्नोसिस कुछ और बनाना चाह रहे हो और वाइवा घूम जाएगा दूसरी तरफ, ठीक है? तो डिस्टेंडेड नहीं है, ठीक है? प्रोटुबरेंट है.
Sir, non-mobile.
What are the grounds in the history and examination to make the diagnosis as malignant at the first place?
Sir, patient is have advanced age, sir, and with the history of weight loss, and lump is rapidly progressive, sir, with the history of unintentional weight loss and constipation and decreased appetite, sir.
Okay, so far you have not done any investigations.
No, sir.
And you emphatically said the patient has been operated for open cholecystectomy.
Yes, sir.
Do you have something to correlate with the previous operation with the
Yes, sir.
present lump?
There is
With the same other symptoms like constipation and weight loss?
sir, there is no document available, sir. If it's introp, histopath is if there is incidentally directed CAGB, sir, then it may be a secondary to that, sir.
The lump is cystic, soft or solid?
Sir,
That is firm.
Firm, sir.
Firm throughout.
Sir.
But you can say, you said that the swelling is homogeneous, no? There is no irregularity, nothing.
Sir.
And straightforward you can jump on the diagnosis of malignancy. Examination findings पे जाओ. तुमने वेल डिफाइंड लिखा हुआ, वेल डिफाइंड मार्जिन्स. So how you can justify the well defined margins with the malignant swellings? You got the point?
Yes.
Based on these findings is against your diagnosis. May or may not. Okay.
आपने सिर्फ कॉन्स्टिपेशन की हिस्ट्री दी है ना? लेफ्ट साइडेड कोलोनिक ग्रोथ्स जो होती हैं, दिस इज लेफ्ट साइडेड.
Sir.
The position is somewhat near the splenic flexure.
Sir.
That is a narrow point.
Sir.
है ना? लेफ्ट साइडेड कोलोनिक ग्रोथ्स के जो पेशेंट प्रेजेंट करते हैं,
Sir.
उनकी बावल हैबिट स्पेसिफिकली कैसी होती हैं?
So constipation and diarrhea both are altered bowel habits.
Yes. Altered bowel habits.
Sir.
Why do you progress for malignancy then? Smooth, well defined, no alternative bowel habits. Firm बताया आपने. और क्या हो सकता है?
Based on these regions, what are the other organs involved?
Sir, sir, it may be spleen, but sir, it is not moving with respiration, sir.
No, not question is not a spleen, because you can insinuate the finger in between the lump and the costal margins. The spleen is out.
Any spleen can be there. Some sort of a spleen can be there with this finding.
No, sir.
Accessory spleen?
No, sir, it's.
अच्छा ये बताओ. Why not tail of pancreas lesion?
Sir, tail of pancreas, but there is no history of. It may be a pseudocyst of pancreas.
तुमने कार्नेट्स टेस्ट नेगेटिव बोला है.
Sir.
तुमने इंट्रापेरिटोनियम रेट्रोपेरिटोनियम को डिफरेंशिएट नहीं किया है.
Sir.
You've just differentiated between the parietal and the intra-abdominal swelling. You have not
But there
differentiated
is
between the two.
a patient have no pain, sir, and there is.
So, tail of pancreas mass. Why pain?
Maybe tail of pancreas, sir, but there is no other history suggestive of its pancreatic origin, sir.
मगर malignancy तो हो सकती है.
Sir, but there is no history of any jaundice, sir.
Question is this: how can you differentiate between the parietal intraperitoneal swelling to the retroperitoneal swelling?
Intraperitoneal swelling and retroperitoneal swelling, sir, we can do a knee bending test, sir, but nowadays we are not doing that, sir. So other test is shifting test can be done, sir. We mark the swelling, sir, and then turn the patient to left side, sir, lateral side, sir. If swelling displays, sir, then it's abdominal swelling, sir. If not displayed, then it is a retroperitoneal swelling, sir.
Conclusive diagnosis or provisional diagnosis in your slides?
No, sir, not in slides.
No diagnosis. Okay.
एक चीज तुमने बोली. I'm sorry. You said कि there's no jaundice.
Sir.
Tail of pancreas lesion में jaundice क्यों होगा? When do you expect jaundice?
So when periampulary is.
Yes. When it is somewhere which is causing obstruction to the CBD. So tail of pancreas lesion में तो होगा नहीं.
Sir.
So why not tail of pancreas lesion?
Sir. Sir.
Mesenteric attachment कहाँ से कहाँ तक होता है?
Mesenteric it's in the midline, sir.
Left to right होता है ना?
Yes, sir.
कहाँ से कहाँ तक? पढ़ना है इसको जाके.
Sir.
उससे रिलेटेड कुछ हो सकता है?
Mesenteric cyst.
पढ़ना पड़ेगा. स्टमक का कोई लेजन हो सकता है?
Yes. Sir.
जेस्ट हो सकता है?
Sir.
Yes. जब भी बेटा कोई केस प्रेजेंटेशन करो ना, उस एरिया के ऑर्गन्स को हमेशा दिमाग में लेके करो. यहाँ क्या क्या हो सकता है, क्या क्या मुझे मिल सकता है? RCC
RCC, but it's non-bloodable, sir, and there is no urinary symptoms, sir. RCC can
फिक्स हो गया, RCC enlarged RCC है, बड़ा है, फिक्स हो गया ऊपर जाके.
in advanced stage, sir, then there is a pain hematuria with fever, sir.
Adrenal mass.
Adrenal mass.
So open your mind. मतलब ये नहीं है कि मैंने केस प्रेजेंटेशन करना है तो एक ही ऑर्गन को लेके करना है. सारी जो उस एरिया के सारे ऑर्गन्स हैं सबको माइंड में लेके चलो, तब जाके तुम्हारा एक तुमने ECOG 0 बोल दिया और मैलिग्नेंसी पे कूद गए, है ना?
What is the significant weight loss?
More than 5%, sir. Unintentional body weight more than 5% in 3 months, sir, and more than 10% in 6 months, sir.
These all points goes against the malignancy. Okay, that you said it is originating from colon. That we will say yes, there can be possibilities there. But just enumerate the DD in that region. Most of the things you have already listened.
Sir.
On the basis of discussion so far, can you repeat the points in your differential diagnosis 1, 2, 3, 4?
Sir, differential diagnosis, sir, it can be parietal, sir, parietal mein, it can be lipoma. Sir, it can be intra-abdominal, sir, or retroperitoneal. Intra-abdominal it can be splenic, sir, and omental, mesentery, sir, and retroperitoneal from the kidney and pancreas. Adrenal, sir. Adrenal, sir. And stomach also, sir. Sir.
वर्म बॉल हो सकता है?
Sorry, sir.
वर्म बॉल हो सकता है?
Sir. No, sir. No investigation done, sir. No, sir. Sir, firstly, I will stage the disease. Number one investigation, sir, first is ultrasound, sir, to look for origin of organs, sir, and ascites, sir, and extend and swelling, which type of swelling, sir, polycystic swelling, sir. Then origin, organ of origin, sir. Size, sir, and size, sir, and what is the consistency of the swelling, sir? That is maybe cystic, hard, or then any mets, sir.
Size, size, and nature.
Nature. Then other
things.
Then other thing. Then ascites.
First you localize one, no? Size, nature, then associated things. Ascites. हाँ केस इसने यहाँ लिया है. कमांड हॉस्पिटल का केस यहीं का है ना. तो what are the features, characteristics which give rise to idea about this swelling is malignant with your diagnosis?
So malignant is solid swelling, sir, and solid swelling with there is maybe ascites present, sir, or lymphnopathy is also there, sir.
Suppose this swelling arises from the colon.
Sir.
Okay, with your diagnosis, your possibilities. What next? What next investigations?
Then we will go for colonoscopy, sir, plus biopsy to confirm the diagnosis.
Which type of the malignancy you need the colonoscopy, or which type of the colonic malignancy doesn't need the colonoscopy.
Adenocarcinoma.
You have taken this case from KGMU or from Command Hospital?
KGMU, sir.
यहीं से लिया था ना, तो टाइम कम मिला, दैट्स वाई, है ना? पीछे नहीं सुनाई दे रहा ना, लोग और मस्त हैं, बोल नहीं रहे। नहीं, कोई बात नहीं, फिक्स्ड माइंड नहीं होना चाहिए, वन ओरिजिनल डायग्नोसिस फॉलोड बाय अदर पॉसिबिलिटीज़, हैं, और लगे रहो, सोचते रहो, लगे रहो, व्हाट आर द अदर पॉसिबिलिटीज़। जो क्वेश्चंस जो होते हैं ना, दे गिव इट क्लू टू डिस्कस मोर। यू हैव प्रेजेंटेड ओवरऑल वेल, थैंक यू।
Now I would like to call upon stage Dr. S.K. Bharti sir, Professor R.B. Singh sir and Vivek sir to kindly felicitate the presenter from BH. Dr. Upendra.
Check.
Thank you, respected examiners and the presenters. Now I would like to request Dr. Sanjeev Kumar sir to kindly present his lecture on the topic hemorrhoid and anal fissures.
डाल दे इसमें डाल दे उधर पॉइंटर है so good afternoon time कम है so I will start with approach to a case of anal fissure. I will take only 10 minutes hardly and discuss the basics of anal fissure. So I will cover the talk under most common site is posterior midline in males, and in females usually it occurs at the anterior side, on anterior side. The etiology basically is due to shearing force of any kind which cause tear of the posterior side of the anal canal, that is the less elastic area of the enoderm, and by shearing it got longitudinal tear over there. So etiologically we classify anal fissure into two types, that is basically primary anal fissures and secondary anal fissures. तो प्राइमरी एनल फिशर जो होते हैं दैट इज बेसिकली ड्यू टू एनी काइंड ऑफ शेयरिंग फोर्स, दैट इज ड्यू टू कॉन्स्टिपेशन, chronic diarrhea and the factors leading to development of constipation, that is low fiber dietary intake, child bearing age, prior anal surgeries, है ना, ये सब सारी चीज़ें प्राइमरी फिशर को जनरेट करने के लिए या डेवलपमेंट के लिए रिस्पॉन्सिबल होती हैं, वाइल सेकेंडरी एनल फिशर्स आर ड्यू टू एसटीडीज, ट्यूबरकुलोसिस एंड अदर infectious disease like HIV as well as anal cancers. So it is actually a vicious cycle. Whenever there is development of acute fissure due to any shearing force, there is a micro trauma of the anal canal, distal anal canal, enoderm, that causes spasm of the anal sphincters and reduced blood flow of that particular area. Again ड्यू टू स्पाज्म शेयरिंग फोर्स फिर से इंक्रीज करता है, फ्लो डिक्रीज होता है ब्लड का, एंड लोकल इस्चीमिया हैज टू बी हैपन. अगेन पेशेंट को कॉन्स्टिपेशन होता है एंड शेयरिंग फोर्स बढ़ता है, तो माइक्रो ट्रॉमा फिर से होता है और फिशर आपका क्रॉनिक फिशर में डेवलपमेंट या चेंज हो जाता है. तो बेसिकली फिशर एनल फिशर का पेशेंट आपके पास जब प्रेजेंट करता है तो दैट इज the most and common sign or symptom is pain, है ना, pain while defecation that may persist for minutes to hours to days, है ना, and the characteristic of pain is ऐसे कहता है कि that is a sharp of pain at the time of defecation. There might be a blood on the tissue paper or patient may complain of a small amount of blood while defecation. If it associated with any kind of infection or underlying fistula, mucus or pus discharge might be present over there. Clinically we classify anal fissures into two types, that is acute anal fissure and chronic anal fissures. Chronic anal fissure की बात करें तो that is developed after 6 weeks, और एक्यूट की बात करें तो लेस देन 4 to 6 वीक के ड्यूरेशन में रहता है, तो दैट इज नोन एज एक्यूट एनल फिशर. If you examine clinically, there is deep tear in the distal anal canal, spasm of the anal sphincters, as well as there is no any kind of inflammatory induration on the edges of your fissure. While if you examine the chronic patient of anal fissure, there is exposed internal sphincter fibers with induration over there, hypertrophied anal papilla and sentinel tags. 3 things are characteristic of chronic anal fissure. Picture देखो, तो there is tear in the anoderm in acute fissure, while there is exposed internal sphincter fibers, hypertrophied anal papilla and sentinel anal tag in the chronic anal fissure. So management, diagnosis for management is entirely clinical. Anoscopy recommended नहीं है, we have to do clinical inspection as well as parectal examination. On parectal examination, there might be increased tone of the anal canal. Patient try to avoid parectal examination. Patient आपको मना करेगा कि सर पेन हो रहा है, try to avoid it. आप naked eye से inspection करेंगे तो आपको tear दिख जाएगा. Acute fissure है तो chronic में आपको papilla as well as sentinel tag दिख जाएगा ना. Then treatment is basically conservative medical therapy and surgical management की तरह से categorize करा जाता है. तो in medical therapy, what are the treatment modalities? Warm sitz bath and laxatives along with other locally applied medical agents है ना. Stool softener, high fiber diet, laxatives. अगर स्पेसिफिक थेरेपी की बात करें तो GTN ग्लिसरल ट्राइनाइट्रेट, कैल्शियम चैनल ब्लॉकर्स एंड बोटुलिज्म टॉक्सिन है जो कि स्पेसिफाई करा गया है फॉर थेरेप्यूटिक पर्पज ऑफ दिस क्रॉनिक एज वेल एज एक्यूट एनल फिशर्स. कौन सा अच्छा है, विच वन इज बेटर, सबके अलग अलग रिकमेंडेशन है. तो फॉर केमिकल स्पेक्ट्रोस्कोपी glyceryl trinitrate is first and foremost therapeutic agent but having less superior side effects. इसके side effects as compared to other agents like diltiazem and nifedipine ज़्यादा हैं, तो the priority drug is your diltiazem and nifedipine that should be applied 2 times in a day, preferably prior to 30 minutes prior to defecation, so that your sphincter का स्पाम दैट गॉट रिड्यूस्ड एट द टाइम ऑफ डेफिकेशन. तो विशियस साइकिल जो है वो आपकी पेशेंट की क्या होती है, चेक हो जाती है, बंद हो जाती है. देन बोटुलिज्म टॉक्सिन दैट इज इंजेक्टेड 20 इंटरनेशनल यूनिट ऑफ बोटुलिज्म टॉक्सिन इज इंजेक्टेड इनटू इंटरनल स्पेक्टर फाइबर, सो दैट क्या होता है, केमिकल स्पेक्ट्रोटमी हो जाती है, बट रिपीटेड इंजेक्शंस आपको लगाने पड़ते हैं फॉर थेरेप्यूटिक पर्पज है ना. साइड इफेक्ट्स आर यूजुअली लेस है ना, जो नॉर्मल गाइडलाइंस हैं SCRSI की. diltiazem एंड निफेडिपिन में 3 months ट्रायल के बाद देयर इज हीलिंग अप टू 80% देखी गई है इन क्रॉनिक फिशर्स एज वेल. बोटुलिज्म टॉक्सिन में रिकरेंस रेट इज वेरी मच हाई अप टू 50%. सो नाउ इट इज बोटुलिज्म टॉक्सिन नॉर्मली यूज नहीं करा जाता है. सेकेंड, सर्जिकल मैनेजमेंट ऑप्शन में पहले स्फिक्टर स्ट्रेच करा जाता था. इन दैट वी हैव टू पुट आवर 4 fingers इनसाइड द एनल कैनाल 1 by 1 एंड स्ट्रेच द एनल कैनाल है ना. बट साइड इफेक्ट्स ज़्यादा थे उसके, पेशेंट को परसिस्टेंट पेन रहता था, फाइबर्स टीयर होने की वजह से फाइब्रोसिस बहुत ज़्यादा हो जाती थी, तो लॉन्ग टर्म इफेक्ट्स आर वेरी लेस. सो बेसिकली वी हैव टू डू लेटरल इंटरनल स्फिक्ट्रोटमी in these patients for treatment of acute and chronic anal fissures. स्फिक्ट्रोटमी चाहे जित मेथड से करें, लेजर से करें और सीजर से करें, द बेसिक प्रिंसिपल इज सेम. वी हैव टू कट द इंटरनल स्फिक्टर एट द साइट ऑफ 3 or 9 o'clock position. Recommendation is up to dentate line or you may use to cut the fibers up to the upper part of the fissure. Same results has been obtained, but healing rate जो डेंटेट लाइन तक आप इंसिजन लगाते हैं उसमें एज कंपेयर टू जो सुपीरियर पार्ट ऑफ द फिशर है वहाँ तक लगाने से क्या होता है, हीलिंग अच्छी देखी गई है. देन ओपन और क्लोज और लेजर, तीन मेथड है. ओपन अगर करना है तो हैव टू मेक ए रेडियल इंसिजन ओवर एनोरेक्टल जंक्शन एंड इंसाइज द इंटरनल स्पेक्टर फाइबर्स अप टू द डेंटेट लाइन. क्लोज्ड में जो एक्सटर्नल और इंटरनल स्पेक्टर फाइबर्स के बीच का ग्रूव है, वी हैव टू इंसर्ट द एनर्जी डिवाइस और स्कैल्पेल, उसमें इंसर्ट करके वी हैव टू रोटेट इट एंड कट इट अप टू द डेंटेड लाइन. ऑब्वियसली ओपन मेथड आपको ज़्यादा अच्छा है बिकॉज यू हैव टू डू इट ऑन योर नेकेड आई, है ना, डायरेक्ट विजन में करते हैं. लेंथ एज आई टोल्ड, you can opt both of them up to the higher part of apex of the anal fissure or up to the dentate line. Healing rates are comparable in both the techniques. Complication क्या है, hemorrhage हो सकता है, hematoma हो सकता है, bruising, abscess, sometimes fistula में भी conversion हो सकता है. Proper hygiene is to be maintained. Significant risk of flatus incontinence for part time, transient flatus incontinence होती है, but that will recover with time actually. In some patients where lateral internal spectrotomy is contraindicated, we have to do fissurectomy along with anal advancement flap. क्या क्या conditions है, like reduced anal tone है ना, पेशेंट की टोन मेंटेन नहीं हो पा रही है तो LIS करने पे आपका इनकॉन्टिनेंस का रिस्क इज गोइंग टू बी इंक्रीज. इन दैट केस जो स्कार टिश्यू है, फिशर कैरियर, दैट हैज़ टू बी रिमूव अलॉन्ग विथ एनल एडवांसमेंट फ्लैप, है ना, पीछे की स्किन और सबक्यूटेनियस टिश्यू लेकर के उस एरिया में हम क्या करते हैं, फ्लैप लगा देते हैं ना, ठीक. देन ए स्मॉल वीडियो विच इज शोइंग बेसिक्स ऑफ लेटरल स्पेक्ट्रोटमी. चाहे जैसे करो, द टेक्निक डिफरेंट करती है, लेकिन जो पार्ट इंसाइज करना है दैट शुड बी द सेम. आई एम डूइंग इट विथ कॉटरी, यू कैन यूज योर सीजर्स, योर नाइफ, और यू कैन यूज लेजर. वाइट फाइबर्स आर इंटरनल स्पेक्टर फाइबर्स एंड रेड फाइबर्स आर ऑफ एक्सटर्नल स्पेक्टर फाइबर. वाइट फाइबर आपको दिख रहे हैं, दैट इज टू बी इंसाइज्ड. Slight blunt dissection will give you pain so that you might not injure the external specter fibers. It is white fibers which are, जब कॉटरी से करना है तो वी हैव टू यूज वेरी लेस पावर, है ना, लेटरल स्पीड उसका कम से कम होएगा. सो थैंक यू. अब लंच ले लो, फिर बाकी का बाद में, है ना.
Thank you, sir, for such a nice lecture. Now I would like to request Dr. Geetika ma'am to kindly felicitate Dr. Sanjeev Kumar sir.
ये हो गया मेरा फादर. अरे मोटा दिख रहा हूँ. थैंक यू मैडम.
So we now disperse for the lunch, and this will be half an hour.
Continuing with the lectures, now I would like to invite Dr. Manoj Sonkar sir to give his presentation on the topic ergonomics in laparoscopy.
लेजर पॉइंटर नहीं चलाएंगे लेजर पॉइंटर लीजिए Yeah, good afternoon students, my dear colleagues and senior faculty members. I am Dr. Manoj Sonkar. I will be talking on ergonomics in laparoscopy. As the subtitle says, ergonomics in laparoscopic, it is the key to keyhole surgery. So, if you want to learn keyhole surgery, that is laparoscopic or minimal access surgery, you should know about ergonomics and should follow good ergonomics in order to improve and gain confidence when you begin your career in laparoscopic surgery. Ergonomics in Greek means natural law of work. Any work we are doing, it is applied to that work. So, when you are dealing with a laparoscopic surgery, there are some laws which you should follow, so that it will ease the process of doing a laparoscopic surgery. Why ergonomics in laparoscopy? Why it is important? Because if you follow a good ergonomics, it will make you more efficient, more comfortable and more confident. If you are having a bad ergonomics, not following proper ergonomics, or if you are doing a good ergonomic this thing. So, what is the problem of this bad ergonomics? If you do not follow good ergonomics, it will lead to struggle throughout the surgery. You will struggle entire surgery, and this will lead to stressful surgery. You are stressed during the surgery, and this stress leads to the complication, more complication in the laparoscopic surgery, and this complication ultimately makes you to convert the patient into an open surgery. But to contrast, if you follow good ergonomics, it will give you less pain, it will gain more. If you do you have a less pain, you will do better surgery, and shoulder pains, stiff neck, eye strain, anterior synovitis, these are the complications of doing a prolonged procedure. These are prevented. So, you achieve a better outcomes. First, I would like to emphasize what is the basic difference between an open surgery versus a laparoscopic surgery. In open surgery, you can stand mostly on the right side of the patient, and you can operate on the entire pathology on the left side, left upper abdomen, right upper abdomen, right lower abdomen, in left lower abdomen. So, in cases of open surgeries, ergonomics is optional. You can follow some basic ergonomics and you are comfortable while doing the surgery, but it is not in the case of laparoscopic surgery. In laparoscopic surgery, in any particular surgery, there is a particular position of the surgeon plus the particular position of the monitor system. So, ergonomics becomes essential or rather mandatory when you are doing a laparoscopic surgery. Now, what are the basic problems of laparoscopy against the open surgery? In laparoscopy, you have only 2D vision. Because of 2D vision, there is no or minimal depth perception, and second, there is no tactile or a minimal tactile feedback that we will have in laparoscopic surgery. Second problem with laparoscopic surgery is there is something called as counterintuitive movement. As in laparoscopy, you are dealing with slender long instrument and you make small holes in the abdominal wall. Your abdominal wall acts as a fulcrum. So, this will offer some resistance. So, in order to move an instrument inside the abdomen from the abdominal wall, this is the fulcrum, this is the instrument. So, in order to move the instrument inside the abdomen from right to left, you have to make a counter movement outside, that is from left to right and vice versa. So, this is called as counterintuitive movement. This is to be learned in under training practices, and it is very easy to master, but you should always practice in the endo trainer sessions. And the third limitation of laparoscopic surgery is there is limited degree of freedom, or also called as movement. It offers you only 4 types of movement that is possible in laparoscopic surgery. One is in and out movement of the instrument, another one is right and left movement of the instrument, third is up and down movement of the instrument, and fourth is you can rotate the instrument in order to manipulate the tissue. So, these are only 4 movements or a degree of freedom that you have in a laparoscopic surgery.
Whereas a human hand has 36 degree of freedom, and robotics offers you a better degree of freedom, that is 7 degree of freedom because of the rotation of a wrist. Now, the basic question to a young budding surgeon or a person who is about to bring his start his laparoscopic career is, where should I put my ports so that I could perform a good laparoscopic surgery? And second is, how do I set up my OT, that is the environment, the OT, where should I stand, where should my assistant stand, and where should be the monitor to be placed, so that the surgery becomes less tiring and I can prevent the occupational hazard that is because of the prolonged surgery. Now, answering the first question, where should I put my ports? So, the answer lies in a baseball field. This is called as typical baseball field. So, there is something called as baseball diamond concept for ergonomics in laparoscopy. This is the basic concept of putting port placement in laparoscopic surgery. I will brief you about this baseball field. So, this part is called as the home plate. This is called as first base, second base and third base. So, first base, second base and third base are arranged in a fashion of an arc around the home plate. There are equidistant from the home plate. So, this distance, this distance, this distance is equal. So, they are arranged in a form of an arc. So, when you apply this knowledge of baseball diamond concept to laparoscopy of a port placement, your home plate acts as a target organ, that is, if you are doing a laparoscopic cholecystectomy, your home plate will act as a gallbladder should be your target organ. Your diagonally opposite second base will act as a camera port. Your first base and the third base will act as the left and the right hand instrument of the operating surgeon. So, this is the baseball diamond concept for putting ports. Why do you follow a baseball diamond concept? How will it help? Because it will help you to achieve these three basic principles of putting ports. One is, half instrument should be inside the abdomen and half instrument should be outside the abdomen. Second is, your camera or the telescope should come in center with respect to your right and the left hand working instrument. And third, the most important is, you achieve an ideal working angle at the tissue which you are dissecting. We will deal it one by one. Baseball diamond concept is basically the combination of two basic principles, that is arc principle and a triangulation principle. Arc principle is to know where to put the ports, and second, triangulation principle is where to put a camera with respect to your right and the left hand working instrument. So, what does the arc principle states? Arc principle states, you draw an arc around the target organ approximately 15 to 18 centimeter away from the target organ. So, if this is your gallbladder or this is your appendix, you draw an arc around 15 to 18 centimeter away in a form of an arc, and you place all the ports in this position. Why 18 centimeter? Because the standard length of the adult laparoscopic instrument is 36 centimeters, and half of that is approximately 18 centimeter. How do you measure this? You can use simple method. You can use your palm. The tip of your middle finger to the wrist is approximately 18 centimeters. So, you can place your tip of the middle finger at the target organ, and accordingly your wrist will guide you what is approximately 18 centimeter, 15 to 18 centimeter away. Next, why you want half instrument in and half instrument out? This is very important, because as you are dealing with a long slender instrument and your abdominal wall acts as a fulcrum, you want to achieve it like a type 1 lever. What is type 1 lever? Type 1 lever, this pivot is your abdominal wall, hole in your abdominal wall, and this half instrument is this side, half instrument is outside. So, when you have this configuration, that is lever type 1 lever, your x amount of force which you apply outside or x amount of movement you have outside the abdomen, similarly it will be transmitted inside the abdomen. But if you have a type 2, type 3 lever, you or overshoot, that is not good for surgery, you may create complication. So, for doing a laparoscopic surgery, you should achieve a type 1 lever. Next, second principle, you should have a camera in center, camera or a telescope in the center with respect to the right and the left hand working instrument. This is your left hand working instrument, this is your right hand working instrument, this is your target, and the camera comes in the center or in between the two ports. So, it is called as triangulation principle or coaxial alignment of the port. Why do you want this camera to be in the center with respect to your right left hand working instrument? Because of this parallax, important parallax, that is called as linear parallax. You can see this image, the left side of the image, left half of the image and the right half of the image is almost same. So if you are looking from the center, your brain judges that this brick of the railway track and this brick of the railway track nose is of the same size, but the actually same size, but it sees it's a smaller this thing track, small in size, and this is big, though this actual size of the same both is same. So what it says ki this is closer to your vision, closer to your eyes, whereas this part is away from your eyes. So when you put an left hand working instrument and right hand working instrument on the either side, your brain knows and your hand knows कि your this organ is closer to your instrument, whereas this organ is far away from your instrument. Similarly, if you are putting the camera on one side and your instrument from the other side, your brain knows this appears bigger as compared to this. So your brain thinks this is closer to your eyes, but actually your instrument is coming from the other side. So actually this part is closer to your eyes rather than this. So there may be undershooting or overshooting. There are other parallax also, they are called as motion parallax. Object that is closer to your vision, closer to your eyes, moves faster if you are in the motion, and object that is farther away moves relatively slower as compared to the other. Contrast parallax, color parallax, object that are closer to your eyes is more brighter, more clear and more contrast, whereas object that is far away appears little blur. There are two types of port positions you can have. One is called as coaxial, which I already told you, and one is sectoral port placement. So what is coaxial port placement? Coaxial port placement, also called as contralateral port placement, in which your right hand working instrument and your left hand working instruments are on the either side of the optical axis or the camera. So this is called as coaxial port placement, that is preferred. Another port placement is also called as sectoral port placement or ipsilateral port placement. In this, both or the right and the left hand working instrument are on the same side of your optical axis or the camera. This is a little difficult to master, so for a beginner you should not attempt for a ipsilateral port position. Once you have practiced a lot and you have been oriented and become little expert, then only you opt for a sectoral port placements. So this is an example of a coaxial port placement in a case of an lap appendix. So your umbilical port will have a right hand instrument, your suprapubic port will be your left hand working instrument, and your camera will come from the left iliac fossa. If you go for a sectoral port placement in an appendicectomy, lap appendicectomy, your right hand working instrument will be in the left iliac fossa, left hand working instrument in the suprapubic area, and the camera will come from the umbilical. This is the example of a sectoral port placement. Next, the third working principle is the ideal working angle which you should achieve at the target organ. What is ideal working angle, or also called as manipulation angle? You use this angle in your day to day life when you eat, when you type, everything, when you are writing, you ideally use this angle, but nobody notices. So how do you achieve an ideal working angle when you are doing a laparoscopic surgery? As you know, the length of the instrument is approximately 36 centimeters, your laparoscopic instrument. If you want to achieve an angle of 60 degree at the target organ, this is an umbilical your camera port. So you should be at least 7.5 centimeters to 8 centimeters away from the optical port laterally on the either side, so that you achieve an ideal working angle, that is 60 degree. How do you use this practically? When you are doing a surgery, you can make a diamond with your fingers, where your index finger, tip of the index finger meeting will be at the target organ. Your anatomical snuff boxes will be your right and the left hand working instrument, and the tip of the thumb that is meeting, that will be your camera port. So this way you can draw a picture, or you can make over the abdomen when you are doing a this thing appendicectomy or any other surgeries. Next important is what are the various angles of in laparoscopy. There are two major important angles in laparoscopy. One is the azimuth angle, another one is a manipulation, or also called as a working angle. What is azimuth angle? Azimuth angle is an angle between the working port, one of the working port, and the optical axis. So this is an azimuth angle, one of the working port and the optical axis, that is the camera. And what is manipulation angle? Manipulation angle is an angle between two working instruments, that is one left hand working instrument, right hand working instrument. So this angle that is made by the two instruments is called as a manipulation angle. Ideal azimuth angle should be 30 degree. So, ideal manipulation angle is twice the azimuth angle, that is 60 degree, but an angle manipulation angle between 45 to 75 degree is ideal for doing a good laparoscopic surgery. Anything that is less than 45 degree or more than this is not good for doing laparoscopy or laparoscopic surgery or dissection, or for that matter suturing. Now, answering the second question is, how do I set up my OT or the environment around me? So, first you should mind it, the first question we answered is the relation between the surgeon and the surgery, basically what organ we are dealing. This relation is between the surgeon and the environment or the OT setup. This will decrease the occupational hazard, that is wrong port placement and the difficulty in doing surgery. So, what are those principles we should follow? One is straight line principle, second is elevation angle concept, third is waist level table height, downward gazing view and arm position. So, what is straight line principle? This is a very simple basic principle. It states that the monitor or the screen, the organ of pathology and the surgeon, all three should be in a straight line. All three should be in the straight line, but why you want this to follow? All three should be in the straight line, because you have two axes, one is motor axis, another one is a visual axis. Motor axis is the way your hand is going and visual axis is what you see. So, there is a decoupling in the motor axis and the visual axis in laparoscopy when you are doing a laparoscopic surgery. It should be ideally same. When you are doing an open surgery versus your laparoscopic surgery. So, when you are doing an open surgery, your visual axis is directed towards the tissue or the organ you are dissecting, and your motor, that means your hand, is directed toward the tissue. So, they are onwards converging at the target organ or the organ of pathology you are dealing. So, this is your motor and visual axis are converging to the target organ. But whereas in a laparoscopic surgery, your eyes are over the monitor and your hands are below. So, they are not converging to a single point or a target organ. So, there is a discrepancy your brain does not able to comprehend. So, you are making it align in a straight line, so that they infinitely they point toward the same point, though you cannot achieve the idea same motor and visual axis converging over the target organ, but you can minimize this parallax, this problem, when you align the patient into a straight line. So, we will take an example. If you are doing an appendicectomy, the monitor, the pathology, appendix and the surgeon, all three should be in the straight line. When you are doing a cholecystectomy, the surgeon stands at the left hip of the patient, then you have a right hypochondrium, the target organ, and the monitor should be at the right shoulder of the patient. Coming to elevation angle. Elevation angle is an angle that is made by the patient's body with one of the working instrument. So, this is an elevation angle, patient body and the one of the working instrument. Ideally, the manipulation it should be equal to the manipulation angle. So, manipulation angle should be equal to the elevation angle. So, ideal manipulation angle is 60 degree. So, you should always have a 60 degree. So, 45 to 75 degree range of manipulation angle can also be applied to this. Next is surgeon stance. How should the surgeon stand? This is an ideal position in a surgeon should stand, and this is not a good position because it will lead to tiring or fatigue of the surgeons. So, why it is ideal? Because this person has a downward gazing view, 15 to 25 degree of downward gazing view, not straight or not looking up. Second is the elbow angle is very important for doing a long surgeries. This elbow angle should be more than degree. The height of the table should be below the waist or at least at the waist, so that you are able to achieve this angle more than 90 degree. If the table height is more, or if you are doing an obtuse acute angle, then the surgeon will have fatigue. And lastly, predominantly the movement of the during the surgery should be below elbow. You should not use your shoulders or adduct your shoulder, abduct your shoulder, because it will lead to fatigue. So, the take home message from this lecture is, if you could summarize, I could summarize it 3A to be followed when you are starting with a laparoscopic career is, first is alignment. A for alignment, that means straight line alignment. You align the three structures, three things in one line, that is the surgeon, the organ of pathology and the monitor. Second A is arc principle. Once you have aligned the patient, then you identify the target organ and you draw an arc around the target organ 15 to 80 centimeter away, imaginary angle. And third is angle, that is triangulation. You try to make an angle that is 60 degree at the target organ by placing the ports and camera with respect to each other, so that you make and achieve an angle of 60 degree. So, any questions? You can find this lecture on my YouTube channel also. If you have any query, you can ask. Anybody?
Thank you so much, sir. Now I would like to call upon say Dr. Soumya ma'am to kindly felicitate, sir. Now I would like to call upon stage Dr. Rudramani sir to give his talk on the topic basics of lap suturing.
So, good afternoon, ladies and gentlemen. कितने लोग हैं जो रेजिडेंट्स में, कितने लोग हैं जो लैब सुचरिंग कर रहे हैं? किसी ने भी जो प्रैक्टिस सेशंस कर रहे हैं या जो लोग ऑन पेशेंट्स कर रहे हैं? Anybody among you? So, okay, ठीक है, फिर हम लोग शुरू करते हैं. That's great. हेलो हेलो, पहले वो शुरू करा दो मेरा. कंट्रोल सर आपके पास भी है? नहीं, मुझे इसी से दो. है कहाँ पे ये? इस पे दो. ओपन करो. आप कंट्रोल छोड़ दीजिए प्लीज. क्या वो कॉपी कर रहे हैं भी? So, till it is being copied, the only thing I just wanted to say that this lecture, though it is named to be lecture, this will not be going as conventional lectures. No more theoretical discussions. Deliberately, I have not made down named procedures. We will be discussing only about the principles, because any surgeon in the world who have named any procedure with his name, it has the basic principles which is shared by the other surgeons. So, understanding of the basic principles of any procedure is important rather having a name कि हाँ ये जो है वो रोजेस टेक्निक है या वो जो है कोई और टेक्निक है. तो इस चीज़ की बजाय हम लोग प्रिंसिपल्स पे ज़्यादा बात करेंगे. फाइन, ओके. मेरा सिस्टम उठा दो साद, मेरा सिस्टम उठा दो प्लीज. मेरे लैपटॉप को कनेक्ट कर दीजिए प्लीज सीधे. G. Okay, fine. Thank you. Sorry for the trouble. So we'll be discussing about the basics of laparoscopic suturing and knotting. So already with a wonderful presentation of by Dr. Sonkar, half of my work is done. In a suturing, it is important that you have to take care of the ergonomics. It is important to know the anatomy of the suture, the type of suture, the needle which you are taking, and how we are going to handle the anatomy of the needle. So the anatomy of the needle itself, the methods of needle insertion into the abdominal cavity, the needle handling and holding, that is very important. The needle holder body, the port can be inserted. But gentle pressure over it, when you apply the gentle pressure, then needle sits itself in the jaws. In that further, we will be demonstrating that. You can see. So first, we will be demonstrating the dangling technique. डिस्ट्रैक्ट कर रहा है बार बार, इसको हटा लीजिए. Am I audible? Fine. So you can see that the needle has been inserted inside, and in the air the needle is being manipulated. On the right hand there is the needle holder, and in the left hand there is a fenestrated grasper. With this, you are going to have a pace pace with him in 15 days or 10 days. It is a matter of practice. So one question here: any troubles with this video? Did you find any troubles with this video? Anybody, please? Pardon? We are breaking it down, well handling the tissue. Again we are breaking the down. So what? Needle holding is at the right place. That is the point B. Yes, please. Anybody else? Please say it. Optical access is fine, but nobody gave a hint that the suture was pulled against the tissue. So this is not to be done, because if you are pulling the suture against the tissue, then it is going to cause a trouble. So the right technique to move it is like prick the tissue, hold it nicely from the point C, again hold it from the point B, and this is the pull of the suture in the line. If you are pulling the suture against the line, then you are going to make it a cut through. The knot tying. The knot tying can be by two methods. One is known as needle drop technique, that is C or reverse C loop, and the other one is needle holding techniques. Fine. So we are moving forward. The knot tying. The first we are going to take that needle drop technique. The formation of a loop. If it is a right-handed person, the suture is taken. Fine. On this, because I time. Two.
Thank you, sir. Thank you. Very nice interpretation. Very nicely elaborated once again. So, as Subit sir has identified, highlighted this point of restrictive transfusion strategy. So, this is a defined term. If we follow restrictive transfusion strategy, it has been seen. The studies say that the results are better as compared to the traditional threshold. So, we keep a high threshold. We go for blood transfusion only when the hemoglobin levels are below 7 grams per deciliter, if we follow restrictive transfusion strategies. But this is applicable to young healthy individuals. If we are dealing with an old person, his threshold may not be, his ability to tolerate blood loss may not be that good. So you will have to keep the threshold low. Similarly, in patients who are having comorbidities, here also the threshold will be low. So what should be the ideal ratio of blood products? Dr. Soumya, can you elaborate?
So normally these type of patient who present in acute care surgery setup, so we have to follow the principle of damage control. Actually what has been done by trauma surgeons, similarly in acute care surgery there is protocol of 1:1:1, that is 1 PRBC, 1 FFP and 1 platelet. So advantage of this is that it mimics the whole blood composition, and in that way we will not be overloading the patients, and that will supplement all other components which is required.
I would like to add one thing, that the ratio of blood products is not well accepted. In different books and different articles, they have mentioned different ratios. In the latest, as far as I remember, in the latest edition of Sebastian, it is said that no ratio has been well accepted. Yes, Dr. Weber wants to add something. Mike, please hand over, somebody hand over mic to him.
This is very valid question, and as a trauma surgeon we used to resuscitate all those patients who are rapidly bleeding, and same scenario is applicable for patients who are massively bleeding from lower GI tract. So as far as we know that these patients are not only shedding off RBCs, they are becoming hypocoagulable conditions. So for all these patients we have studies in the name of proper trial and PROMIT studies. So it's been a proven fact that all these patients require 1:1:1 ratio of PRBC, FFP and platelet transfusion. So it's a level 1 evidence.
As
but
per ATLS protocol.
no, it's not there in ATLS, but it's everywhere in trauma surgery literatures. So for rapidly bleeding patients, we have this 1:1:1 protocol, but apart from that, we have further investigations like PT-INR, we can look at the PT-INR values, and apart from PT-INR values, we have TEG, thromboelastogram, which is point of care tests, which are available at our own institutions also. So sometimes we may need these point of care testing facilities so that we can precisely match the requirement of what sort of blood component is needed for all those patients. Like many patients who have already bled like 6 hours back, and those patients may benefit from platelet only or FFP only, and if patient has started bleeding within 3 hours, these patients may require tranexamic acid in addition to blood transfusion.
Thank you, Dr. Weber, for your inputs. Now, coming back to this particular case, so what is the most probable diagnosis? Sumit sir, can you please? We have a patient, elderly patient, who is having significant blood loss. The condition is painless, absolutely. Yes, yes, definitely.
So once you analyze, obviously this bleeding, especially the age of the patient, is very important.
Sir.
And the second is if you can highlight the underlying comorbid condition, patient on anticoagulant treatment or maybe kind of warfarin or antiplatelet treatment. Then third and fourth is any history of previous bleeding. But is this age group of patient, the common cause is rightly mentioned is the diverticular disease, and right side it would be angiodysplasia is most common on right side, and left side would be diverticular disease. Other cause would be if the patient has hypertension on anticoagulant therapy. So sometimes this patient have aortoarteritis and maybe ischemic colitis, and very rarely but not very uncommon is the carcinoma of the descending colon or the rectum. This can also sometimes present to the massive GI bleeding.
Rightly said, sir. So here, this case also was of diverticular bleed. And what are the salient features of diverticular bleed? Dr. Sanjeev, can you elaborate? What are the salient features of diverticular bleed?
Diverticular bleeds are usually sudden onset, usually found in older age group, and it is usually not associated with any kind of pain, or on examination you may or may not found anal outlet disorders. And bleeding on proctoscopy, it might be from the area which we have examined on proctoscopy. Normally उसके ऊपर से आता हुआ fresh blood दिखता है ना. So these are silent features on examination.
Yes, these patients may also present with dizziness and syncope because of the volume of the blood loss.
A huge, definitely a huge volume of blood loss is there. So patient is usually presented as a case of hemorrhagic shock.
Absence of pain is for residents. This is important to note that absence of pain is very, very important. So why does it bleed? Why the diverticulum bleeds? Because there is no inflammation, there is no component of diverticulitis, but it is bleeding. Sumit sir, please. Sir, why diverticulosis patients do bleed?
The blood vessel which is supplying the diverticulum usually ruptures and causes bleeding.
Yes, there is no inflammation. It is just because of a stretching, because as the dome of the diverticulum expands, there is pressure on the wall of the blood vessel, there is stretching, and it becomes liable to rupture. Now, coming to the management of this patient, how we should proceed. If the patient is stable, we have resuscitated him and he has responded well to the resuscitation. He is stabilized. Dr. Soumya, can you tell how we should proceed in this patient?
So if resuscitation has been done and patient has responded well to all the efforts of resuscitation, then our aim should be localization. And for lower GI bleed, colonoscopy is the gold standard, because at the same time it's diagnostic well as therapeutic. So definitely I would like to go for colonoscopy followed by necessary intervention required. And for diverticular bleed, as boss must be doing on routine basis, slipping is most common procedure.
Yes, yes, sir, please.
Multiple options are present for to control the bleeding of diverticulum.
Yes, sir.
Diverticular bleed. We most easy yes the procedure is apply a hemoclip at that side of the bleeding side. Otherwise we can also use banding. जो EVL करते हैं ना जो अपर जे ब्लीड में बैंड लगाते हैं उसको यहाँ पे लगा सकते हैं इजीली. उसको सक करते हैं इस जाके यहाँ म्यूकोसा को सक्शन में अगर प्रॉपरली वो आ गया तो बैंड को डिप्लाई कर दीजिए. तो EVL इज ऑल्सो वन प्रोसेस. अगर इन दोनों से नहीं रुकती तो बड़ी क्लिप आती OTSC क्लिप. OTSC क्लिप में हम उसको सक करके OTSC क्लिप को अप्लाई कर देते हैं तो उससे भी ब्लीडिंग वहाँ की रुक सकती है. अगर इन सब मेजर्स से भी ब्लीडिंग नहीं रुकती तो फिर रेडियोलॉजिकल इंटरवेंशन एंजियो एम्बोलाइजेशन उन सब की ज़रूरत पड़ती है.
I wanted to ask one question, sir. Sir, it has been said that most of these patients, the bleeding stops spontaneously, even without any intervention. So, suppose the patient has been stabilized and you do a colonoscopy to diagnose what was the lesion, and you see that there is a presence of diverticulae, multiple diverticulae, and there are red spots, but there is no active bleeding. Should we offer treatment or should we leave them?
Usually we don't offer treatment in these patients.
Okay.
पहले क्या होता था डायवर्टिकुलोसिस इंडिया की कॉमन डिजीज थी नहीं. हम लोग में डायवर्टिकुला इतना कॉमन नहीं होता था क्योंकि हम लोग का रफेज इंटेक ज़्यादा था. वेस्टर्नाइजेशन की वजह से डायवर्टिकुला काफ़ी मिलने लगे अब पेशेंट में. और जैसे सर बोल रहे हैं रेड स्पॉट मिलना ये यूजली नहीं मिलता पेशेंट में. अब कोई पेशेंट लोअर जीआई ब्लीड का आया और हमने कोलोनोस्कोपी की हमको डायवर्टिकुला दिख रहा है तो हम उसको डायवर्टिकुलर ब्लीड मान करके नहीं छोड़ देंगे कि डायवर्टिकुलर ब्लीड ही है. हम उसको फर्दर भी इन्वेस्टिगेट करेंगे. अगर उसको कोई और कॉज मिलता है तो उसको प्राइमरली कॉज मानेंगे कि ये ब्लीडिंग का है अनटिल अनलेस आपको डायवर्टिकुला से एक्टिव ब्लीडिंग दिखाई दे.
Very importantly, sir has mentioned this, that presence of diverticular doesn't mean that the the culprit is diverticular bleed. There may be patient may be having some other lesion which is actually responsible for bleed. So there are, if we have to offer treatment, there are multiple options, as sir has pointed out. There are clips, and then there are some advanced modalities: argon plasma coagulation, thermal coagulation, epinephrine. It has been said that if you are using epinephrine, whether it is a case of upper GI bleed or lower GI bleed, this applies to both types of bleed. If you are using epinephrine, you should add one more thing, such as hemoclips. So now the next question is, if the patient is unstable, I would like to ask this question to Ashok sir. So if the patient remains unstable even after resuscitation, then what should we do?
Because the patient is unstable, the best would be kind of angiography in this patient. And if we are able to localize his angiography, the preferably would be if the patient can be shifted in operation theater, then CT angiography, which can tell you the where site of bleed, one site of bleed or multiple site of bleed. And obviously the first sign would be extravasation. Second sign would be sometimes nest extravasation, but there is a hyper enhancing wall of the diverticula and very rarely you can also find thickening and the bleeding spot in this place. And the same time it can be embolized. The first line would be, today the initial time it used to be epinephrine injection into the blood vessels, but now most of the interventional radiology prefer, if the site is localized, then go for angioembolization in this patient. And there are various methods and various substances being used of angioembolization.
So sir, is it preferable to go for CT angiography always before going for direct angiography?
The best would be the patient, if patient can be shifted and little bit, if unstable, then you directly go for angiography. So you can immediately take care of therapeutic option also. You need not to wait after CT angiography.
Okay, sir. Thank you. So, very rightly, sir has mentioned about the next best step to manage an unstable patient would be CT angiography followed by angiographic embolization if conditions permit. If the patient is very highly unstable, we don't have time to shift him to OT for angiography, then direct angiography can be attempted. So, I would ask one question to Sumit sir. Please tell the residents about super selective embolization. There is much hype about IR. People say there is a term known as super selective embolization.
This is nothing. Means selective embolization means you are going to the main vessels. Like when you go to the celiac axis, you can go to the superior mesenteric artery, or you can go to the inferior mesenteric artery. So all originates from the aorta. So if you go to the super selective, first you will do angiography from here, then you have to cannulate selectively like branches of the superior mesenteric, like if you are going into the various ileocecal branches or sometimes the ileal branches. Similarly, is superior hemorrhoidal in this area, which demarcate into various sigmoid branches. So super selective means going the right over the branches like sigmoid branches and then embolizing over there. So this has an advantage. It just selectively block the bleeding artery and avoid the major embolization and territory of infarction or necrosis. So that is the very selective cannulation, means going the very, very minor and peripheral blood vessel, not the major blood vessel.
Thank you, sir. Thank you for your information.
All IR person are doing only super selective embolization for GI bleeding.
Oh, okay, sir.
So because there are lots of postgraduate, can you tell what are the various embolization materials are used in this by the interventional radiologist?
Yes, can any one of the students answer this question? Materials used for embolization.
There are several material.
Raise your hands.
At least mention one or two, not necessary to mention all.
So don't look at your phones.
So the commonly used is the gel foam and then also the spring coils and the various others like microspheres, microsphere ball, and the most common even on the the cyanoacrylate, that is the glue, fibrin glue, and also at times is by other substance also. They are very small particles and they can go through the catheter if you do a super selective embolization right over and block only small arteriolar vein and bleeding stops. So these are the various material depending on the preference, availability, and also the site and also the choice of interventional radiology. You can use the substance. And
Thank
the
you.
cost, the most important is the cost.
Thank you, sir. So, sir, ये question आपके लिए है. तो what is the role of surgery in this patient? Which patients will eventually require surgery?
Obviously, there are many two indication if it fails to. Rightly mentioned about 70-80% patient it is stops is spontaneously and any kind of intervention is not required. But 10-50% patient where the bleeding does not stop. But even out of this 10-50%, majority can be controlled either by epinephrine, selective catheterization, or maybe embolization. If not, these are the group patients who continues to bleed and requires even after embolization continues to bleed and require further resuscitation, fall in hemoglobin, that group. And second group would be the patient, if by chance it is not a super selective, it's a major vessel has been embolized, this part of things may go into necrosis behind proximal or distal to the actual diverticulosis, and the patient present is a bleed afterward. These group of patient may need a kind of resection.
So surgery may also be needed if you have got a successful embolization to manage the afterwards complications. So sir has very rightly, very nicely enumerated about the role of surgery in these cases. So in refractory cases, at those cases where the hemorrhage is very, very severe, you don't have time to go for any investigations. You just have any only option to go take the patient straight away to operation theater. So what is the importance of pre-operative localization of bleed? Is it necessary or mandatory to localize the bleed before going for surgery? Anyone from the panelists can take this question.
Ideally, it should be localized whenever and wherever possible, because it will save the patient from unnecessary and morbid surgery. And suppose localization fails and patient needs surgery, patient is unstable, then subtotal colectomy should be preferred. But I would like to have sir to give some inputs.
If she has rightly mentioned, then the best would be to localize, because if you localize, your extent of resection would be limited. The time in resection would be obviously very limited. Less time, less resection, and you can save lots of bowel, especially in the case of small intestine, not in the large. Second is, right, whether we should do a blind subtotal colectomy or it's a segmental colectomy, because it's not localization. So there is underway, especially not in case of this, but the best would be there are various maneuver on table localization. One is that if you open the abdomen, just see on the mesenteric side of the blood vessel. Sometimes you find diverticulosis, a hypervascular structure. If there is a small tumor within the lumen also, you'll find hypervascularity around the mesenteric side. And you can grossly do and localize in maybe 10 to 50%, you can see the site of. Second, you can see the blood called filled small or large bowel, and you can pinpoint by some bowel may collapse, there is no bleeding across that. Third is you can do a clamping and declamping. If your suspicion area found, put a clamp and two area and see milk the rest of area. If it start feeling, then you feel it's bleeding proximal to that, and distal is not. And not the least, intraoperative enteroscopy is another maneuver, whether you can put either into the small intestine or in the colon. The best would be you can do even on tubule colonoscopy. And if diacular disease is highly suspected based on clinical finding or clinical examination or clinical scenario, localized in just by simple on table anesthetic colonoscopy. If not, then the other is you can do an enterotomy, make kind of hole into the terminal ileum, and you can do enteroscopy both on small bowel, also you can go on the colon side, and depending on the site of localization, you can dissect. If nothing, the best would be go for subtotal colectomy. And the second part would be don't make anastomosis because of various reasons. When the patient is hemodynamically stable, it may not heal and it may leak. Third would be the best advantage if you make a ileostomy and the distal limb of rectum or maybe a colon, you can make a mucous fistula. So if the patient even bleed after that, you know which side is bleeding, bleeding from the rectal side or bleeding from the small intestine. And you can scope from outside and further localize.
So very elaborate discussion is going on. So I have nothing to add. Every point has been already discussed. Just to summarize that it preferably we should try to localize. If we are not able to localize the bleed, then the best option will be subtotal colectomy, because if we go for segmental resection, we may not be it is a possibility that we not have dealt with the actual culprit.
So the one is subtotal colectomy. I will tell you, if you do a subtotal colectomy, in up to over 90% time you have taken care of the bleeding point, because majority of time it is the bleeder into the colon. But because the pattern of bleeding especially is totally different in small bowel versus large bowel. So if you do a subtotal colectomy in this scenario, 95% patient will not re-bleed, only 10% may bleed.
So moving on to our second case. So this is a 25 years old lady who presents with episodes of bloody diarrhea, tenesmus and lower abdominal pain for 2 weeks. Yes, definitely, sir. So go through the history. Patient is hemodynamically stable. She is having anemia, and importantly, she is having a history of similar episodes 6 months back. There is also a history of weight loss. What should be your suspicion, students?
What would be differential diagnosis? A young male patient bleeding recurrently for last 6 months with fall in hemoglobin, and you see the bloody diarrhea. What would be the differential diagnosis? It's very written on the face of this history.
Ishali?
Okay, if you cannot, then you tell me what are the causes of bloody diarrhea in 25-year male patient, recurrent for last 6 months. What would be the possibility? One is the, speak loudly, inflammatory bowel disease. What else? IBD has mainly two components, ulcerative colitis and Crohn's disease. What are the similar disease to tuberculosis of India? It's very common. What else? Any kind of polyp in these patients? Do you know the polyp has a similar kind of bleeding pattern? The only odd point is here is the bloody diarrhea. I mean, diarrhea means it's mixed with stool. What else? Short is the infective. Think of infective diseases.
Patient is having abdominal pain. You see, tenesmus and lower abdominal pain.
So no, the patient has tenesmus and lower abdomen. Okay.
Yes, so, as we have already mentioned, we should always consider diagnosis of inflammatory bowel disease in these patients. Inflammatory versus other forms of colitis. So, colitis can be because of various other reasons also. So, how we can differentiate? Dr. Sanjeev, can you tell some clinical points by which we can differentiate inflammatory bowel colitis because of ulcerative colitis or Crohn's disease and infective colitis or ischemic colitis?
You know, in infectious colitis, you might have a short history that is usually presented with along with abdominal pain, cramping abdominal pain, and short history, 5-7 days history that usually is responded to your antibiotics. When you see ischemic colitis, it has recurrent long history. Patient को severe abdominal cramps इसमें भी होते हैं, and along with that, patient may or might not responded to your local antibiotic therapy. IBDs में आपकी frequent history मिलती है, long history रहती है, along with your weight loss of the patient, and bloody diarrhea obviously is there, and other symptoms और भी मिलते हैं. There is no bleeding, mucus discharge persistent मिलता है, and this might be your differentiating features of this IBDs, infectious colitis, and inflammatory bowel disease.
If this case history is given to me, and this is written that patient is having bloody diarrhea along with abdominal pain in young patient, then less chances of ischemic colitis. Ischemic colitis के पेशेंट यूजली ओल्ड पेशेंट होंगे जिनमें कार्डियक डिजीज होगी, जो पेशेंट में लंबी कार्डियक हिस्ट्री रहती, यूजली वही पेशेंट इस्चेमिक कोलाइटिस करके आते हैं, अदरवाइज ऐसे पेशेंट नहीं होते. दूसरा, अगर सर ने 6 मंथ पहले का ब्लडी डायरिया का एपिसोड ना लिखा होता तो 2 वीक की हिस्ट्री में आउटराइटली कहना कि दिस इज अल्सरेटिव कोलाइटिस इवन आफ्टर कोलोनोस्कोपी इज वेरी डिफिकल्ट. This patient is having similar history 6 months back. That goes in favor of IBD because this has relapse and remitting courses. Otherwise, until unless history is more than 4 weeks, it is very difficult to say this is IBD.
Another thing I would like to it is, sir has rightly mentioned that this patient would be older in age. And if older in means underlying medical disease, if you take the history of medicine, it will itself the patient has a kind of ischemic cardiac disease or something, and that can lead to. Now the next question is, what are part of bowel can get ischemic on patient with ischemic disease and bleed? What are the commonly site involved in patient with is okay? What is watershed? Which point? Which part of the bowel? Okay, 1 second. Rectosigmoid junction. Third. What is the difference of pattern and vascularity in left-sided colon versus right-sided colon? It's more common in the left-sided than the right side. Okay.
Also, I would like to add for infective colitis, you may get history of exposure, like some change in dietary habits, or some recent travel, or some one or other kind of some exposure.
Yes, there are many points in history which can help us in arriving at a definitive diagnosis. So there can be history of exposure, age, and mode of onset, whether there is relapse and remission, or whether it is an acute onset. The volume of stools. In infective diarrhea, the volume of stools is usually large and it is foul smelling. Then, if we are suspecting it to be a case of ischemic colitis, certain risk factors become important. If there is history of hypertension, atrial fibrillation, or a recent abdominal vascular surgery, then this patient may be suffering from ischemic colitis. But in this case, these things were not present. So then if we are talking about inflammatory bowel disease, we should also always inquire about extraintestinal manifestations. So I'm not going into details of these because of paucity of time. We have already discussed most of the points which are relevant in history. So what are the investigations? Sumit sir, please can you highlight what are the investigations which can help us to differentiate between the various types of colitis?
First one is the routine investigations like CBC, LFT, protein analysis, CRP, and fecal calprotectin. Next one is the colonoscopy. And
Sir.
other important thing is viral marker. Viral marker should be done in all patients to rule out HIV induced CMV colitis, sometimes mimic the ulcerative colitis also. And colonoscopy with
Sir, before colonoscopy, what is the importance of calprotectin?
usually in ulcerative colitis we don't prefer calprotectin too much because there is blood loss and any inflammatory condition of the bowel. Even in acute infective colitis, calprotectin will be high. So it is not able to differentiate between ulcerative colitis and infective colitis. Level more than 200 is very much suggestive of inflammatory bowel disease, but it cannot definitely differentiate between the two. In the
So it can help, but it is not very specific. Yes.
Dr. Sumit has very rightly mentioned the role of fecal calprotectin is mainly when there is a dilemma, whether there is a kind of bowel inflammation vis-a-vis non-specific, vis-a-vis a malignant pathology in clinically not clear patient. So here is not going to helpful. The diagnosis is almost certain here clinically. We have to confirm with colonoscopic finding to one the confirmation sent to know the extent of the disease, and third is whether the rectum is spared or involved. That's all.
So further evaluation means we have to go for endoscopy. Then this question again is addressed and directed to Sumit sir. Should bowel preparation be avoided?
then colonoscopy should be done on unprepared bowel, and you should not try to see the extent of disease, because if you are using more air and more try to push the colonoscope, it may lead to development of toxic megacolon in these patients. So start, if the patient is having acute severe ulcerative colitis, take the patient unprepared and take the biopsy after seeing the rectum and sigmoid.
So point.
सिग्माइडोस्कोप तो अब आते नहीं, अब तो कोलोनोस्कोप से ही सब करते हैं, उसको कहते हैं कोलोनोस्कोपी या एक शॉर्ट कोलोनोस्कोपी। पहले सिग्माइडोस्कोप आते थे पुराने टाइम, तो अवेलेबल नहीं होते। दूसरी बात, मतलब जैसे अल्सरेटिव कोलाइटिस के 3 टाइप के प्रेजेंटेशन होंगे, मॉडरेट सीवियर। तो हमारे पास जो हॉस्पिटल में एडमिशन होता है वो यूजली एक्यूट सीवियर अल्सरेटिव कोलाइटिस में होता है, तो उनमें प्रिपेयर कराने की जरूरत नहीं है। डायरेक्टली पेशेंट को अनप्रिपेयर्ड कोलन में उसको चेक करना चाहिए कि उसको रेक्टम में सिग्मॉइड का इन्वॉल्वमेंट है कि नहीं। अगर वहाँ तक दिखता है तो आप आराम से वहाँ से बायोप्सी ले करके और आप पेशेंट को छोड़ दें, उसको पुश करने की कोशिश कर रहे हैं कि हम एक्सटेंट देख लें कि E2 डिजीज है कि E3 डिजीज है, इस तरह के लिए ट्राई नहीं करते।
You have rightly mentioned here the objective is not to see the extent of disease, objective is just to make a diagnosis. Now, one question to you, whether the phosphate enema or proctopolis enema should be given instant just to clean the rectum and sigmoid?
PC enema
Can be given. Okay. That's bowel preparation is not required, but PC enema can be given.
So point to be noted that we can avoid bowel preparation in acute patients. Uh, Endoscopy can help us in establishing the diagnosis. It can also help us in differentiating between ulcerative colitis and Crohn's disease. This is a large topic. I will not go into details of how to differentiate between ulcerative colitis and Crohn's disease based on endoscopic findings. So just give me 15 minutes because it's very interesting session. I think all of the experts as well as the students are very actively involved. So just give me 10 minutes actually. So quickly moving on to biopsy findings. So there are few features which are characteristic of Crohn's disease and few of this ulcerative colitis. So this is an endoscopic view of ulcerative colitis. I will not run the video because of paucity of time, and this is the biopsy histopathological picture. This is architecture distortion. This is more specific for ulcerative colitis, and this is non-caseating granuloma, which is more specific for Crohn's disease. Oh, thank you, sir. So I will just. So mainly the management of ulcerative colitis is medical only. I will not go into details because there is a pressure to conclude. But I would just like to ask sir, what is the role of surgery when surgery comes into play in these cases?
So surgery is the obviously the patient which have the terminology is known as chronic ulcerative colitis, means the group of patient where the first line of management, that is the medical management, has completely failed. Second, some of the patient have started and require steroid for repeated maintenance, and patient started developing side effect of steroid. Fourth, if in emergency situation, you can go for the patient as toxic megacolon not responding to immunosuppression or azathioprine, cyclosporine, and or the patient who has developed perforation. So these are the emergency indication, and the elective would be patient not responding to medical management and going require multiple operation. Sometimes the patient has no finances for continuous treatment rather than one-time surgery, and very rarely the patient develop either dysplasia, start developing severe dysplasia, or maybe sometimes the patient develop carcinoma in situ or early carcinoma. So these are the indication for surgery.
So sir has very rightly pointed out the indications of surgery. It is important to note that bleeding itself is not a common indication for surgery in ulcerative colitis. There are other important indications. Those are more common indications of surgery in ulcerative colitis, and we will not go take our third case because of paucity of time. Just I am moving on to take home message. Just I wanted the students to go through this flow chart, which is for third case was related to obscure GI bleed. So just for the sake of definition, knowing the definitions, Dr. Soumya, can you tell what is obscure GI bleed and what is occult bleed? Obscure bleed means that we have, sir, yes, sir.
So the obscure means obviously the patient is bleeding, you know. The only we are failed to localize this site by routine investigations like upper GI and colonoscopy. The occult is the patient never shows frank bleeding. This patient usually represent you fall in hemoglobin, and if
Represent
you
as
do
anemia, sir.
anemia,
Yeah.
and anemia means not only anemia. This
Yeah.
patient common presentation they come with dyspnea,
Yeah.
and walking. Sometimes they have complaint of breathlessness. Sometimes when they stand up, they say कि अब तो मैं घर में खड़े नहीं हो पाते हैं, गिर जाते हैं. This all because of hypoxemia, secondary to chronic blood loss. And if you do occult blood in this patient, at least 3, then 2 would be definitely positive.
Yeah. Thank you, sir. So very rightly, sir has mentioned about what is obscure bleeding actually. So, so this if you come across a case of obscure GI bleeding and you subject the patient to upper and lower GI endoscopy, you do not get anything. So, what is the next step? So, next step as per this flowchart says is to do a repeat. If the patient is stable, do a repeat upper GI and lower GI endoscopy. That will be the first step. And if there are facilities and expertise, you can go for push enteroscopy. The next if still you are not able to diagnose, the next investigation of choice would be capsule endoscopy. I would just like Sumit sir to tell in brief, very brief about capsule endoscopy.
As I've rightly said, the patient hit with obscure GI bleed or occult GI bleed, the investigation of choice after endoscopy, colonoscopy, and push enteroscopy is if patient is a overt GI bleed, then patient is bleeding, then we can do either double balloon, single balloon, enteroscopy. Enteroscopes are available. But if a patient is not bleeding actively but occult blood is positive, then a capsule is available. This is shown in capsule. पेशेंट आता है, उसकी एक कैप्सूल एंडोस्कोपी की मशीन आती है, उसको पेशेंट को पूरा टाई कर देते हैं और पेशेंट को पहले पेगलेट पिला देते हैं जिससे बहुत क्लियर हो जाए पेशेंट की रात को, और मॉर्निंग में उसको 9 बजे 9:30 बजे के आसपास कैप्सूल खाने के लिए कह देते हैं. उसमें जो मशीन बांधते हैं उसमें कैमरा लगा रहता है. जैसे जैसे कैप्सूल जीआई ट्रैक्ट में पास करता है वैसे वैसे खिंचता जाता है और वो कोलन से शाम तक वो पास कर जाता है, नेक्स्ट डे पास कर जाता है. लेकिन शाम तक कैप्सूल जो उसका कैमरा होता है पिक्चर देना बंद कर देता है. तो नियरली अबाउट काफ़ी सारी फोटोज आती हैं जिसको हम नेक्स्ट डे अपने कंप्यूटर पे लगा के इंटरप्रेट करते हैं कि क्या है. तो इस तरह से कैप्सूल
I can give you a theory in short. You can write a short note on this. This capsule endoscopy, if you see rightly, is mentioned. The size is 11 into 26 millimeter in size, small capsule, and it has 4 component especially 4 diode. Diode is a source of light, and then is a small camera chip and radio frequency transmitter, and obviously he has mentioned a sensor and monitor on top of it. And the battery, there are 2 batteries. Battery life is only 8 hours, so it only take the picture for 8 hours, and wherever it travel in the bowels, and it is recorded, and finally the physician look into and it can crudely tell you where the possible site of bleed, but not exactly whether a small bowel, large bowel, you can say right or left colon, but you cannot pinpoint a specific site of bleeding. And capsule is passed in obviously through the stool, and contraindication is the patient is diarrhea. If you swallow, it may pass into the stool. And the second is the obstruction. If the multiple stricture in a small bowel, you should never do a capsule endoscopy. But it is one of the best investigation for obscure and occult bleed. If the size of body is suspected in small intestine, this is the best investigation after enteroscopy. If the bleeding is suspected in small intestine, as you mentioned, they start with the mid-gut bleed. So it is the investigation of choice. I don't know about the cost these days. Initially it came in 35,000, maybe 15-20,000.
नहीं नहीं सर, अभी भी 35 to 40 के बीच में था.
And this sensitivity is not very high, just around 50%
50 to 60% मैक्सिमम. यूजुअली जो मिलता है वो या तो NSAID इंड्यूस्ड अल्सर्स मिलते हैं, वर्म मिलता है सेकंड, थर्ड टीलेंजेक्टेसिया मिलता है, चौथा क्रॉन्स डिजीज, फिफ्थ ट्यूबरकुलोसिस. ये 5 डायग्नोसिस यूजुअली मिलते हैं.
जिस्ट भी मिल जाता है.
जिस्ट भी सब रेयरली सर.
Okay, sir. Thank you, sir. So we will now conclude with take-home messages. So there are many take-home messages here. Resuscitation precedes diagnosis is of paramount importance. If we are coming across a case of painless massive lower GI bleed in an elderly patient, so diverticular bleed is the most common cause, so that should be always in our mind. If there is history of pain before bleeding, we should think of inflammatory or ischemic colitis. And if the patient is stable, we can go for colonoscopy because it is diagnostic as well as therapeutic. And if the patient is unstable, we can go for CT angiographic followed by angiographic embolization. If the patient is on anticoagulants, they are rarely the sole cause. You need to identify the cause. You need not to hurry up to stop the anticoagulants as already discussed here. If the endoscopic findings are negative, it does not exclude GI bleeding source. It means that we may be dealing with an obscure GI bleeding. And lastly, surgery still can be the only or the best life-saving option in selected cases where we are not able to manage by any other means. So that's all. Thank you very much, Ashok sir, Sumit sir, for your valuable guidance. Dr. Sanjeev, uh, uh, he agreed to appear on the panel for a very short notice, and Dr. Soumya, already, as always, is very helpful. So thank you to all the panelists. Thank you very much.
Thank you, sir. Now I would like to call Professor Ashok Kumar sir to kindly felicitate Dr. Rohit Srivastava sir. Sir, जी सर. Sir. Thank you, sir.
So we end this 4-day academic program now. But it's not the end. For those who are interested to do the workshop, ergonomics and laparoscopic suturing, can go to the workshop. The facilitators are waiting for you there. And those who don't want to, they can go get back to their work. And see you all tomorrow sharp at 9 in the convention center. And the dress code for ladies is pink sari and a black coat, and for the boys is and for the boys is black coat, black trousers, white shirt, and some tie. Tie का color हमने fix नहीं किया है, so fine. And for the outsiders, you are all really welcome for the foundation day, followed by lunch tomorrow, and then we have a dinner also in the evening at the convention center only. So all of you are welcome to attend. It will be nice to have you all. It starts at 9. So you can reach by 9:30 something. Okay.
Morning 9:30.
Thank you. जिन जिनको वर्कशॉप करना है प्लीज चले जाइए वर्कशॉप की तरफ. Certificates will let you know. It's all ready. We'll give you.